Sir, we are live.
जांच करना है, हमें भेजना मत रामदास 5 मिनट। जी शुगर इनको तकलीफ क्या हो रहा है?
RX events, can we start?
Yeah.
Yes, sir.
Okay.
So this is Dr. Prabhat Pandey. I welcome you for this session. And to begin the session, there's a very stalwart in the field of endocrinology and diabetes, Dr. A.G. Unni Krishnan. And I have been listening him since last many years, and I'm a really big fan of him. And he'll be discussing on the topic relationship of thyroid and diabetes. So I invite Dr. Unni Krishnan, before describing his a long CV, which most of us know. But with all best wishes, I invite you, Dr. Unni Krishnan, for your talk, please.
Thank you, sir. It's a pleasure and honor to be here. And let me just start sharing my screen. RX events, you will have to allow me to share the screen. Yeah. So I hope my screen is visible and I'm audible.
Yes, sir.
Yes. Go ahead, Dr. Unni.
Yes. So I'm going to talk about hypothyroidism and diabetes, especially thyroid disease and diabetes. What are the connections? So let me begin by showing you this paper we published many years back in 2013, which looked at how common is hypothyroidism and other thyroid disorders. You can see that the prevalence of undetected overt hypothyroidism is about 3.47%. The prevalence of subclinical hypothyroidism is 8%. Hyperthyroidism is 0.67%. But if you see, the prevalence of diabetes is 16.6%. And this is a study done in 8 cities of India. And why I'm showing you is because this data shows the thyroid disorders carried out in the same population. So thyroid function tests and diabetes diagnosis was carried out in the same population. So hypothyroidism shares many commonalities with the metabolic syndrome and type 2 diabetes. You have obesity, dyslipidemia, insulin resistance, hypertension, NAFLD, and severe risk in hypothyroidism. All these features are also seen in type 2 diabetes and the metabolic syndrome. So there is an overlap of the symptoms. This is a busy slide, but I just want you to focus on the lower end of these slides, because this picture shows you what thyroid dysfunction does to blood glucose levels. Hyperthyroidism results in apoptosis of insulin-producing cells of the pancreas. This results in hyperglycemia. The insulin clearance is increased, and that therefore there is a lack of insulin, and there is hyperglycemia, and maybe even diabetic ketoacidosis can occur. Very simply put, the insulin or diabetes medication requirement can increase in diabetes patients if they have hyperthyroidism. If you look at hypothyroidism, there is a reduced insulin clearance, which means insulin levels go up, which means exogenous insulin requirement can go down in diabetes patients. And there is a risk of hypoglycemia in diabetes people who have hypothyroidism. So you need to decrease the insulin dose in diabetes people when you have hypothyroidism. But once you replace with thyroxine, you will have to increase the insulin dose. So just to tell you, to summarize, hyperthyroidism has a tendency to hyperglycemia and hypothyroidism has a tendency to hypoglycemia. So many people have suggested that type 2 diabetes is associated with an increased risk of thyroid nodules. But is there an increased risk of thyroid cancer? So this paper was done on almost 147,934 women. They were free of cancer at baseline and were followed up prospectively. The follow-up period was 15.9 years, and they found 391 incident thyroid cancers. But the authors found no significant association between thyroid cancer and diabetes, and there was no significant association between thyroid cancer and diabetes treatment or with the duration of diabetes. So there is no evidence to say that thyroid cancer is associated with diabetes. Now, in a person with diabetes, how often should thyroid function test be done? So this depends on the type of diabetes. In type 1 diabetes, TSH and anti-TPO antibodies should be done at baseline and annually. If a type 1 diabetes has got a goiter or if GAD65 antibody is positive, if there are growth issues, pubertal issues, fluctuating sugars, then you may need to do the thyroid functions more frequently. About 25 to 30% of type 1 diabetes subjects have autoimmune thyroid disease, and that is the reason you have to be more careful and do frequent thyroid function tests. In type 2 diabetes, thyroid function tests should be done at baseline. Routine repeated testing is not needed in type 2 diabetes, and there's no need for routine calcitonin tests in patients with type 2 diabetes who are on GLP-1 receptor agonist. So let's look at a case. A 54-year-old lady with a TSH of 14. She has a normal T4 and T3, BMI is 31. She is asymptomatic, HbA1c is 6.4% on metformin and sulfonylurea. There is dyslipidemia. So certainly such a patient would be an ideal patient for treatment with levothyroxine because this is subclinical hypothyroidism and the TPO is also should be done in this patient, but nevertheless, because of dyslipidemia, treatment with thyroxine is ideal in this subclinical hypothyroid patients. In fact, it's important to treat with thyroxine and then only give statin because giving statin first may increase the risk of muscular pains, etc. So we've already looked at simple problems like hypothyroidism and diabetes. Now let me look at some new ideas. There is some exciting basic science data on MODY genes and thyroid cancer, type 1 diabetes masking the diagnosis of thyroid disease, and insulin sensitizers. So let me talk about MODY, maturity onset diabetes of the young or monogenic diabetes. Now, there are many types of monogenic diabetes, but if you look at these two mutations in the hepatocyte nuclear factor 1 alpha and hepatocyte nuclear factor 1 beta, they are responsible for MODY type 3 and MODY type 5 respectively. If you look at HNF factor 1 beta, HNF factor 1 beta is a cause of MODY type 5, but it is also expressed in papillary cancer cell lines of certain types. And HNF1 alpha, which is responsible for MODY type 3, is the HNF1 alpha mRNA and protein have both been detected in anaplastic thyroid cancer cell lines. Now, there is no need to worry or panic about this because this is a very preliminary finding and is in the basic science domain. This just says that we should do more research on HNF1 alpha and HNF1 beta in the thyroid cancer cell line so that you can individualize molecular and targeted therapy for thyroid cancer. These are new ideas and they do not have any clinical relevance at present, but something exciting which researchers in the lab are working on, I thought I will share with you. So after this, I'm going to talk about type 1 diabetes masking the diagnosis of thyroid disease. So friends, let me show you a case. This is a 13-year-old lady with newly diagnosed type 1 diabetes. In this young girl, the HbA1c is 13.5, the random blood glucose is 456, the GAD antibody is positive. Note that the anti-TPO antibody is also positive. The TSH is low at 0.54 and free T4 is 0.78. I want you to note that this girl with type 1 diabetes, autoimmune type 1 diabetes, because GAD antibody is positive, has got autoimmune thyroid disease because TPO is positive. But because of the new onset hyperglycemia, this hyperglycemia can suppress the TSH and mask the diagnosis of type 1 diabetes. So in addition to type 1 diabetes, people having autoimmune thyroid disease and hypothyroidism, as I discussed, sometimes the diagnosis of type 1 diabetes may be masked. The diagnosis of hypothyroidism may be masked by type 1 diabetes. Why? Because in type 1 diabetes, there is hyperglycemia, weight loss, osmotic diuresis, and in hypothyroidism, there is weight gain. And this weight gain of hypothyroidism may be masked by the weight loss of recent onset type 1 diabetes. Second thing is, in hyperglycemia, severe hyperglycemia, there may be a defect in the T4 to T3 conversion. So you may have a low T3 and a not so low T4. The third is, in type 1 diabetes, some authors have postulated that there is an unknown thyroid hormone binding inhibitor which may inhibit the deiodinase that converts T4 to T3. Finally, as I said, very severe hyperglycemia can suppress the hypothalamus, suppressing TRH, suppress the TSH, and also suppress the thyroid hormone. So all can be low, as in this case. So coming back to this patient, of course, you will be managing the type 1 diabetes with insulin, but you should repeat the thyroid function test after giving insulin and normalizing the sugar to see if there is a latent unmasking of hypothyroidism, which is very important in young children, because if you don't correct hypothyroidism, it may have an impact on puberty, academic performance, height, etc. So this is the DCCT study. As you know, the DCCT study is the largest study on type 1 diabetes, showed that controlling glucose intensively with insulin reduced neuropathy, nephropathy, and retinopathy. But in this cohort of the DCCT, they took two groups, one with positive anti-TPO, other with negative anti-TPO. The x-axis shows the duration of diabetes. The y-axis shows the percentage of people who did not have hypothyroidism. So you can see that people with a negative TPO, a higher proportion did not have hypothyroidism, and patient with positive TPO, a lower proportion did not have hypothyroidism, which means that a higher proportion had hypothyroidism. So if you look at the normal adult population, the TPO antibodies double the risk of progression to hypothyroidism. But if you look at this DCCT cohort of type 1 diabetes, DCCT subjects who are TPO positive had a 17.9 times. So in the normal population, there is a twofold increase with anti-TPO, but in the type 1 diabetes population, there is a 17-fold increase in hypothyroidism with anti-TPO compared to anti-TPO negative people. And you can see that this was statistically significant and hypothyroidism was more common in women. So just to show you that in type 1 diabetes, TPO is a very strong predictor of hypothyroidism. This is a small paper I published in 2006, which looked at TSH receptor antibodies in type 1 diabetes. And we found that some proportion, 18% of this very small study, had TSH receptor antibody positivity. Remember, TSH receptor antibody positivity does not mean hyperthyroidism. It can, if it's a blocking antibody, it means hypothyroidism. It's a stimulating antibody, it means hyperthyroidism. So it could predict both. And we saw that these antibodies did not overlap. They identified TPO and TRAB, identified distinct subsets of patients. Of course, this is a study which requires more research and a very small sample size. So not very important, but I thought I will discuss it. Finally, I come to my third topic, which is insulin sensitizers and hypothyroidism and thyroid. So this is a very important study, a retrospective study done in euthyroid diabetes patients. They were divided into two groups. 119 subjects who were never treated with metformin and levothyroxine, and the TSH was done. You can see the baseline and end of TSH was same. 203 subjects who were only given metformin at recruitment, and you can see that metformin reduced the TSH in these euthyroid subjects. This here, metformin reduced the TSH in that subject, and 71 subjects who were already taking thyroxine and were euthyroid, and metformin was added on. So in this group, on your extreme right, there was no metformin. In this group, there was metformin, and here there was metformin in a background of thyroxine. All were euthyroid. What you can see is that in this group, addition of metformin suppressed the TSH in these hypothyroid subjects taking levothyroxine. And this was statistically significant. So metformin has a tendency to suppress the TSH. So again, these authors did further analysis. They took the subjects and did a multiple regression analysis for TSH levels at 1 year of follow-up as a dependent variable, and they found that metformin was, again, in this multiple regression analysis, metformin significantly lowered TSH, and the authors said that metformin can reversibly suppress TSH, which means if you remove the metformin, TSH can go up. Metformin also reduces the TSH if the TSH levels are initially high, about 2.5 in hypothyroid people with diabetes. Now, why does metformin suppress the TSH? We really don't know, but there are some theories. Earlier, it was believed that metformin decreases the absorption of thyroxine. Now, people don't believe that theory. People believe that metformin acts on the brain, suppresses the hypothalamic TSH releasing hormone, that suppresses the pituitary TSH, and the suppression of pituitary TSH is because of a central action of metformin. There are some other studies that suggest that metformin increases the action of TSH via the IRS1 pathway. So metformin via the IRS1 pathway, because of the insulin sensitizing pathway, makes the TSH work better. So the body has to make less TSH. So these are some of the theories, but in practice, always remember that metformin can suppress the TSH a little bit, may not be clinically significant, but an important point to remember. Now, this is another study which described pioglitazone addition to patients with thyroid-associated orbitopathy. We know that Graves' hyperthyroidism affects the eye, and in this study, when type 2 diabetes subjects were given pioglitazone with Graves' disease, there was an exacerbation of thyroid-associated orbitopathy or Graves' orbitopathy. But when they withdrew the pioglitazone, the Graves' orbitopathy did not remit. Why does this happen? This happens because the expression of PPAR gamma is very high in the adipose tissue and connective tissue of the orbit. So therefore, if you give pioglitazone, that activates the PPAR gamma. That activation can stimulate functional TSH expression, and the TSH receptor antibody binds to the functional TSH receptor which is expressed in the orbit. So very simply put, the thyroid orbitopathy overexpresses PPAR gamma. Pioglitazone stimulates PPAR gamma. Stimulation of PPAR gamma worsens orbitopathy by expressing the TSH receptor. So that's a vicious cycle. And pioglitazone also induces a recruitment and differentiation of orbital fibroblasts into lipid-laden adipocytes. So when the fibroblasts in the eye convert into lipid-laden adipocytes, which are inflammatory and stimulate further adipogenesis, this may worsen the pathogenesis of thyroid-associated orbitopathy. So avoid pioglitazone in thyroid-associated orbitopathy. This is a case study. You can see this patient who So see the photograph before pioglitazone or thiazolidine was added. After thiazolidine was added, you can see that the TZD caused lid retraction, proptosis, and worsening of orbitopathy. And you can see the enlargement of the inferior rectus muscle demonstrating that. So important to avoid pioglitazone in Graves' disease, even if they have no orbitopathy, because orbitopathy, if there is mild, it can be worsened. And of course, avoid pioglitazone in thyroid associated orbitopathy. Well, I've discussed some of the important clinical points of thyroid disease and diabetes, the connections. I've talked about the importance of diagnosing and treating hypothyroidism in people with diabetes, and that treatment is very important. I also talked about certain newer aspects such as insulin sensitizers and thyroid disease, metformin and thyroid disease, TZDs and thyroid disease, how type 1 diabetes may mask hypothyroidism, and the importance of diagnosing and treating hypothyroidism and other thyroid diseases in diabetes. Friends, it has been a pleasure discussing this topic with you, and thank you for listening to me.
Thank you. Thank you very much, Dr. Unni, for your nice and lucid presentation as always. And we had decided that the discussions will be held in the last out after all the three speakers have spoken. So now I invite, can I invite the second speaker?
Which is affiliated with RSSD.
I think the second speaker is there. Sarab, you can call him. Dr. Supratik is there.
All right, Dr. Bhattacharya, please. Dr. Supratik Bhattacharya to speak on his topic.
Thank you. Yes.
That is the residual risk ODC from LDL to lipoprotein A. Dr. Bhattacharya, please.
Thank you so much, chairpersons, for your kind words of introduction. Thank you, Dr. Bansi Sabru and team RSSDI for this kind invitation to talk on this topic today. So I'll just take a moment to share my screen, if that's okay. So somebody needs to take down.
Yeah. Please go ahead, sir.
Thank you. Please give me a shout out if it's visible to you at the moment. Are the slides visible?
Yes, sir.
So this is the topic, residual risk odyssey from LDL to lipoprotein A. And this was actually published in 2021 as an editorial comment in the Journal of American College of Cardiology by Robert Rosenson. And I'll come to the significance of this particular topic in a while. But just to set the context, we know that atherosclerotic cardiovascular disease is the leading cause of death. And despite significant advances in the treatment of atherosclerotic cardiovascular disease, we know that it remains the leading cause of death and disability worldwide. And the traditional risk factors for ACVD would include hypertension, diabetes, elevated LDL cholesterol levels, along with smoking, obesity, and family history of atherosclerotic cardiovascular disease. We also know, since the advent of statins and the discovery of statins, it has remained the cornerstone and one of the pillars of treating atherosclerotic cardiovascular disease. Because of the cost effectiveness, it has become absolutely indispensable. And management of risk factors is absolutely crucial in the treatment of ACVD. And among the risk factors, elevated LDL cholesterol seems to be one of the principal drivers of atherosclerosis, and there is a linear correlationship as well. So LDL-centric approach, namely the statins that we know about, has served as the foundation for primary as well as secondary prevention for decades and led to significant improvements in the cardiovascular outcomes. Now, the point remains, is that good enough just to target the LDL cholesterol? Now, we know that it's easier because LDL cholesterol is something that we can do in every single lab. And there is a positive correlation between the elevated LDL cholesterol levels as well as future cardiovascular events and atherosclerotic cardiovascular disease risk. Now, if we are addressing and hitting the LDL cholesterol hard and bringing down even below 70, we do see that there is a residual risk that remains, and that is going to be the topic of discussion for today. Now, when the LDL cholesterol remains more than 70, even despite using maximum tolerated statin dose, there are indications to use a non-statin agent, and that can be of various mechanisms. So one of the things that are considered based on the cost per se would be something like ezetimibe, and it's a Niemann-Pick C1-like transporter inhibitor, and it blocks the absorption of the dietary and the biliary cholesterol and the plant sterols. Or we could think of something like a human monoclonal antibody inhibitor. And the commonly used one is, of course, the one that you see on the screen. So proprotein convertase subtilisin kexin type 9 inhibitors, or commonly known as the PCSK9 inhibitors. And the prototypes are alirocumab and evolocumab. Now, these are the second-line cholesterol-lowering treatment, which help achieve LDL cholesterol targets, which was not achievable by the statins alone. And these are the ones which work by enhanced LDL receptor-mediated clearance of the LDL and other atherogenic lipoproteins. Now, what do we mean by the residual cardiovascular risk? So certain trials demonstrated that despite the significant reduction in the LDL cholesterol, as we were saying, even up to say 30 to 40 mg per deciliter, with even PCSK9 inhibitor-like agents, which has got the capacity to robustly decrease the LDL cholesterol levels, we do see that there is a risk reduction, which was modest with slight high event rates. And this could be because of the residual cardiovascular risk, and there could be multiple drivers of this residual risk, which might not be directly addressed through the current treatment strategies using statins. So residual cardiovascular risks could be because of the residual inflammatory risk that remains, or the residual metabolic risk, or even the residual thrombotic risk, which are related to something called the lipoprotein small a. And the related gene to lipoprotein small a is the LPA gene, and it comes in about 40 isoforms, beg your pardon, and so you see a lot of heterogeneity when it comes to this particular molecule. So lipoprotein small a is an LDL-like particle containing apolipoprotein A linked to apolipoprotein B, as you see in this structure. And several studies have now evidenced an excess of LP small a, an independent risk factor for ACVD events. So over on top of addressing the LDL, probably there is a need to address this LPA as well, because we know that LP small a might promote atherosclerosis and thrombosis and also increase the coronary risk. What are the mechanisms? So it can drive atherogenesis through a myriad of mechanisms. And one of the things that are proposed is probably the suggestion that LP small a is the primary lipoprotein carrier of oxidized phospholipids. And these oxidized phospholipids are a danger-associated molecular pattern, which is recognized by receptors on the innate immune cells, which triggers inflammation, which triggers thrombosis, and also plaque destabilization. And surprisingly, large impact of the LPA compared with LDL-C on the ACVD risk suggests that it possesses other pathogenic properties as well. This diagram elaborates what we were trying to say in here. And as you can see in here, lipoprotein A can drive immune cell activation, increasing the reactive oxygen species. It can drive inflammation. It can drive endothelial cell activation, increase the prothrombotic agents, increase immune cell recruitment. It can also act by driving platelet activation, increasing aggregation degranulation, and thus drive atherogenesis, and finally, plaque destabilization. What about the LP and cardiovascular risk? We know that LP small a is highly prevalent cardiovascular risk factor with levels more than 30 milligrams per deciliter, affecting 20 to 30% of the global population. And three major levels of evidence support the notion that elevated LPA are a causal independent genetic risk factor for cardiovascular disease. And this comes from epidemiologic studies and meta-analysis. It comes from genome-wide association studies and also Mendelian randomization studies. LPA and cardiovascular risk. So this comes from meta-analysis of almost 29,000 statin-treated patients with high baseline ASCVD risk. And what we have seen is that as compared to those who have a baseline LPA mass of less than 15, compared to those who had LPA more than 50, they were associated with at least 42% higher risk of future cardiovascular events. Similarly, the Inter-Heart study showed that anyone with the LPA level of more than 50 milligrams per deciliter was also having a 48% increased risk of having a future myocardial infarction event. A sub-analysis of the Jupiter trial demonstrated that LPA was a strong predictor, which was associated with 27% residual risk, independent of the LDL cholesterol and other risk factors. This FOURIER trial, which means further cardiovascular outcome research with PCSK9 inhibition in subjects with elevated risk. Again, 25,000 odd patients with established atherosclerotic cardiovascular disease were looked into, and patients with baseline LPA concentration, which was in the highest quartile of more than 165 nanomoles per liter, versus those who had LPA levels very less than 13 nanomoles per liter. There was a 22% higher risk of coronary of a cardiovascular related death, MI, or urgent coronary revascularization. FOURIER trial also showed that patients who were treated with evolocumab versus placebo for 48 weeks, evolocumab not only decreased the LPA concentrations by 27%, but it also reduced the risk of major coronary events by almost 23%. It also showed that there was a stepwise decrease in the risk of major coronary events for patients who achieved either a LPA or a LDL cholesterol value below achieved median, and the lowest event rate was observed for those individuals who achieved lower levels of both LPA as well as LDL cholesterol. So anyone, and we are trying to drive the LPA, and the median drive was to around 12 milligrams per deciliter for LPA, and LDL cholesterol median was around 65. So somebody who was achieving both low levels of LPA as well as LDL cholesterol, they had the maximum risk reduction. And as you can see in here, lowest event rates was seen, 28% lower risk of major coronary events with both. So ODYSSEY outcomes, evaluation of cardiovascular outcomes after an acute coronary syndrome during treatment with alirocumab. Again, 19,000 odd patients with recent ACS on high intensity statin therapy was looked into, and alirocumab reduced LPA by 23%, LDL cholesterol by 51 milligrams per deciliter, and risk of MACE was reduced by 15% versus the placebo. So there was a linear relationship between the LPA and the cardiovascular risk, and in the placebo group, participants in the highest compared to the lowest baseline quartile of the LPA show that there was 46% more likely to experience MACE in the high quartile as compared to the low quartile. Similarly, there was a 54% higher chances of experiencing non-fatal MI or cardiovascular related death in the high quartile versus the low quartile. The results indicated a linear relationship between a baseline LPA level as well as the risk of 3-point MACE. ODYSSEY outcome trials showed that the higher levels of LPA more than 13.7 milligrams per deciliter was also associated with the higher cardiovascular event rate, regardless of the LDL cholesterol level. So whether the LDL cholesterol was driven below 70 or even stayed over 70 didn't matter. As long as they had a higher LPA level, it was independently associated with a higher risk of cardiovascular event. So additionally, PCSK9 inhibitors like alirocumab decrease the cardiovascular events, the subgroup of patients with LDL cholesterol below 70 even, and those with LPA of more than 13.7. So alirocumab induced reductions in the LPA and corrected LDL cholesterol content of the LPA, independently predicted the lower risk of total cardiovascular events. And what we did see was each 5 milligrams per deciliter reduction in the LPA predicted a 22.5% reduction, relative risk reduction in the cardiovascular events. And the results of the Odyssey outcome trial suggest that LPA should be an independent treatment target after ACS. Let's look at what the guidelines say. The AHA-ACC 2018 guidelines recommend that anyone with family history of premature atherosclerotic cardiovascular disease should be screened, or personal history of ASCVD not explained by major risk factors, and anyone who is an adult aged between 40 and 75 years of age without diabetes and intermediate risk for ASCVD, you need to target the LPA to 50 milligrams per deciliter or less. Similarly, EAC or EAS 2019 says that LPA measurements considered at least once in each adult's lifetime to identify those with very high LPA levels more than 180 with lifetime risk of ASCVD, and should be considered for selected patients with a family history of premature cardiovascular death, and for reclassification who are borderline between moderate and high risk. So initiate moderate to high intensity statin in adults aged 40 to 75 years with a 10-year ASCVD risk of 7.5% to less than 20%, and target LPA and anyone with a baseline LPA of more than 100. Similarly, high-risk patients with the LDL cholesterol more than 70 and LPA of more than 100 on maximally tolerated statin should be considered for more intensive therapies like ezetimibe and PCSK9 inhibitors. And now we are having ongoing trials with the novel agents which target the LPA, and they're in the phase 3. And one of such molecule is TQJ230. There's some interesting research that is coming up, and it's based on the antisense, of course. Another thing that I wanted to highlight was, the level of OXPL that we were talking about earlier, apolipoprotein B containing lipoproteins, primarily the LPA, was found to be highly predictive for future atherosclerotic cardiovascular disease. So accelerate study is something that showed that anyone with higher hsCRP levels and high levels of LPA would have higher chances of a future cardiovascular event. So there's a lot of ongoing research to identify markers other than LDL cholesterol for atherosclerotic cardiovascular disease related cardiovascular deaths. And LDL cholesterol-based approach has remained the foundation for ASCVD management. But even after significant LDL cholesterol reduction, there is a high prevalence of cardiovascular events indicating residual cardiovascular risk. LP small a has been found to be an independent cardiovascular risk factor promoting atherosclerosis, and several meta-analyses along with the recent major trials like the ones we were talking about, Fourier and Odyssey, have proven that elevated LPA levels increase the risk of cardiovascular events irrespective of the LDL cholesterol, even when you have driven the LDL cholesterol levels less than 70. The Fourier and Odyssey trials also showed that significant reduction of the LPA levels with PCSK9 leads to reduction in the risk of cardiovascular events, and there is ongoing research with the novel LPA, novel molecules which are targeting the LPAs in particular. So LPA is a strong predictor of cardiovascular risk and should be considered as an independent treatment target. And that remains the key takeaway from our talk today. Thank you so much for your kind and patient hearing, and back to the chairperson, please.
Thank you, Dr. Supratik, for your wonderful talk. I think the discussion will be in the last, so I will request Dr. Sheikh, the next speaker in this endocrine summit.
Yes, sir. Good afternoon.
Good afternoon. So this is the regarding, he's a well-known personality in diabetes fraternity and endocrinology. So I will request, not wasting much time, I will request Dr. Sheikh to present their talk, and the discussion will be at last. So Dr. Sheikh, dice is yours, please.
Sure. Please allow me to share my slides, chairpersons and the technical team. Thank you so much. Hello, everyone. I think the topic given to me for this particular session, along with Dr. Unni and Dr. Bhattacharya, is what would you do after the patient has got a fragility fracture? What's next? So this particular talk is going to have some mechanistic insights into what exactly is a fragility fracture. Why is it that the bone is involved in diabetes? Links between diabetes and osteoporosis. What further investigation you would actually do when you see a patient with a fracture? How do you stratify these patients with the risk, where the risk could be less than 20%, between 10 to 20 or more? What are the preventive tools that you would talk? Because finally, what we want is not to see a patient with a fracture, but we want to see a patient without a fracture, where he already has got a risk factors, and also once a fracture, there can be a second risk fracture also. So here we need to prevent that. Some therapeutic strategies depending upon the time that we have. How do you treat this particular bone? How do you tackle the insulin resistance, which may be one of the issues that the bone is getting leached from? And also the diabetes treatment and some futuristic fractures. How do you deal with that? A lot of treatment, pharmaceutical armamentarium, a lot of molecules are upcoming in the next few decades. And I'm very thankful to RSSDI to having given me such a topic. Importantly, the linear increase in hip fracture incidence with increasing HbA1c, as we see the most down with the HbA1c of 6, with one of the abnormally controlled A1C more than 10. And that is where we get an idea about that. Yes, it is not just the heart, it is not just the brain, it is not just the kidneys, or it is not just the heart failure that's the new baby. It is also that 1% of HbA1c that is important, that we need to look into. So to answer the question, what next? Importantly, first look at how much is the HbA1c of this patient, because that itself is going to be one of the important risk factors for a fragility fracture. What about the risk and diabetes? Whether it's a type 1 diabetes or a type 2 diabetes, it's quite high. For any fracture, the HR is 1.3, 1.19 for type 1 versus type 2. Hip fractures, spine fractures also. These patients really literally become like kind of a bubble-filled ball. If they slip or if they fall, that's why prevention of falls is important. So if they slip or fall, they are going to break one of the other bone. Your fracture risk in the Women's Health Initiative in type 2 diabetes for any fracture was 1.2, hips, pelvis, upper leg was 1.46, spine 1.27. And if you look into this commonality, the common chronic metabolic disorders across the world have a quality of life issue on an individual's health. In India, where we have every 7 out of 100 having type 2 diabetes, we may have at least 3 or 4 having kind of osteoporosis by 2050. It's quite a debilitating disease. It's a silent killer, and the cost of treatment is definitely much more than what we would think otherwise, even prospectively or retrospectively, wherein the bone is less dense, susceptibility fractures are more. An important thing to understand is that diabetes is actually one of the independent risk factor for osteoporotic fractures. Prevalence is there depending upon type 1, type 2 diabetes. It's been there nearly in all the population. Even the Asian Americans or the Asian Singaporeans who are there, the fracture risk is different. So what are the risks? Let's look into this particular table. The risk factors that help for developing or which cause osteoporotic fractures, they may be directly due to the diabetes itself, poor glycemic control, that's the first slide we showed, and nephropathy, wherein there is a adynamic also and a dynamic bone disease which could happen in a patient of diabetes with nephropathy and chronic kidney disease. Neuropathy and diabetic diarrhea, where there is a lot of risk of fall versus there is a risk of losing out calcium, magnesium, and phosphorus, and due to concurrent presence of either a Graves' disease, which is again a bone leaching disease, celiac sprue, wherein there is issue with absorption, amenorrhea, the FSH-LH link is out, delayed puberty, eating disorders, of course, anorexia nervosa and bulimia nervosa, and sometimes maybe we do not know, even orthorexia nervosa may cause the bone to become weak, to become fragile, to be osteoporotic with a risk factor, and we know then what needs to be done. The risk of falls are so important because if a patient from a fairly uncontrolled one comes to us, if you are very heroic in suddenly getting their glucose values down, we may land up this patient with an episode of hypoglycemia, and that's a very important factor in their history. So when it comes to next, apart from looking at the control, we also have to look at the risk factor for the falls, where the patient gets up at night for nocturia, poor vision, retinopathy or cataract could be there, poor balance due to neuropathy, foot ulcer, amputation, diabetic footwear, something is slippery in the house, orthostatic hypotension, which could be drug induced again, which could be diabetes itself, long-standing can cause that, impaired joint motility and chorioarthropathy, which can cause a lot of associated risk factor to fall again needs to be considered. And these both, osteoporosis is an endocrine disorder and diabetes as an endocrine disorder, they're both seen very frequently and are interconnected in a lot of ways. As we see here, that there is definite initial adolescent accumulation of bone, and it is diminished by around 20-25 years, wherein the person actually gains the whole momentum of the bone and then gets his BMD by around that particular age, as we see here at number 2, and after 40-42 years or so, wherein the decline happens after even 27-26 years in patients with diabetes. So osteoporosis has got a lot of stages onset, and they could overlap with different types of diabetes at various stages of diabetes. There are many kind of mechanisms that we see with diabetes induced osteoporosis, whether it's a TNF alpha or the rank L molecule, which along with the MCSF may have kind of a all osteoblast derived activators of osteoclast proliferative and differentiation. I think we can talk 2 hours about these mechanisms. This is in short age showing one particular graph wherein the ages itself, the uncontrolled diabetes itself has issue with the type 1 collagen, bone rigidity, and other stress yielding issues wherein the bone leaching or the osteoclast activity is more, TNF alpha rank L activity is more, and the blast function is reduced. So overall, there is more resorption, less formation, decrease repair, which is important, and decrease in bone quality, the TBS or that score with because of the non-enzymatic glycated induced skeletal fragility, and it is important. That's why in agenda slide we put up that particular word that we need to look at insulin resistance as well as the HbA1c when you're talking about the non-enzymatic age-induced skeletal fragility. And that's how this literature also on mechanism concludes about the diabetic skeletal fragility to altered bone quality. That's the word that we use. And we need kind of more studies to look into the assessment of biomechanical consequences of this accumulating age. So I will now, from mechanism, will come to what exactly would you do next. We talked about a chart where we saw what history you would take, where we saw what precaution you would take. Now let us look at the goal of what exactly you would do. This particular patient who's come with a fragility fracture, identify at risk fracture, whatever the last column that we showed you in our second slide was that particular patient with the risk of fracture, prevent the first fragility fracture or future fracture if one has already occurred. So in our given scenario, we're talking about prevention of this particular future fracture and of course treating the current one, stabilize or increase the bone mass, that's important, relieve symptoms of fracture and or skeletal abnormalities, improve mobility and functional status. I'm going to show you slides about all these things, initiate lifestyle changes, slide on this, to enhance prevention of fracture. Now, diabetic therapy itself has action on the bone quality itself, whether it is metformin, which has got some action about increasing the BMD and reducing of fracture. Sulfonylureas, TZDs, we all know in postmenopausal ladies, we would not want to use TZD because there is kind of a data which causes that they may reduce the bone formation and may have increase in risk of fracture. We know the bone anabolics like insulin and GLP-1 analog, which could be neutral versus may actually help to increase the BMD and bone formation mask. And SGLT2, we have some data in the past, some data of the current talking about this particular drug. So a 10-year risk fracture is higher at every level of BMD, whether the T-score that we look into is -1, -1.5, or 2, or at 2.5. So essentially what we are trying to tell is that apart from prevention, precaution, and listing the patient with the risk factors and stratification, we also need to have an assessment done by BMD. For example, if the patient is a postmenopausal lady or a man over 50 years of type 2 diabetes and there is a typical osteoporotic fracture, then we need to start on anti-fracture medication. And if the BMD is, if there is no fracture, second time means this patient has already come with one and the score is less than 2.5, again treatment would be given. And if there is too much rapid bone loss on follow-up, we need that trabecular bone score or the TBS, adjusted fracture probability. We'll show you some slides on this. And of course, look at fracture of spine. When we talk about what exactly is typical osteoporotic fracture, look at the spine, hip, pelvis, or humerus and the clinical risk factors, substitute them with rheumatoid arthritis, advanced age. So this is a very easy tool which is available on our website. If you just put fracs, we will get that. Now look into, let us see what happens after fragility fracture is there. Depending on whether it was a male of more than 50 years or less than 50, depending upon the age, or whether it's a pre or a post-menopausal diabetic patient with this complication. Assessment of total number of clinical risk factors, and we need to perform some baseline investigation minimum, which could be either kind of a CBC, which could be either ESR, LFT, calcium, phosphorus, vitamin D, chest X-ray, spine X-ray in some patients, and in some patients this could be mandatory to see whether because the patient may have presented with one fracture but maybe having still one more fracture inside the body. So we need to at times look into history and examination. Special investigation as and when needed that we would look into. This could be system specific or organ specific depending upon the age. So for example, a 80-year postmenopausal female or male, you would want to do a myeloma screening, or a patient with a risk factor of pulse, which is more, or the patient has lost weight recently, you would do a thyroid function test. In men, of course, testosterone, because hypogonadism itself is a risk factor, as I showed you about amenorrhea and other slides. Prolactin, PTH, urine, BJP, again for multiple myeloma, along with protein electrophoresis, biopsy to rule out malignancies, where depending upon the case, you have to get the baseline DEXA, femoral neck, as well as the lumbar spine. And it may be done within 3 to 6 months after the fixation of fracture, if that was very, very in emergency. And as a diabetologist and endocrinologist, if we are called a little later after the surgery, then we need to look into that. It has to be done. And if the 10-year major osteoporotic fracture probability of this particular patient is calculated, and in WHO FRAX chart, this is as easily available as the EGFR that we calculate on our phone. The reference would be the Singapore Indian population, and look at the BMD versus CRF FRAX. I want to stress upon one point over here that people with diabetes do have a higher baseline BMD, but they have a lower score. That's why the TBS or the trabecular bone score is going to be very, very important. It's a very important clinical pearl. And always ascertain the disease severity and the type of pharmacological therapy that you would want to use. Depending on that, what you would want to use, also the blood test may differ. So of course, it's a clinical decision making. If the patient has got high fracture fragility risk, which means that here your number comes as more than 20 in the WHO FRAX chart, then you would do pharmacological therapy and counseling for lifestyle, as well as non-pharmacological therapy and a DEXA at least at 2 sites, at femoral neck and lumbar spine. This is again an important clinical pearl that in DEXA, look for the neck and the lumbar spine, and not just only at the wrist. Now, that is where the treatment guidance is going to be important, and that's why we move ahead in time and we look for anti-osteoporotic agents, we look for bone forming agents. Vitamin D and calcium, of course, are going to be one of the important prongs that we need to give: regular weight bearing exercises and avoidance of tobacco and alcohol. And then you may reassess after treatment of DEXA, maybe approximately of around 2 years duration or so. So if you look at the management, if there is a prior fragility fracture, as in the case given to us, or the T-score is less than 2.5, or if there is T-score is between 1 to minus 2.4, and the fragility risk score is between 3 to 20, then the pharmacological treatment is very, very important. And the case given to us here, the patient, of course, needs a direct pharmacological treatment and prevention of a future risk. Now, when it is a fracture, generally the thought is that we need to see an orthopedician, but actually when the disease is an endocrine disease, it's a kind of a teamwork where you need an occupational therapist, we need a physical or a physiotherapist, we need an orthopedic surgeon. Depending upon which bone is involved, we may need to call even a neurosurgeon, of course, endocrinologist, and at times maybe a nephrologist, because that's how then we form a team and call upon how do you get into goals. The patient thinks that he needs to maintain or regain the independence, and that's very important. This goal needs to be keep in mind, because the patient needs to be moving, the patient needs to be walking. The physician goal is, of course, as we discussed, what next? So next is to prevent the next fracture. And that is why one of the yesteryears, the theme of Osteoporosis Day was capture the fracture. I think that was a very, very apt theme kept for around 2019. We need to improve the bone mineral density and the TBS, and the patient is thinking that, yes, we should make sure that the treatment is working quickly. But let us understand, there is quickly means it takes 1.5 years for the bone to actually get the strength. Bone and muscle are one unit. Stronger the muscle, stronger the bone also is there. That's the reason we need to have those exercises that the patient needs to be done. Patient comes with the thought that I need to do only bed rest because of fracture, but actually it's not like that. Very rarely our colleagues, surgical colleagues, tell them for a bed rest unless it's a quadriplegic thing, or unless it's a fracture at a very innocuous site where we would be careful in immobilizing or mobilizing. So that would depend upon the case. However, the patient would also have a goal of having a treatment that will give a different fracture outcome, and from the physician side take a different treatment approach to achieve a different fracture outcome. And the patient also should have a goal of having a treatment that is simple and easy to use, because this is again very important. There are various types of anti-resorptive treatments, bone forming treatment that needs to be given. Of course, cost is going to be important, but the cost of therapy always is lesser compared to the cost of surgery. And that's the reason the prevention is better than cure in this particular case of diabetes with osteoporosis. For the physician, it's again provide support to begin and stay on treatment for optimal outcomes. I think this is one of the most important line for this particular talk of what next. We need to provide this support to begin. We need to provide the support to stay on the treatment, and we need to provide the support to have optimal outcomes. Each word in this particular line is what we are looking at, and we need to harp upon our patient and what type of exercise can the patient do. It is usually, as I said earlier, bone and muscle are one unit, and muscle strengthening is important depending upon the site of fracture. For overall health prevention, the exercises would be different, balancing exercise would be different, and weight bearing exercises, of course, are one of the important places where it should be done. And it has, even though it has a small effect, we need to give this particular benefit. It reduces the loss of muscle mass, which is very important for diabetic patients. As they are losing muscle, they may be sarcopenic, which itself can cause the bone to lose calcium and the bone cells, and also will start reducing the risk of falls, which is very important. Improve the balance and strength. Regular walking decreases this particular risk of hip fracture. Importantly, tell your patient about how he has to decrease the caffeine. For any diabetes patient, 2 regular cup of coffee, 1 morning, 1 evening, would give less than 200 milligram of caffeine. Anything beyond this is detrimental to heart, detrimental to brain, detrimental to blood pressure, detrimental to bone. So that's why it's a very important history taking about how much coffee you are drinking. Alcohol, you all know how much it is going to be detrimental for the bone. And of course, carbonated drinks they are also bone leaching. They are resorptive. Maintaining adequate body weight is very important. Increase in the exercise and weight bearing and balancing exercises. Let us understand that these are the patients who may be nearly kind of 50 plus, or maybe 60 plus, or maybe 65 plus. So be very careful by giving CNS depressing or any kind of a similar drug, or a patient with orthostatic hypotension. Treat visual disturbances, and eye doctor is very important over here to have a clear vision. And of course, patient education. Like diabetes, osteoporosis is again one of the important drugs, one of the important diseases where drug therapy is important, and we need to talk about patient education. So I think the time given is 20 minutes. I have crossed the time limit already, but I would wait till my chairperson tells me to stop. The pharmacological management, anti-resorptive therapy, as well as bone forming therapy. Usually the thing that is easily available and cost effective and cheap is bone anti-resorptive, or the bisphosphonate, which reduces the bone turnover, which reduces trabecular perforations, which increases bone mineralization and reduces fracture risk. So this could be either alendronate, it could be ibandronate, it could be residronate, it could be zolindronate. So alendronate is once a weekly drug, ibandronate is once a month, and zolindronate is once a week intravenous drug, which is usually given in a casualty or a daycare that we would want to give. HRT, of course, there are a lot of varieties that we would give within the first 10 years post menopause. Also, but of course, this is given in consultation with the gynecologist, in consultation with the patient, and we need to give drugs which the patient will tolerate, which the patient will feel happy. And as I showed you, one of the patient goals, it's a discussion between how quickly the patient would come also for follow-up. There are drugs like raloxifene, there are drugs like strontium ranelate, and the newer on the block, which came in around 4 years back, the denosumab. It's kind of an injection. It's again an anti-resorptive therapy. Good also for postmenopausal therapy, good also for in patients with kidney disease and osteoporosis, and in patients where the effect of other drugs is not yet coming. The offside of denosumab is it's an injection which is to be given once in 6 months, and of course it's a 60,000 rupees per injection. So that cost needs to be spoken to the patient. Now these were anti-resorptive treatment. Now let us move towards bone forming treatment. Bone forming, one is we discussed in the earlier slide about the muscle forming or the muscle building exercises. Bone forming, we have teriparatide, the recombinant teriparatide, the RhPTH is the one which is one of the best ones to be taken. And there are, of course, a lot of other molecules related to teriparatide which are upcoming. They target bone formation, bone volume by increasing cortical thickness, by improving the cortical bone geometry, and restoring cancellous microarchitecture, and thereby they reduce risk. Earlier, we had studies which talked about that teriparatide can be given for around 18 months, and then later we were told that teriparatide now can be given to approximately 2 to 3 years. That's the upcoming data. But see to it that initially when you give this kind of an injection, the patient does not have postural hypotension. There might be some marginal increase in calcium in the initial few days to weeks. So be careful with that, and also see that the patient doesn't have a background calcium issue where it should not be. With osteoporosis, it should not be a hyperparathyroidism. In those cases, we do not give. So the contraindication should be ruled out. Osteosarcomas also are contraindication to give, not to give this kind of a drug. And we, of course, have the calcium and the vitamin D. And as I said earlier, the insulin resistance and reduction in bone loss. So here is an important line over here. If I'm trying to highlight this, vitamin D and calcium should be along with a tight metabolic control in most of the diabetic patients, and they should have their health assessment to be conducted and continue to prevent fractures. And the treatment for diabetic versus non-diabetic would be similar, but we have to catch them early treat them early and give them a good quality of life, and that good glycemic control is definitely having an impact on protective effect, as I showed you in one of the first slides about the HbA1c and the result that we were trying to take from an uncontrolled diabetes. So that's also very important. And management of osteoporosis with diabetes is going to be really to be taken to improve vitamin D levels. Even though that the patient may come suddenly with a fracture, look at the vitamin D. Do not start with directly with an anabolic, because we need to build the calcium. Treating osteoporosis is like treating osteoporosis is like making a wall wherein we have the wall is made of bricks. We have cement in between the bricks, wherein we call it as a vitamin D and calcium. And then there is a plaster over the wall, which could be that we avoid that the bricks do not get damaged. So your brick is going to be more of kind of a teriparatide like of a treatment, which is bone forming, your cement and concrete in between, and then your plaster layers. And to decorate, we have colors and others. And I think with this note, I would like to give it over to the chairpersons. Thank you so much. I'm sorry I've extended my time. I spoke for almost 35 minutes. Thank you so much, ladies and gentlemen.
Hello. Thank you very much, all the speakers. Now we invite the questions. Dr. Dinesh, would you join for the question answer session? Am I audible, Dr. Unni?
Yes, yes.
I think the questions are invited. To set the ball rolling, my first question to Dr. Unni himself, that you said in your talk that in a patient of diabetes who has got a subclinical hypothyroidism, and if the lipids are abnormal, is the right time that one should start thinking of starting a anti-thyroid therapy. But very well, most of the time diabetes dyslipidemia is always there, and otherwise also we do start statin therapy in a diabetic patient, especially above the age of 50 years as per the new guidelines. So how far it is feasible and how far is your statement true to the fact?
Thank you for that question, sir. So there are two important points here. If you remember, this patient had a TSH of 14. So where the TSH is more than 10, and if there is a subclinical hypothyroidism, then we generally start therapy. But some guidelines are now saying it should be above 20. That is the British guidelines, but generally above 10 is considered good enough to start. Now, the second thing about this patient is that in a patient with hypothyroidism, now if there is dyslipidemia, of course, you're thinking of statin therapy. But there have been some case reports where if you start statins before correcting the hypothyroidism, it can cause rhabdomyolysis and muscle pains. So therefore, when you see a patient with hypothyroidism requiring treatment, I'm not talking about a TSH of say 6 or 7, may not require treatment. But supposing a patient like this, TSH 14, weight gain requiring treatment, such patients, it's always good to correct with thyroxine and then correct the dyslipidemia if there is a residual dyslipidemia after correcting for the thyroid deficiency. But again, you will know that now the current lipid guidelines, our treatment is based on the risk, not based on the level. So after correcting the hypothyroidism, you can straight away start on statins depending on the risk. You don't have to look at the LDL. So these are some of the points, but I take your point that not all subclinical hypothyroidisms today need treatment. That point, sir, is very well taken, because earlier we were treating a lot of TSHs which was slightly high. Nowadays we don't treat. We look for the right patient to start treatment. That point I take very well, sir.
Thank you very much. Any more questions from anybody, or Dr. Dinesh would like to intervene? My question to Dr. Bhattacharya, please. You have very well spoken about the lipoprotein A, but you know that for all the practical purposes, the focus is always on the lipoprotein LDL cholesterol by most of the physician and also by the cardiologist. How do you justify that when exactly the focus and importance should be given to the lipoprotein, or both things should be looked together?
So thank you so much, Dr. Pandey, for your kind question. So I think we have highlighted that LDL cholesterol is something which is feasible to do at every single biochemistry lab, and it's also possibly, you know, like when you're talking about the cost of the test, it's much lesser as compared to doing LPA level. So that's why if you look at the recommendations, those who have a very high LDL cholesterol, once in lifetime, they recommended that they should get their LPA levels done. And those molecules which are targeting both the LDL cholesterol as well as the LPA does best in terms of reducing future cardiovascular events. Because clearly data is showing that when you treat the LDL cholesterol to the target levels, even below 70, there is a residual risk that remains. And that is possibly because of the elevated LPA levels, and we need to address that as well. So as of now, as we were seeing that we do have the PCSK9 inhibitors, which does both. It drives the LDL cholesterol down, it drives the LPA levels down, and thus has the best effect in the future cardiovascular outcomes and reducing cardiovascular related mortality. However, there are novel agents that are coming up which are going to target only the LPA itself. And as we had been showing, they're right now in phase 3 trial. So we are going to get them in a few years' time, hopefully.
In a present scenario, what do you think that which statins acts best on the LPA and what doses?
So we had shown you that anyone with so you have to target the LDL cholesterol, and that's all that you can do. So you have rosuvastatin and atorvastatin, and whichever study you look into, they're equally effective in driving the LDL cholesterol down, and to a certain extent also addresses the LPA, but not as effectively as PCSK9 inhibitors.
Dr. Dinesh, would you like to have any question or anything else? Or else I would like to close the session, and thank you very much to all the 3 speakers. You have been fantastic and you have really enlightened us and made us wiser. Thank you very much, Dr.
Thank you,
Unni.
sir.
And is there any more question?
Thank you, sir. Thank you so much.
Thank you, Dr. Altamash. Thank you very much. Bye-bye.
Thank you all. Good wishes.
Thank you.
Thank you so much, everyone. Great to see you.
Thank you.
Thank you.
Thank you.
After transplant, no doubt is the
Thank you.
terminology. Similarly, you have new diabetes
Take care, sir.
developing after the COVID virus infection. And it is known that the COVID-19 virus can attack the beta cell. And this is like the type of type 1 diabetes, not known.
Hello, can you start it off?
Yes, sir. Yes, sir.
Hello, can you start off?
Yes, sir.
Okay. So thank you, ladies and gentlemen, for being present over here in this wonderful seminar of RSSDI. In fact, after this previous seminar of endocrine symposium, we are now back into some clinical thoughts and clinical insights, for which we have a wonderful galaxy of speakers, starting from Dr. S. Arulraj, Dr. Kamlesh Tiwari from Patna, Dr. R.M. Anjana, and Dr. S.B. Madhu. So they will be highlighting us on the various aspects of diabetes, mainly the legacy effect, which the first speaker will take on. And then we have this lifestyle modification for diabetes, and then the vascular complications in pre-diabetes. So very clinically pertinent topics. So without wasting much time, I will ask Dr. S. Arulraj to proceed with his deliberation on the legacy effect in diabetes care. So over to Dr. Arulraj.
Yes. For giving me an opportunity in RSSDA to discuss about a very important clinical topic. which has been well studied and accepted. It is a legacy effect in diabetes, which is a very common terminology. We use it as we keep doing our work in any profession or business. As you work hard, you have a legacy effect. That is something positive comes back to you after years also. Even in our own practice, it comes there. All of us know. Like that in diabetes, there is definitely a positive note in the future when you stiffly control the diabetic state in the early years, especially below the target of HbA1c 7. This is a slide from my good friend Dr. Mohan. This it makes us to realize the diabetic status in our country. There are about 84% of people, they have diabetic, but they don't know they have diabetes. They are labeled as non-diabetics. Only around 16% are diabetic. This is the data from Mohan from Chennai. Out of them, 33% only know that they are diabetics. 67% of them do not know that they are diagnosed or not. And there are, of this, 44% are on treatment and 56% not on treatment. And those who are treated, roughly about 29% have only a control, and uncontrolled is 71. See, only 20% of the people know they have diabetes. Out of them, 29% are only controlled diabetes. Therefore, it makes us to say that diabetes is a disease, a metabolic disease with vascular complication, but goes poorly controlled, which leads to a lot of things. Then what we should do to change? This is a BMC data, that is a 2005 data. This is to the 2019 data. Of these, 53% of the people are aware they are diabetics, 47% are not aware, of which 42% are only treated, 58% are not treated, out of which 25% are only controlled. Now today we say that there are about 77 million diabetic people in India, and these are the numbers that we see here. That shows most of the people have not been diagnosed to have diabetes. And even those people who know that they have diabetes, they have a poorly controlled diabetes. That is why this topic becomes very important and for the future. What we label as a legacy effect in diabetes is a long-term effects of a tight glucose management. There is a legacy effect describes the long-term health benefit that result from intensive blood glucose management in diabetes care compared to standard glucose control. And what is metabolic memory? Metabolic memory is again a term used to describe the beneficial effects of immediate intensive treatment of hyperglycemia, which can be maintained for many years. That is what we were talking now. See, this is a situation when there is a the diabetic status, the dysglycemia keeps on varying between 8 to 7, 7.5. When the glycemic control is 7, the risk for future vascular complication risk seems to be very low. See why we are bothered. Diabetes has, as Professor Moses used to say, two components. One is metabolic, another is vascular. Metabolic is clinically challenging but solvable easily, quickly. Whereas vascular, it is a highly highly challenging situation and takes care of the life of the patient by increasing the mortality and morbidity. Therefore, this legacy effect is given a lot of importance. The therapeutic inertia and the legacy of dysglycemia over microvascular and macrovascular. The diabetes, when it is T2DM, decline in the beta cell functions keeps on coming as years keep moving. The hyperglycemic burden is associated with longer term microvascular and macrovascular complications, which is a known fact. And this metabolic karma or the atherogenic legacy of diabetes, in 2017, this Edwin Bierman Award lecture, it was stated that the role of oxidative stress and advanced glycation products, AGE, are identified as potential targets for vasoprotective therapies in the setting of diabetes. There are very number of studies like our UKPDS study, and then this pre-terax and diamicron MR controlled evaluation, advanced study, and epidemic, the DCCT and EDSA. All of them say, in addition, for this metabolic memory, there is an epigenetic pathway. In addition, the oxidative pathway, epigenetic pathway is also active and causes glucose-induced histone methylation that plays a very key central role. In the legacy effect, as per the DCCT trial, when the HbA1c target was kept at 7.2, it showed a great legacy effect, 63% reduced risk of diabetes-related retinopathy after 5 years, 54% reduced risk of kidney disease after 5 years, 60% reduced risk of neuropathy and nerve damage, and 30% reduced risk of cardiovascular events after 20 years. The risk of complication increased with higher level of A1C. Herein, there are some of the findings from the glucose study. During the trial, when the control of A1C was 7.9, whereas in the intensive group it was 7. In the 7.9 group, the differences in the vascular effect were very much. And there are 12% reduction in any diabetic related endpoint. Maybe, hyperglycemia, hypoglycemia, myocardial infarction, and microvascular complications, including kidney and eye. When there is a stiff control of, A1C around 7, the vascular component, especially microvascular component, is very much safeguarded. And 21% reduction in the risk for diabetes-related retinopathy, 33% risk reduction in kidney disease. It is called as a glucose legacy effect. In short, all of us know when there is a tight control of blood glucose in the early years, how you do that, we'll come to it. When it is 7, and that carries this control, protects the vascular system for the years to come, even if there are little ups and downs. There is a, trial called the Dog-Wing Prevention Trial that also confirms the look-ahead trial in the diabetic, reversal group also says that when there is a stiff control, the vascular complications are reduced. Our popular UKPDS study, what does it show? That is sustained benefit with respect to cardiovascular disease outcome seems long after the conclusion of the trial. What is a diabetic effect? That is, diabetic effect always causes damage to the large and smaller vessels. The good news is this diabetic effect can be reduced by adequate control of the blood sugar in the early years. And again, the long-term observational follow-up of this trial revealed that there is early glycemic control has durable effects. Even after 10 years, we are able to evaluate it. As per the result goes, when the HbA1c levels are 6.5, the microvascular and macrovascular even are reduced. When it is to 7 to 8, the microvascular may be there, but macrovascular does not go. Conclusions are, among patients with newly diagnosed diabetes and 10 years of survival, HbA1c levels 6.5 for the first year after diagnosis was associated with worst outcomes. Immediately, intensive treatment for newly diagnosed diabetic patient is necessary to avoid irremediable long-term risk of diabetic complications. This is the legacy effect following our UKPDS and ACCORD trial. All of them say the first large clinical trial to compare the cardiovascular effects of statins and placebo, an inactive pill, to combination therapy of statin, and that did not have any legacy effect. There is a statin effect on the vascular complication. This is the system or the mechanism of this metabolic memory. There is hyperglycemia, which goes to an oxidative stress, intracellular and decrease in the nitrous oxide bioavailability, oxidative stress, and it causes the, chronic vascular complications. And here, advanced glycation end product also comes there, and oxidative stress is there. Two mechanisms are causing an oxidative stress. These are the summary of the few, trials. All of them say when there is an adequate control of blood glucose, there is a safety or a legacy effect on the vascular system. This is the Accord trial. The treatment after primary outcome. Intensive group has, very good safety of their vascular system. And this intensive group, in DCCT also has a good control of the vascular, long-term vascular complications. And the cumulative incidence of the first any predefined CVD outcome is also available. And intensive treatment when there is a, good glycemic control, the vascular long-term complications are very much reduced. This is again our, when there is an hypoglycemic effect due to insulin or sulfonylurea, you are able to get a good reduction of the vascular complications. And therefore, for microvascular disease prevention, the A1C goal for non-pregnant adults in general should be kept as 7, because only then you have, good clinical outcomes in the long run. And when there is a, there are certain people in whom the 7 cannot be adhered to, especially people having a hypoglycemia with a limited life expectancy, already having vascular complication. In those people, little relaxation of the guidelines can be there. This is again the mechanism. High glucose level goes to intracellular oxidation, superoxide, and damages the, mitochondrial membrane and cells, which cause the vascular component. This is about DCCT trial. Advanced glycation end products are there, which has been recorded in the skin biopsy of these people. Significantly, it lowers the intensive arm. Also, significant reduction in the advanced glycation end products. This is the vicious circle, as we said. There is hyperglycemia, intracellular, ROS, and it goes to endothelial damage and causes vascular reaction. The legacy effects, again, the pathophysiology is overproduction of superoxide anion continues even after the blood glucose levels normalize. Possibly, that is explaining the lasting legacy effects seen after the diabetic state is under control. Continued production of the superoxide may be one of the factors. There is again another algorithm, that is hyperglycemia. It is focusing on epigenetic modifications and intracellular superoxide, and goes to a formation of an inflammation. A low-grade inflammation continues in these people. And this effect can be due even when you control the blood sugar with the metformin. This is what this study, proves. There is a recent study here, that shows a reduced all-cause mortality in intensive treatment group after 25 years reveals legacy effect even in T1DM. Even in T1DM, when there is a stiff control right from the beginning, the vascular complications are very much less. This is a recent study which has come out. Now, these are the summary and conclusions of the various, studies and how to prevent the CVD in diabetes. The glycemic control has to be at 6 to 7, and microvascular complications are definitely reduced. Macrovascular takes longer time. Some of the trial they were not able to demonstrate. BP control has no legacy effect, because when I'll also come to it little later, when there is diabetes and hypertension, you may control diabetes, but the ill effect of hypertension may continue and damage the vascular endothelium. That has to be, we need to be, very careful. Therefore, a combined intensive blood pressure and blood glucose control versus standard blood pressure and blood glucose control reduced CV mortality and all-cause mortality consistent with the imperative multifocal approach. This is again a metabolic memory in cardiovascular disease. When we talk about, vascular disease, we are concerned about cardiovascular system, cardiac and vascular, either in the, cerebral or in the peripheral. And again, this oxidative stress is the cause for it, and that can definitely have the legacy effect. Now, ladies and gentlemen, hyperglycemia can also promote the formation of AGEs independent of superoxide anions, and due to a histone modification, DNA methylation, RNA alteration, all can also form AGE formation, which has been proved in DCCT trial by taking a biopsy from the skin, which showed the AGE. And one word about the hypertension. When there is a hypertension in diabetic study, there is a study 10 years after the original study. The patient with hypertension diabetes study were not actually newly diagnosed. When there is a hypertension, when that hypertension is adequately controlled, and if you don't continue the treatment, legacy effect is not there. Whereas in diabetes, when you have made a stiff control in the early stages, and even if there are some ups and downs, the vascular protective effect continues. Whereas in hypertension, it does not continue. You see, then the absence of a BP legacy are only a time-to-time effect relationship BP and the CV outline. Then if you have a patient who has got diabetes and plus this, you will have to control diabetes adequately, and you will have to control blood pressure also adequately within the guidelines, and this control should be continued for long term. Otherwise, it will definitely damage the vascular endothelium. This has been proved in a value trial and heart trial, and all these benefits of hypertension therapy and major outcomes usually appear shortly after the treatment implementation. Therefore, when there is a combined disease for both the people, you will have to be very, very careful. But when both are under control, definitely there is a significant reduction in the myocardial infarction by 22%, stroke by 33%, CV death by 37%. Therefore, adequate control of both is essential here. These are the conclusions. Rather than focus on the possible lack of BP legacy, the interpretation should emphasize the questionable finding that CV protection is more likely to be effectively achieved if tight blood control is also implemented early and sustained over time. This is what I have been saying. It has to be sustained. Now, conclusions, ladies and gentlemen. Early intensive treatment of new-onset diabetes is aimed at tight glucose control, reduces the risk of microvascular complication and probably macrovascular as well. The metabolic memory and legacy effect are terms that have been used to describe the fact that glucose control early in the natural history of diabetes profoundly influences the prognosis later in life. And for this, an early use of insulin is very much necessary. When to use it, how to use it, always needs to have a clinician decision and patient education also. Thank you all. The message I would like to convey is stiff control of blood glucose at 7 HbA1c has a protective effect on the vascular system. Let us do that. Thank you very much. Thank you.
Thank you, Dr. Arul Raj, for your very deliberate and wonderful presentation. You really dealt well on the topic. So the questions we'll be discussing at the end of the session. So now we have our second speaker, Dr. Kamlesh Tiwari from Patna, who will be highlighting us on the lifestyle modification for diabetes mellitus. Dr. Kamlesh Tiwari is ex-professor in HOD of medicine from SK Medical College, Muzaffarpur. The rest, everything has been highlighted in the slides. So over to Dr. Tiwari. Please proceed with your deliberation.
Thank you, Chairperson. I'm setting my slides. Can you see my slides? Can you see me?
It's visible. You just
Yes.
enlarge your slide. Yeah, it's okay.
Okay. So my topic, lifestyle modification in diabetes mellitus type 2. So diabetes is a group of metabolic disease characterized by hyperglycemia resulting from defects in insulin secretion, insulin action, or both. Long-term damage, dysfunction, and organ failure associated with chronic hyperglycemia, especially eye.
Dr. Arulraj, can you please mute yourself? Dr. Arulraj, please mute yourself.
Okay.
Especially eye, kidney, nerve, and heart. So in India is the capital of diabetes mellitus with 69.1 million after China. This is the figure of 2015, and according to IDF, around 450 million people had diabetes in 2015, expected to rise 642 million by 2040. Around 75% of subjects with diabetes live in low and middle income country, and it is increasing in rural population as well as in middle and lower classes. So can we prevent diabetes mellitus? Answer is yes. How? This is the death figure due to diabetes, and diabetes is the third most common cause for the death after ischemic heart disease and other heart disease. So why the prevalence of diabetes is increasing in our country especially? Because aging of the population, urbanization, especially in the developing countries, more sedentary lifestyle, and bad food consumption pattern, especially more food with high fat content and more refined carbohydrates. So these are the main factors for diabetes in rural area and in poor country and developing country. Now, for better lifestyle management of diabetes, we have to consider diet, exercise, weight reduction, no smoking, moderation of alcohol, and management of stress. The recommended lifestyle interventions include taking 2.5 hours each week a moderate intensity physical activity or 1 hour and 15 minutes of high intensity exercise. Number 2, losing weight gradually to achieve a healthy body mass index and replacing refined carbohydrate with whole grain foods and increase intake of vegetables and other food high in dietary fiber and reducing the amount of saturated fat in the diet. So these are the 4 things which we should adapt for the prevention of diabetes. About exercise, there are many advantages of exercise, like it causes glycemic control, improves insulin sensitivity, builds physical fitness, optimizes physical fitness, and gives psychological well-being. And there are certain disadvantages also, carry some risk like stents to compromise cardiovascular system, injury to musculoskeletal system, predisposed to hypoglycemia, and may exacerbate complications as well. So this physical activity is divided into 2%, moderate intensity physical activity and vigorous physical activity. And these are the types: brisk walking, cycling on the moderate type, and jogging, swimming, cycling on the steps are on vigorous type. So ideally 2.5 hours of moderate intensity exercise and 1 hour and 15 minutes of vigorous physical activity. But in my opinion, both should be combined, and timing is not that bar. So both activities should be there for a human being. These are the common types of exercise. And this is the calorie spent in various activity like walking 3 miles, 5 miles, 8 miles, cycling, mopping, scrubbing, and gardening. So these are the calorie lost per hour due to various exercises. In precaution, correct footwear, that is most important during exercise. Comfortable loose clothes should be there. Close inspection of feet every day should be there. Carry snacks as protection from hypoglycemia. And patients should be able to carry out a normal conversation while exercising without getting breathless. That is most important thing. Exercise testing, patient may feel slight but noticeable increase in breathing, causes increase in heart rate, sweating, and walking with talking without increase in breathlessness. That is the guideline for exercise. Second thing is obesity. Obesity is a nationally declared epidemic. It is a term that means your weight is at least 20% more than a normal weight. So whatever we eat, energy in should be energy out. But what happens? Excess calorie and lack of physical activity, energy imbalance over a long period of time. Excess energy is stored in fat cell, which enlarges or multiply. Enlargement of fat cell is known as hypertrophy, whereas multiplication of fat cell is hyperplasia. And with time, excess in energy storage leads to obesity. These are the conditions associated with obesity, diabetes, hypertension, gallbladder disease. And the benefits after losing weight, like 20% fall in total mortality, 30% fall in diabetic-related death, 40% fall in obesity-related death, so on. So there is definite benefit after losing weight, which we can see here. So weight management, healthy BMI should be between 20 to 25. Above 25 is overweight and above 30 is obese. So if you are underweight, increase food intake to optimize weight. If it is normal weight, continue same amount of food intake. And if it is overweight, gradually decrease the amount of food. So that is the principle in general. This is the BMI should be normal. That is 18.5 to 24.9 is normal BMI for normal weight. But in diabetes, it is not only obesity which matters. It is waist circumference that is more important. And if it is more than 94 in men and more than 80 centimeters in women, it is associated with metabolic syndrome that is a part of diabetes or increased resistance. So that is more important rather than obesity. But anyway, patient has to lose weight, whatever condition is there, whether it is a simple obesity or central obesity. So there are two things. One is exercise and second thing is diet. So what can we do in diet? The general dietary advice from NICE guideline to reduce risk of type 2 diabetes is to decrease intake of fat and increase intake of dietary fiber. People who are currently overweight are advised to eat a smaller portion to consume fewer calories. This is healthy diet. This is balanced diet. Balanced diet contains nowadays 40% of fruit and vegetables, 25% fiber is carbohydrate, 25% protein, and only 10% fat. So this is balanced diet for an individual nowadays. So fat, that is more harmful for diabetic patient, as we know, because it is a carbohydrate metabolism related to sugar, but cause of death is atherosclerosis and ischemic heart disease. So fat is more important than carbohydrate here. So what we should do for fat? As we know, fat we get in 4 types: saturated fat, trans fat, monosaturated fat, and polysaturated fat. Saturated fat is that tends to remain solid at room temperature, and monosaturated tends to remain liquid at room temperature. So in diabetes or obesity, our aim to reduce the saturated fat and no to trans fat, and increase the amount of monosaturated fat and polysaturated fat. That is a good cholesterol which will help in a human for maintaining the fat content of the body. So monosaturated and polysaturated are found in plant-based food and fish. But don't take fatty meals, poultry fats and skins in large amount. That should be limited, and no, not at all to the trans fat, no. So these are green vegetables and fruits. So what are the advantages? We are seeing these pictures everywhere for the dietary modification. Now, these plants contains esterols and estanols, and it helps in the metabolism of cholesterol. Actually, it prevents the absorption of cholesterol from the intestine, because on a molecular level, esterols and esterols look like a cholesterol. So when travel through the digestive tract, they get in the way. They can prevent real cholesterol from being absorbed into the bloodstream. And instead of clogging of arteries, the cholesterol just goes out with the waste. So these plant cholesterols are helpful because it prevents the absorption of real cholesterol. The nuts, very important, and important that everybody says that it contains more fat, it contains more energy. That is true. It contains more fat and contains more energy. But the fat which is there is monosaturated fat, which is a good cholesterol, helpful cholesterol, and it removes bad cholesterol from the artery. So it should be taken. Don't worry about fat. And about energy, well, it contains a lot of fibers as well. So that fiber helps into reduction of weight. So weight maintenance and good cholesterol are the quality of these nuts. So we must take nuts early in the morning to some amount, not too much. 1 ounce or 1.5 ounce is enough in every morning, and that is more beneficial for losing the weight and for removing the bad cholesterol from our body. Regarding protein, we know non-vegetarian proteins are fish, eggs, meat, and dairy foods. So if patient is diabetic, ideally fish and eggs are good, not meat. And dairy foods are also not very good for diabetic patients or those patients who are overweight. So try to take fish as per the requirement, and 1 egg can be enough, but try to take the vegetarian proteins as much as you like, and that will be helpful. And in the list, it is beans, soya beans, green peas, spinach, sweet corn, asparagus, and these other things which can be taken as a protein. About carbohydrates, we get carbohydrates from many foods like these ones, but in our Indian culture, what is the problem? Problem is Indian diet is not complete without roti and bhat. So every patient will ask, can I take roti? Can I take bhat? And becomes very difficult to answer those small silly questions. So roughly there is no much difference in the nutritional value of roti and bhat. There is slight difference in roti and bhat because roti contains more sodium content, whereas rice doesn't contain that sodium. And roti contains more amount of phosphorus and magnesium and fiber, whereas there is nothing like that in rice. But main thing is we take 2 or 3 chapati in our diet, but amount we take more for rice. So that is the difference. Amount of rice that is more, and that causes more energy consumption. So reduce the amount of bhat or rice, that will be helpful, but otherwise there is no difference in nutritional value. These are the glycemic index of common food items we know already. So diabetic, what not to eat, like sugar, sweet, pastry, vada, mutton, beef fry, chips and cola, they should avoid these type of food, and they should take a small frequent meals, at least 6 times in a day. That is a routine. In the morning, lunch, and in the evening. It is divided into 6 portions. So divide the food into 6 parts and then take a small and frequent diet if patient is diabetic. Avoid all fried foods. There is no compromise in this. Avoid all fried foods. Now, smoking and alcohol, these are 2 things which are not directly related to diabetes, but as we know, diabetes ultimately causes ischemic heart disease and myocardial infarction. So smoking and alcohol is related with heart actually. So it is harmful in diabetic as well, and it can cause increase in heart rate, increase in blood pressure, injuries heart and blood vessels, and these things if you smoke too much. So it is better to stop smoking even if you are taking any in case of diabetic. And similarly, cases alcohol, kindly don't take alcohol. It is harmful to the health, especially in diabetic and especially in the heart patient. Well, there is one view that a small amount of alcohol can be permitted if patient is suffering from heart disease. Well, that a small amount is 32 ml for female and 60 ml for male. And that is for, it causes a small amount of increase in the HDL cholesterol. That was the view, and it can cause even slight vasodilation. So they have permitted to take a small amount of, 2 pegs in the male and 1 peg in the female. But usually it causes a lot of bad effects, which you can see here, and it should be avoided. If patient is not taking alcohol, don't encourage him to take alcohol at all. Stress, that is another important factor which we should take care of. And as we know, modern life is full of hassles and stress, frustration, and demand. So we should try to keep the stress in a normal condition. And there are certain tips to managing the stress. And yoga, pranayam is also helpful to reduce stress in the certain individuals. So we must try yoga and pranayam to keep the stress away. And good sleep, that is also very important to relieve the stress, and to being a normal, healthy person, sleep is essential, especially 6 to 8 hours, and that is must. So take home message is a major, diabetes mellitus is a major challenge to human health. Type 2 diabetes can be prevented. Primary prevention is suitable and affordable. Lifestyle interventions are effective in prevention. Barriers for prevention should be addressed, and diabetes can be managed with lifestyle alone. And healthy eating and regular exercise, yoga, pranayam, and good sleep are needed to keep the person healthy, and we'll try to reduce the diabetes. Thank you very much.
Thank you, Dr. Kamlesh, for very well highlighting the importance of lifestyle modification in type 2 diabetes. In fact, it's a very pertinent topic for the diabetic patients, the most important which we can say. The question and answers will be dealt up later on. So now we have the next speaker, who is Dr. R.M. Anjana. She's from Chennai, and she'll be speaking on cluster drug responses. So without wasting much time, I will just hand over the session to Dr. Anjana. Dr. Anjana, please proceed with your deliberation.
Thank you very much, sir. So let me just try and share my slides. Yes, so I think, so you can see my slides?
Yeah, your slides are visible. You can just enlarge it.
Yeah, just 1 second. I'm trying to get rid of this. 1 second. Yeah, that's gone. And I'm just going to put this. Yeah, right. So, yeah, there it is. Right. So thank you very much for the opportunity to speak at RSSDI. We are still on a virtual mode right now, and hopefully I'm unable to come. I know there is a hybrid going on this time, but very happy to be a part of this. Thanks to Banshi sir and all the others at RSSDI. So today I've been asked to speak on cluster drug response, and I have no conflict of interest to declare. So what is this cluster drug response? So first is we have to say, what is clustering of diabetes? And for that, we have to ask the question, is all type 2 diabetes the same? Well, obviously it's not the same. Those who are thin are different from those who are a little heavier. Those who are younger onset diabetes have differences from older onset diabetes. There's differences in rates of complications, in differential response to drugs, etc. So in Scandinavia, the first attempt at clustering type 2 diabetes into different subclusters was done by Leaf Group and colleagues. And what they did was that they took about 8,000, 9,000 individuals from the Swedish Scania cohort, and they clustered based on all diabetic patients they took, and they clustered based on these 6 variables: the GAD antibodies, age at diagnosis of diabetes, BMI, A1C, HOMA beta, which is a measure of insulin secretion, and HOMA IR, which is a measure of insulin resistance. So they clustered based on this and got subtypes of diabetes in this population. They then replicated this in few small cohorts. You can see 4,800 people, 3,000 people, etc. So this is what they first did. Now, these are the clusters that they had. They had 5 clusters, all of diabetes together. The first one is called SED, which is actually another name for type 1. So we won't talk about that anymore. But among the rest, we have 4 subtypes of diabetes, which was SID, which stands for severe insulin deficient diabetes. Then they had SIRD, which is severe insulin resistant diabetes. Then they had MOD, which is mild obesity related diabetes. And the last is MARD, or age related diabetes. So these were the 4 types of diabetes which they applied. So then they said, we asked the question, can this then be applied straight away to the Asian Indian population? Now, Asian Indians have a unique phenotype, which all of us know about, right? We have a greater susceptibility to type 2 diabetes. Why do we have this? The diabetes that we have, if you look at the ICMR INDIAB study, which is a national study on diabetes and related risk factors, you'll see that the age of onset for diabetes in the Asian Indian population is in the age group of 25 to 34 years. Now, you take any other Western Caucasian population, you'll see that this is somewhere in the 50s. So you have a shift to the left by a couple of decades in our population, with younger and younger people getting diabetes. Moreover, you'll see that these are very thin people. So they are thin in the sense that they have a low BMI. They may or may not have a low birth weight. But if you look at them, they'll have a lot of visceral adiposity. So they have thin arms and legs. The BMI may be a little low, but they have a lot of visceral fat. So that is a particular kind of phenotype that we have. We also have high levels of insulin per se due to insulin resistance. We have low levels of adiponectin. We have a lot of the inflammatory markers, CRP, etc., and a very characteristic dyslipidemia where we have low HDL, high triglycerides, and high small dense LDL. So it's not just the total LDL, but the type of LDL, which is small dense, making it very atherogenic. So suffice to say that all of this gives us increased risk of type 2 diabetes and premature cardiovascular disease. So this is a collaborative study between the Madras Diabetes Research Foundation in Chennai and the University of Dundee in Scotland. The study is called INSPIRED, which stands for India-Scotland Partnership for Precision Medicine in Diabetes, and is funded by NIHR UK. So the first thing we did was try to apply the same exact thing of Scandinavian population into the Indian population. So if you look at this, now first they had, let's take BMI. So BMI in SID was obviously the lowest, okay? And then they had the highest was of course in MOD, which is their obesity related. Now compared to Indians, the obese people were actually not very obese. Look at the obesity rates here, BMI 24 for SID, 25 for MOD, and it's higher in the insulin resistance group, it's higher in the MARD group. So suffice to say, and if you look at all of these parameters, they are not sitting very well in the Indian population. So we could not replicate the Scandinavian clusters as is in the Indian population. So then we said, okay, we are not able to replicate it. Can we make our own clusters? And this was the publication that came out in July 2020, where we reported independent subclustering of type 2 diabetes in the Asian Indian population from the INSPIRED study. The base population or initial discovery cohort for this was from the Dr. Mohan's clinics. We studied 19,000 individuals with new onset diabetes, less than 5 years from diagnostic visit. These were included into the study. Now, the clustering variables which we took were different. They were based on the Asian Indian phenotype. So we had 8 of these variables. So age at diagnosis, BMI, waist, HbA1c, triglyceride, LDL, and we also had C-peptide, fasting, and stimulated. So all of these variables went into our clustering. And these were the subgroups that we found. So 2 of them are very similar to the Scandinavian clusters. The SID, which is the severe insulin deficient diabetes, is the same. And the MARD, the mild age-related diabetes. So the first and the last are similar to the Scandinavian clusters. But we do have 2 novel subtypes which have been described for the very first time. And that is the IROD, which stands for insulin-resistant obese diabetes. So what we found is that in the Asian Indian population, obesity and insulin resistance go together. So we are not able to separate. In the Scandinavian, we were able to show separate insulin-resistant type, separate obese. For us, it appears to be combined. So when you have obesity, the insulin resistance goes along with it. So that was called the IROD. And the most novel one is called SIRD. So this is described for the first time in the world, wherein they have a combined deficiency of insulin deficiency and resistance. So it's a kind of in-between between SID and IROD. So if you look at all of their characteristics, it will be between these two populations. Now, the importance of this is that being combined, it's double the trouble. So that's what happens. There's increased risk of all the microvascular complications, as we'll see in a minute. So these are the cluster phenotypes. Not to scare you with a busy slide, but just a few key points. What is the age at diagnosis for this population? For MARD, it's about 50 years, which is quite young. In any Scandinavian population, you will see that it's above 65. So even the WHO defines aging to be, elderly to be at 65. But for us, even at 50, 55, we are seeing the MARD cluster that's coming in. Now look at the other clusters. Look at the SID, the insulin deficient variety. These are the lean, thin diabetics. And all of us have seen this in practice. Look at the BMI is very low, waist is very low. Look at IROD. So that becomes the highest. So this is the most obese category. This is the thinnest category. And SIRD is somewhere in between for both of these. A1C, of course, the insulin deficient varieties, which is SID and the SIRD, have high A1C, very high triglycerides in the SIRD, and very good HDL in the MARD. So these are the kind of characteristics that we have. If you look at the C-peptide and HOMA and all that, it will follow the same kind of characteristics, wherein it's lowest in the SID and highest in the IROD, as it should be. Now, remember I said that we took new onset diabetes less than 5 years. So did it change when we took less than 3 years, less than 1 year? No, it didn't. The clusters remain stable even with the other data sets. Now, I've told you about the clusters. Remember I said that the base population for this came from a clinic. So the obvious question then is, how can you extrapolate this to India based on a clinic population? We don't have epidemiological evidence. And thus we took the data from the nationally representative data set of India, which is the ICMR INDIAB study. Now, in INDIAB, we had 6 of the 8 variables used for primary clustering. So we had age, BMI, waist, HbA1c, triglyceride, and HDL. We did not have C-peptide alone. So without that, we were able to recluster. And if you remember the previous slides, what you see, so MARD here is 55 years, just like in the hospital clustering. And look at the BMI, again, lowest in the SID, highest in the IROD, glycated hemoglobin high in the deficiency states, and everything is kind of mirroring the exact same clustering variables up to decimal point. It's almost the same. So this was able to show that the clusters remained stable and had a stability index of 0.75. We were able to replicate this at a national level for all of India. So what is the clinical relevance of this clustering? It is the risk of microvascular complications. And thus, these are the Cox hazards ratios, which talk about which of the complications are more prevalent among the various subclusters. So as you can see, retinopathy is very high for SID, is 1.5 higher times of getting retinopathy, but even SIRD, so this is the combined group, has a very high risk. If you look at nephropathy, and this is by albuminuria, both micro and macroalbuminuria, you'll see that SIRD alone is significant, and CKD is by GFR. So IROD, as you would expect, but SIRD is also there. So the importance of this, look at this. In every category, you see that the SIRD is coming out as significant, and this is what is quite important in this clustering. Now, we're coming to the drug responses among the clusters. Now, for this, we took a separate population. So these are the contributing centers who gave data for this study. And you can see it's the who's who of diabetology, and everybody in RSSDI is here. We had from 12 of these states and 1 union territory, a total of 15 centers contributed 32,000 data points into this study. The first thing we did, of course, was recluster. And not to take you through those complicated tables again, but we were able to again replicate in this new cohort the same 4 clusters of SID, SIRD, IROD, and MARD. Then what we did, we had to look at drug responses. So we had baseline drug available in 30,000 individuals. We needed a HbA1c follow-up. For 14,000, we had that. Then after all the cleaning and removing all the other stuff, we finally had 13,000 individuals in whom we could study the drug responses. So this slide here is busy, but it tells you the prescribing patterns of which drugs are given for type 2 diabetes in the country. So if you just to tell you here, the disclaimer here is that it's a retrospective analysis. When we remember, we just got data from people with those with new onset diabetes and their drug patterns. That's how we have studied this. When physicians were prescribing, they did not know anything about SID, IROD, or SERD. They were just prescribing for type 2 diabetes. So from this, we know that in India, the commonest drug prescription for new onset diabetes is a combination of traditional drugs, the sulfonylurea and metformin. Although we talk so much about the newer drugs, it's quite surprising to see that still maximum, the cheapest and most efficacious drugs are sulfonylurea and metformin. Now, contrary to that, all guidelines say that we should first start with metformin. Are we doing that in a small percentage? But primarily metformin alone is not being given. We are giving in combination with sulfonylurea. Among the newer drugs, the ones that is being used is the DPP-4. So maybe it's because SGLT2 are still newer and they still have to go off patent and things. But this is the usage pattern which has been described and published. Now, the last part is to look at whether or not. So all the guidelines say that for any type 2 diabetes, metformin is the drug of choice. But among these clusters, are there drugs which are more efficacious than metformin? And should we prescribe maybe something else in subclusters and see which is the best drug to be given in the best cluster? And that is what this analysis is about. So metformin is here. We have shown you SID and SERD with both insulin deficient states. And in this, we see that metformin is given as reference. So obviously, insulin did the best here. These are insulin deficient states. So you can see what the numbers mean is that there is a 13% extra response over and above metformin in bringing down A1C in this category. So for SERD, you'll see it's 20%. So 20% extra response. So what this means, these are huge numbers. What this means is that perhaps in these two, early insulinization is the key, and giving insulin early. If you identify these two, remember these are also the ones that quickly progress into retinopathy and CKD. So giving insulin early aggressive treatment is possibly needed. In addition, you'll see sulfonylureas and DPP-4. So the secretagogues are also working well in these groups. Whereas if you look at the IROD as well as MARD, in MARD, you'll see that nothing actually is working better. Metformin is a very good drug. Similarly, even in IROD, the sensitizers are working better. Of course, insulin does have good effect in IROD as well. But you'll see that the sensitizers. So suffice to say that across the clusters, we do have differential drug responses. And we maybe should not be just blindly giving any drug to any cluster. It's possibly good where we see that in each cluster, which drug is responding well, where we have to start insulin, etc. So to do this in the primary care setting, we've developed this tool that's called Diana. What it does is that so you've just put in these variables, the 6 variables we had: age of onset, BMI, weight, A1C, triglyceride, HDL. If you have C-peptide, good, but you can also predict without the C-peptide, and you enter these values. The tool gives you a risk of what you're dealing with. For example, if you're dealing with SID or SERD, it will tell you. It will also tell you what is the risk of retinopathy, nephropathy, etc. And it will also tell you what is the best drug response in this category. So this is the tool that's been developed and will be good for primary care settings. So I'd like to summarize and say, for the first time in actually South Asia, clustering has been done in type 2 diabetes, and subclusters have been identified, 2 of which are similar to the Scandinavian clusters, but we have 2 new and unique clusters, and that's the IROD and the SERD. The SERD is of particular importance because it has difficult to treat hyperglycemia and increased risk of microvascular complications. In addition, we know that in India, traditional anti-hyperglycemic agents are still used widely, and identifying these phenotypes, giving drugs according to the phenotypic characteristics may be the first important step towards precision and personalized diabetes care in this country. However, RCTs are needed. Now, all of this is retrospective analysis, and thus they're confounded by the baseline A1C. So that is the biggest limitation of the study I showed you. And we do need large RCTs to confirm the differential drug responses between clusters. Thank you.
Thank you, Dr. Anjana, for a very well thought of study which you did. especially in the Indian population. I think this will be a game changer for the Indian treatment, if you can see. I will take up questions later on. But now let us proceed to the last speaker of this session, Dr. S.B. Madhu. He will be taking us through to a diabetes-related vascular complications in the pre-diabetes. Means we need to act fast before the onset of diabetes. So he will be highlighting us on this. So over to Dr. Madhu for his deliveries.
Thank you. Can you hear me? Let me share, share my slides. Can you see my slides?
Yeah, it's visible. You can enlarge them.
Right. Okay. So this talk is basically based on one of our recent papers where we looked at diabetes-related vascular complications in pre-diabetes. And as probably reported by a few earlier studies, we also found to our surprise that you do have a percentage of pre-diabetic individuals where what we traditionally attach to diabetes and long-term complications of diabetes were also found. And what could be the implications, what could be the possible reasons for this will be forming the course, the basic gist of my talk for the next 15 to 20 minutes. See, why do we think about pre-diabetes? This study, as we all know, it's a landmark study, the ICMR. What we see is while the prevalence of diabetes is 7.3%, what you can see below is that the overall prevalence of pre-diabetes in the nation is also 10.3% more than the pre-diabetes itself. And therefore, while we need to manage diabetes to prevent complications, there is a huge chunk of individuals who are pre-diabetic, traditionally are thought to only have a risk of conversion to diabetes and to some extent a risk of cardiovascular disease. But perhaps there's another reason why we need to bother about pre-diabetes. Let's see. If you go to the metros, and this was a study conducted in Delhi by us, we found that the pre-diabetic prevalence, depending on which criteria you use, was 21% or 39.5%, including IFG and IGT. So huge chunk of the population is pre-diabetic, in the metros in particular. And therefore, we do need to sit back and consider what could be the possible risk and what do we need to do at this stage itself rather than wait for diabetes to occur and then go on and on into its well-known complications. So this is just a slide to show you what we're traditionally worrying about. And probably we also need to worry about a higher risk of microvascular complications, as this talk will tell you. We've all been talking about ticking clock hypothesis, and this has been generally for macrovascular disease. And it has been traditionally believed that for microvascular complications, this is at onset of hyperglycemia, or rather at the onset of diabetes range hyperglycemia, which is being challenged by several studies across the globe. Now, looking at prevalence of complications in established or known type 2 diabetic patients, if you see, according to studies conducted in our country for the prevalence of complications, different studies, retinopathy ranges from 17 to 34%, nephropathy from 9 to 27%, neuropathy from 19 to 27%, coronary artery disease from 11.4 to 21.4%, and peripheral vascular disease from 6.3 to 28%, depending on which studies you're looking at. So you have a reasonable percentage of diabetic populations having one or the other of these complications. And this is summarized again in this slide beautifully, basically constructed by Mohan et al. And based on his study of cures, again showing basically that the cardiovascular disease is 20% or so. And if you come to retinopathy, nephropathy, again, it's about 20 to 25%. And neuropathy is closer to 20%. And PVD, as we all know, is much lower at 6.3%. So depending on which study you see, you have a fair range of complications about which we are all aware and for which we are treating our diabetic patients. If we go a little ahead and come to complications at diagnosis of diabetes, again, depending on the study that you look at, there is a range, and you can see that in this, depending on the three studies listed on the left column, the retinopathy could be ranging from, generally from 18 to 37, but one study, the HOON, shows only 1.9%, and neuropathy is 32 to 48%, Go to other studies, you have even a newly diagnosed patients of type 2 diabetes, a fair number of them already having complications, as you can see here. Retinopathy 13%, neuropathy 4%, ISD, of course, pretty high, and PVD is pretty high in this particular group. And see, so this group probably has more of macrovascular disease, but the fact remains that 33% had complications at diagnosis. And this is another study showing that newly diagnosed diabetes having a fair amount of complications and even dyslipidemia and macrovascular risk factors to the tune of 58 to 73%. And this was our own study from Dr. Arvind, the CINDI as it is called, where they showed that in newly detected diabetes, again, you have overall neuropathy 13.15%, retinopathy 6.1%, nephropathy already in 1%, and a fair number of them, over 25% or more of risk factors for you have all these complications, but the argument could well be that they were all diabetic, were not detected till they came up with complications, and therefore do not know whether this is before the onset of diabetes range hyperglycemia, or actually they were silent, they were already diabetic, and maybe even at diagnosis, they already had the complications which actually brought them to the physician. So that argument still held. And therefore, we need to look at prediabetes to answer some of these questions, whether even before the diabetes range hyperglycemia occurs, do we have a prevalence, a fair prevalence of diabetes-related vascular complications? This was one of the Australian diabetes study, first in 2002, who actually suggested that probably a pre-diabetic state also has an increased risk of microvascular complications, microalbuminuria, besides an increase for cancer. And therefore, pre-diabetes is an important concept that needs to be understood and identified even from this point of view. And now let's focus on the study that we did. This is a very recent study where we've looked at prevalence of diabetes-related vascular complications in subjects with normal glucose tolerance, pre-diabetes, newly detected diabetes, and known diabetes, and compared them. Basically, we needed about 72 cases of each of these groups, and for that we had to do about 1,300 OGTTs. And from there, we got newly detected diabetes, pre-diabetes, about half of them, and normal glucose tolerance, 657 of them. And then we took 72 NEDMs, matched them with age and sex with pre-diabetes and NGTs, and also took 80 age-sex matched known diabetes from our clinic and screened all of them for micro and macrovascular complications. And this was how we diagnosed the complications. CAD was based only on ECG or history, CV on the basis of history, PVD on the basis of ankle-brachial index, retinopathy on the basis of a fundus examination by a qualified ophthalmologist who saw all the patients, the same ophthalmologist, and nephropathy by the urine ACR, confirmed as per protocol, and neuropathy on the basis of NSS or NDS scores. And their baseline characteristics, they were matched for age and sex, but it so happened that their BMIs were more or less matched. They were not different in all these groups in the patients recruited. And the waist, except for the males, where the pre-diabetic NGTs were lower than the pre-diabetic NDDMs, the wastes also happened to be not different from each other. This is the key slide, prevalence of diabetes-related vascular complications. As you could see, if you were to go from here, we have 6.3% showing macrovascular complications, but you also have 4.2% and 4.2%, although the numbers are low, but these were, the study size was calculated as per sample size calculations. So you have 4.2% of macrovascular complications, of which major part was for CAD, to some extent PVD. All in all, the complications of macrovascular disease in all the groups put together about 11 cases, 3.7% on an average. Coming to microvascular complications, again, starting with the known diabetes, you had them in 17.6% in this study in particular. You also had them in about nearly 10% of newly detected diabetes, and also nearly 7% of pre-diabetes, and about 1% could be even chance of in NGTs. But what is important to know is you have a fair number of pre-diabetics, almost having similar prevalence rates of complications as a newly detected diabetic has. And if you go down these columns, you find the nephropathy was also there among the microvascular. Neuropathy is also there as part of the microvascular complications. And you also had, of course, prevalence of cardiometabolic risk factors in a fair number in all the groups, even the pre-diabetic groups and some of the NGTs as well. Not unexpected, because we are in any case a population which has predisposing factors to CAD and diabetes anyway. So you could find that in a pre-diabetes alone, hypertension was seen in 8.3% of the patients studied. Triglycerides was high in nearly 1/4, low HDL in almost 90%, and LDL cholesterol was high in 41%. Despite the fact that there were low number of smokers, overall the metabolic syndrome was also fairly high. And if you go by the metabolic syndrome features, even in the pre-diabetic group, you find that there were 3 metabolic features in 35 out of 72 and 2 metabolic syndrome features in 25 out of 72. So again, the risk factor profile wise, especially for coronary artery disease, you have a fair number of them. So what did we find in summary? Study found that vascular complications related to diabetes were present in over 10% of subjects with pre-diabetes. Macrovascular in 7% and microvascular in 4% roughly. What is more important is the proportion of pre-diabetic subjects with vascular complications was about half of those with known diabetes, but almost similar to those with newly detected diabetes and with no gender differences. This is the key statement. So the pre-diabetics have complication rates similar to what we find in newly detected diabetes. It could mean that lower levels of dysglycemia may also lead to vascular complications. Over 90% of pre-diabetic subjects were also observed to have one or the other risk factor for macrovascular complications, as we would expect. And therefore, the additional burden of vascular complications in subjects with pre-diabetes highlights the importance of initiating effective preventive measures at the stage of pre-diabetes itself. So we cannot remain silent. Probably we need to be more aggressive in even treating the pre-diabetic state for all the risk of complications, including now the microvascular complications that it would have. And maybe it's time to rethink about our strategies of just non-pharmacological approaches while we address pre-diabetic states. Now, if you look at what is the global scenario and some of the studies which have reported such things earlier across the globe, people have reported retinopathy in prediabetes from 7.9 to 20%, nephropathy from 15.5 to 17.7%, is much more than what our study showed. Neuropathy in 13% of cases of IGT and 11.3% of IFG. This is the typical DPP study where, again, clearly it was shown that retinopathy is seen even in non-diabetics, particularly pre-diabetics. And in this particular study of incident retinopathy, again, even in glucose ranges, which are traditionally associated with pre-diabetic state, you find significant retinopathy. Prevalence of CKD also is found even in pre-diabetic states, as you can see here very clearly. And the association of retinopathy in albuminuria is a little different. There is a so-called cutoff effect for retinopathy after which it suddenly rises. But in the case of albuminuria, or let's say the diabetic-associated kidney disease type of a complication or microalbuminuria, the prevalence appears to be more, gradual, not a threshold type of an effect for a particular glucose value. Coming to the macrovascular disease, this is much more familiar ground. We're all aware of this slide. And we're also aware that in IGT, you have CAD, which is in the range of 14.9 to 24%, and in PVD in the range of 2.9 to 9%, depending on which study you're looking at. And therefore, this has been a traditionally known phenomenon. And the meta-analysis of 18 studies shows again that the risk of CVD is more even in IFG and IGT at 1.2 times. CDC data again shows that not only you have high levels of dyslipidemia, hypertension, microalbuminuria, and also smokers, so you have cardiovascular risk factors also prevalent in this group. So there's a spectrum of cardiometabolic disease, which is a known thing, and even across IGTs you find that these predispose to type 2 diabetes as well as cardiovascular disease. So what we've actually shown from our study and the global studies across the world prior to our studies is that you do have microvascular complications to some extent. And as we showed, almost to the extent that we see in newly detected diabetes, even in pre-diabetes. What could be the possible causes? One of our studies earlier in 2013 showed that there were abnormal glycemic profiles by CGMS in obese first-degree relatives of type 2 diabetes mellitus patients. If we look at the details of this study, it shows by using CGMS that 40% of centrally obese first-degree relatives of diabetic subjects diagnosed as pre-diabetes on the basis of OGTT showed significant glycemic excursion into the diabetic range. That means, although they were pre-diabetic in terms of an OGTT, actually, if you do a CGMS, you would find that 40% in case of IGT would show glucose excursions during a 24-hour period into the diabetic range, 35% if it was an IFG, and even 15% of NGTs would show excursions into the diabetic range in a 24-hour period. So a single OGTT may or may not, in this case, may not be picking up the glycemic burden in the diabetic range. That was the conclusion. And therefore, and in fact, I'm not showing it in this slide, but for fair amounts of time, this happened as you moved up this ladder. As you were from NGT and IFG and IGT and even IGT plus IFG, you found that increasing duration of the 24-hour period, patients were or subjects were in the diabetic range, hyperglycemia. And we also label them as CGMS diabetes. It is therefore also possible that there is significant diabetic range dysglycemia in some individuals with pre-diabetes that results in the development of diabetic vascular complications in them. So this could be one explanation. Factors that cause glucose fluctuations, of course, under free living conditions could be many, including food intake, exercise, stress, beta cell function, insulin sensitivity, and so on, which could cause these fluctuations from time to time and from day to day into the diabetic range in cases of pre-diabetic individuals, into the pre-diabetic range in case of NGT individuals, and so on. And therefore, observations of 24 glycemic variability in non-diabetic persons become relevant and probably also could be the basis of complications seen in this group. And considerable variability of glucose levels exists even among individuals classified as not having diabetes. And whether periods of transient hyperglycemia are part of normal variability or have the potential for complications, of course, is not clear, is possible, needs long-term studies to know the true impact. Another study of interest in this context is a study which we did on PPTG responses and endothelial dysfunction in pre-diabetic first-degree relatives of patients with diabetes, and showed that both postprandial endothelial dysfunction actually increases as we move from NGT, which is group 1, to pre-diabetes without a family history of diabetes group 2, to pre-diabetes who also have a family history of diabetes group 3. So suggesting that even in pre-diabetes, you have endothelial dysfunction incrementally occurring if there's more risk. And this could affect not only large vessels, but also smaller vessels, because it's after all an endothelial dysfunction. And therefore, this may contribute to enhanced cardiovascular and long-term complication risk reported in pre-diabetic individuals. This could be another explanation. And this study, again, experimental biology 2016, showed that pre-diabetes has a toxic environment for initiation of microvascular and macrovascular complications. They explored the role of glycemia in the development, and actually it's shown that these 4 elements, which are traditionally ascribed to diabetes, increased lipolysis, insulin resistance, impaired secretion, dysregulated hepatic glucose production, also is seen to a large extent in a pre-diabetic individual, and therefore the environment for the production or the generation of complications exists in a pre-diabetic individual. And therefore, pre-diabetic risk for micro and microvascular complications is real. So apart from the risk of type 2 diabetes mellitus and cardiovascular disease and cerebrovascular disease in a pre-diabetic individual, and of course peripheral vascular disease, I think we also need to consider a real risk of microvascular complications, which include retinopathy, neuropathy, microalbuminuria, that is kidney disease, and nephropathy. So we must become aware that a pre-diabetic state can also lead to these complications, and therefore we need to start our preventive measures right at the level of pre-diabetes, whether it is aggressive treatment, whether it is aggressive lifestyle intervention, or specific interventions to prevent complications, I think the time to begin this exercise in whatever manner probably would be the pre-diabetic state itself. And we need to focus on this. Thank you very much.
Thank you, Dr. Madhu, for a very well thought lecture. And in fact, I think this will be a beginning for a change in the treatment of diabetes. In fact, what we are following is a common soil hypothesis, which says that yes, diabetes is not only sugar, the blood pressure, the lipids, the lifestyle, everything matters. And what we have highlighted is again the same thing which highlights that we need to act from the womb only. The moment the baby comes into the mother's womb, it is time to act. Because it has been seen that the atheroma development takes place as early as 10, 12 years in an obese child. So we need to change our focus. Means the treatment which we are following as of now is we allow the diabetes to develop and then we act. But I think now the time has come where we should shift our focus to the younger generation so that the treatment, the prevention aspect comes into play. So what do you say about the future change in the treatment modalities, keeping your findings in view, Dr. Madhu?
I think what we need to actually do again is confirm all this in long-term randomized, long-term prospective studies and show actually that, the complication rates are increasing, and by intervening at a pre-diabetic state, you are able to make a dent in the evolution of these complications, and that would set the stage finally for real evidence to start more aggressive interventional approaches in the pre-diabetic state itself. At the moment, it's making us aware of this possibility, making us think to change our strategy, and do a more focused probably intervention study at this stage and look at how much it can affect the long-term complications. Maybe the follow-up may have to be into the diabetic range. It may not be that the complication you stop once the diabetes occurred. You start following the incidence of complications into the diabetic range hyperglycemia as the patient evolves into diabetes, and see in the long term how much, by acting at this stage, how effectively you can prevent the long-term complications even after the diabetes is actually unmasked. And that would actually give the evidence.
Yeah, that's perfectly right. And I think both the micro and the macrovascular complications needs to be taken well care of, because ultimately is where we are all lacking because of dysglycemia and all. So now coming on to Dr. Kamlesh Tiwari, he dealt us on...
Dr. Madhu, can I ask you
a sure.
question? Yeah. Can I ask Dr. Madhu a question?
Yes.
Hi, it was an excellent lecture. But some time back, I had reviewed and given a lecture on similar pre-diabetes and cardiovascular risk. The question that I want to ask you is that, given the fact that we see so much in pre-diabetes, micro and macrovascular complications, but yet we don't screening for them in asymptomatic or at a low risk people, we should start screening for cardiovascular disease, asymptomatic cardiovascular disease much earlier from a clinical perspective? Given the the data that we've got, would it make more sense that we should, let's say, something like a screening for cardiovascular risk much earlier on? Should we be doing that much earlier on in a course rather than wait on it?
Okay, I'm not sure I can answer that question based on this study, because even in diabetic individuals, for asymptomatic patients, the recommendation of universal screening, people have two schools of thought. Even once the patient has become a diabetic, whether you should screen everybody who's a diabetic for cardiovascular disease if he's asymptomatic or not. Even there, so to think of it in a pre-diabetic individual would be taking it one step even more further. What is probably more important is, more than the screening part, I would think that this information immediately would at least should let us change our focus on how we look at pre-diabetes and how we normally tend to be, let's say, a conventional laid-back approach while treating a pre-diabetic. We say, okay, you're likely to become diabetic, so it's fine. Just do some exercise and diet, and that's okay, and we forget about the patient. I think we should be far more aggressive in monitoring this patient, in advising this patient, and make him understand that this is one end of a continuum which requires aggressive treatment, even if it's not very strict pharmacological treatment. At least it should be quite aggressive in our lifestyle approaches, even pre-diabetic individuals, not wait for the diabetic state. I think that is important. And even not wait for a pharmacological approach too long. If your lifestyles don't work, then go ahead and give the pharmacological approaches. I think these two things are something which immediately comes to mind, even in the absence of long-term studies. But to propose a universal screening will be, at the moment, probably not cost effective. That's what I believe. But yes, more aggressively managing pre-diabetes, more intensively focusing on lifestyle, early initiation of pharmacological if there is no response. These probably pointers to these three things would be a clinical message.
In fact,
So
yes, sir.
Brings me to my next question: that do you think that we should change our algorithms to start combination therapies in pre-diabetes rather than go in a stepwise manner of, metformin and then next kind of a thing? So is it time now to change our algorithms, including the RSSD algorithms, to say that we should start early combination therapies?
For that, we would require, studies, intervention studies to show that they actually help. What I've projected is the fact that it can help. The fact that, these things are really
show that, aggressive.
So we need to do at least take up studies
in terms of CVOT trials that it helps.
Yeah, I think
so.
We
What
should
prevents us
start
from
off with
using early
studies.
Combination therapy?
I think we should start off with studies with pharmacological therapy or other forms of aggressive treatment in pre-diabetes much more often, and not only look at, the only endpoint so far has been incident diabetes. I think we should look at we should plan studies focusing on a long-term outcome of diabetes-related vascular complications. Even if the patient becomes diabetic along the way, so it be. Our endpoint should be diabetic complications, even if as the patient becomes diabetic, let's say after 2 years down the line, after 10 years or after 6 years or whatever the period required. If by starting treatment early in pre-diabetes, you can prevent complications or reduce the risk of complications even 5-6 years later, regardless of whether it became diabetic or not. That would be the kind of study that will help us, clearly tell that you need to attack them right at the pre-diabetic stage. Those studies.
What I want to say is that lifestyle modification which we follow is effective for at most 6 months in the beginning, and then the effect wanes off, as has been seen in many trials also. So doesn't we need to change what Dr. Sanjay Agarwal has rightly pointed out, that we need to be more vigorous and we need to treat the patient from the pre-diabetic stage only, because lifestyle alone we know is a failure.
I fully agree. This possibility is definitely there, and that's the whole idea of this study. But I will not be able to tell you based on my study that actually giving that treatment early works and it is useful. That is the only thing I'm saying. Perfectly fine.
Time for change has come, I think, sir.
Time for change has come. At least we should immediately start planning studies, intervention studies to look at these outcomes.
Definitely, sir. That's a point which should be taken well care of, and our bodies should now focus on this, so that we need to be more vigorous in our approach, and we should not, in fact, wait till the patient develops pre-diabetes. We must act before. So now coming on, sir, any other questions, Dr. Agarwal? Yeah, Dr. We have another very good speaker today, Dr. R.M. Anjana.
Thank you so much. Thank you.
Yeah. We have another very good topic today, which was discussed by Dr. Anjana, and she gave us the various clusters of diabetes which we found in the Indian population. So, madam, don't you think that again the same thing within the Indian diabetes, what we see is the insulin defect or the secretory defect which or the beta cell defect which is very prominent, and the same thing has been highlighted by your study. That means we are having more of beta cell defects, and beta cell defect starts early in our diabetes. So again, doesn't this mean that we change our treatment for diabetes for the Indian population accordingly?
So thank you very much, sir. I think that's why I had my hand up. I just wanted to say a couple of things. The first was, sir, to Madhu sir's and Sanjay Agarwal sir's question. I very much agree with Madhu sir, because when you start looking at pre-diabetes and start, looking at screening for cardiovascular complications, one also has to take into account patient acceptability. Cost is one thing, but patient acceptability, even after they become diabetic, when you tell them, do screening for this, screening for that, they're asking, unnecessary test for what, for whom, kind of questions are coming. So similarly, even when you look at treatment paradigms, if you start combination therapy in a pre-diabetic, before even one has to also look at how we're going to explain this to a patient. The Origin study showed that glargine was good, isn't it? but how are we going to give patients insulin even before they develop diabetes? So these are the questions. And I completely agree, sir, that the RCT is what is going to take us forward. So even for those with diabetes in the subclusters, the question is, should we start insulin early? Early evidence does show, from what I showed in the study that we published, yes, there are differential responses to drugs. And yes, it looks like we are going to have to change treatment paradigms according to which subcluster is coming and who needs more aggressive therapy, etc. However, sir, we can't make definitive changes until an RCT is done. And now that is the next step that we are doing. We are funded for an RCT to go ahead and look at the subclusters, to look at drug responses within the subclusters. And once we have that, then we can say definitively which guideline change is needed and what is the evidence for that.
Thank you, Dr. Anjana. In fact, you told about the Diana, is it available in some apps or means you're just
yes.
it
is
in
a
the...
web app, sir. It is a web app. It's not yet, unfortunately, available. It should be available very soon.
Yeah. And another point I just want to ask you, what technique you followed for C-peptide stimulation?
Oh, so it is a normal standard. We didn't do the glucagon stimulation. We just did a normal standard breakfast, sir.
Thank you. I think we are running short of time. Otherwise, the topics were so beautiful that we could have talked about it for hours, and it was really interesting. But time is not allowing us to proceed further. So I think we must thank the speakers who did a very wonderful job in today's this session. And thank you, RSSDI. Thank you, everyone, for bringing us together and discussing this wonderful topic. Thank you. Thanks,
Thank
everyone.
you. Thank you.
Thank you.
Hello. Manisha ma'am.
Yes, hello.
Yes, ma'am. Shall we start the session?
Yeah, I'm here. So we don't have to do anything, na? Do we have to introduce someone? The
Yes,
speaker?
you have to introduce the speakers.
Okay.
Okay. So shall we start?
Okay. So I can introduce to Mr. Samar Banerjee.
Yes.
Okay. Can you hear me?
Yes, ma'am. Start.
Okay. So what time do we start?
Yes, ma'am. Start कीजिए.
Huh?
Yes, start कीजिए.
So can I start now?
Yes.
Okay. So good evening, friends. Today we are going to have this session, and the first speaker is Dr. Samar Banerjee. I am privileged to introduce him. Dr. Banerjee is one of the experts in diabetes with super specialization in GDM. He has a glorious tenure in Neel Ratan Sarkar Medical College, Kolkata. He is rendering praiseworthy experience to medical students in Vivekanand Institute of Medical Sciences. He is one of the founder members of Diabetes in Pregnancy Study Group in India. He held a number of prestigious positions like chairman of the Association of Physicians of India and most recently the president of RSSDI. So I would like to invite Dr. Samar Banerjee to deliver his talk. Dr. Banerjee.
Please allow me to share the screen. Please allow me to share the screen.
Yes, sir.
I think my screen is visible.
Yes, it is visible. Yes, yeah.
Okay. Thank you, madam, for introducing my biodata. I can claim I am the first person until the last person to write a book on pregnancy diabetes. I have written other 9 books also, which are all available in the market.
Great, sir.
I'm going to discuss some salient points, some debatable points that are the role of metformin in gestational diabetes mellitus. Because of rapidly growing population of women diagnosed with GDM, approximating 1 in 7 pregnancies globally, the popularity of using an oral agent such as metformin is expanding enormously in conjunction with the rising cost of the insulin, lack of affordability and infrastructure to use insulin. I am not against using insulin, but we are always searching for any cheaper and easily administrable method. In fact, a number of organizations like Society of Maternal Fetal Medicine, NICE, FIGO, Diabetes Canada, DIPSI, all have supported its use as an alternative to insulin. However, recent long-term studies on offspring have provided conflicting results, with 2 of 3 studies recently published on 4 to 9-year-old children of mothers with GDM or PCOS, which suggests some long-term metabolic programming effects on the offspring, and I'm unfortunate that ADA has gone against the use of the metformin. This has given some clinical investigators and organizations pause in embracing metformin is like equivalent to insulin. Let me audit about the biomechanism of the metformin. Transplacental passage of metformin can pass the placenta from maternal to fetal circulation, likely via the organic cation transporters. Therapeutic doses, short-acting up to 500 to 2,500 and long-acting 2,000. And common clinical settings, pre-gestational diabetes, gestational diabetes, and polycystic ovary syndrome, which is very important because in majority of the cases, if metformin is stopped, also data there will be abortion. It is becoming very popular agent in insulin resistance before and during pregnancy. And you know that GTN is a manifestation of insulin resistance, which is only tackled by metformin, not by the insulin itself. So if you treat with insulin, future development of obesity, hypertension, coronary artery disease, and diabetes features of insulin resistance will be same. The concentration in the umbilical cord is similar or even higher than concentration in maternal blood. Fetus is exposed to at least half of the same concentration of metformin in maternal plasma. But keep it in mind, any drug which is passing through the placenta do not mean that it will be fetotoxic. In a short-term study, there is an abundance of evidence that metformin has a safe track record and may have some benefits compared with insulin or glyburide when used for the treatment of GDM. Metformin is not teratogenic, with reassuring data for use in the first trimester even. In several meta-analyses, women with GDM randomized to metformin, often used with insulin, of course, had less gestational weight gain, less gestational hypertension, and fewer infants who were large for gestational age or with macrosomia above near 4,000 grams, and their infants had less neonatal hypoglycemia than those randomized to insulin or glibenclamide. However, metformin has a failure rate, and 46% of patients they needed insulin, particularly in cases of the pre-gestational diabetes. Unlike insulin, metformin does not reduce maternal triglyceride, a substrate for fetal fat accretion that was related to fetal growth in the MIG trial, and it should not be used if the fetus is at risk for ischemic environment like placental insufficiency, gross hypertension, preeclampsia, or growth retardation. Metformin may, in part, prevent the development of preeclampsia potentially by improving angiogenesis or suppressing the inflammatory markers. Currently, metformin is being studied in 2 RCTs for final answers. One of them is metformin in pregnancy study. Another is medical optimization of management of type 2 diabetes complicating pregnancy moms, for which you'll have to wait for a few years, to which you will determine if the addition of metformin to insulin in this population can reduce adverse neonatal outcome as well as lower maternal insulin doses and fetal weight gain. Regarding long-term outcomes in offspring exposed to metformin, there are limited data. I mean, MIG trial has followed up to 9 years. They will follow longer. We have data up to 9 years. Then this MIG trial, where 75,000 women with GDM received either metformin or insulin during pregnancy and reported on 2-year and 7 to 9 year offspring outcome. At 2 years of age, the 318 offspring in the MIG trial, evidence of higher subcutaneous fat, but there is no difference in total fat mass in a subset. There is no increase in visceral fat, which is a marker of insulin resistance. No difference in neurodevelopmental outcome. At 7 to 9 years of age, 28% of the original cohort were assessed. There are no difference in the total cohort. And it is seen that though in the 2-year follow-up, some extra subcutaneous fat is there, the diabetogenic fat, the intraabdominal fat is not high. But this study different between the 2 centers results, Adelaide and Auckland. In the Adelaide study, had higher rate of large for gestational age compared with those exposed to insulin alone, and their mothers had higher fasting glucose level during pregnancy, suggesting poor glycemic control in utero. So probably the problem with the fetus may be due to uncontrolled blood sugar in the mother. At 7 years, the Adelaide subgroup showed no difference of offspring weight or body composition. But for the Auckland subgroup, no difference in large for gestational age rates for metformin or insulin at birth. At 9 years, the metformin group were heavier, had higher arm and waist circumference, had higher waist hip ratio, and they trended toward a higher BMI, tricep skin thickness, and abdominal fat volume by MRI. But there is no difference in glucose, lipids, insulin resistance, or liver function test in either group. The children at 2 years of age has a larger skin fold, I just mentioned, although fat mass and body fat percentage assessed by the bioimpedance and DEXA are not different. So total body fat or intra-abdominal fat was not higher. No difference in blood pressure and neurodevelopment test. At 9 years, the metformin exposed children had larger waist circumference, waist height ratio, BMI, and tricep skin fold. Increasingly, fat mass evaluated by DEXA and MRI, including intra-abdominal, tends to be higher in the metformin compared to the insulin group, suggesting a higher risk for development of metabolic syndrome, but with comparable biochemical parameters. But the interpretation of the results are very difficult, given the limitations in follow-up. Potential differences in glycemic control. All the mothers were not in the same A1C control. Use of insulin in 46% of the total cohort. And unknown postnatal effects that can markedly influence obesity risk in children. What might be the mechanism by which metformin could result in a programming effect that later increases the risk for higher offspring weight is not clear to us. Outside of pregnancy, metformin has been shown to lower body weight. It has got anti-cancer effects. That means it's proliferate excess cell proliferation. It has got growth inhibitory property and beta cell and gluconeogenic effects, and also to suppress mitochondrial respiration, which all reflects that metformin should not increase the body weight. On the other hand, a recently published large population-based cohort study of 1,996 GDM with on metformin and 1,932 on insulin showed no difference in weight for heights get scored, though the total numbers are less than the mixed trial, but these are not negligible. These are all near 2,000 each group, and no risk of overweight also. Further, there are no difference in behavioral assessment in offspring at 4 years of age. After adjustment of maternal age, race, ethnicity, socioeconomic status, BMI, smoking, history of GDM, and timing of GDM diagnosis and treatment, there is no difference between the metformin and insulin receivers. Metformin may be particularly useful in women at high risk for hypo who are developing very quick hypo or very frequent hypo with insulin, who want to limit maternal weight gain, or with an inability to afford or use insulin safely, especially in those with mild hyperglycemia. The current science is reassuring in the use of metformin for mild GDM with respect to short-term pregnancy outcome. Fundamentally, inadequately controlled hyperglycemia, significant maternal hypo, and the inability to afford and safely use treatment pose even greater risk to both mother and baby. When insulin cannot be used, at least metformin should be given as recommended by WHO. In a cohort of 50,167 babies affected by congenital anomaly, no evidence of an overall increased risk of all major congenital anomalies combined after exposure to metformin during the first trimester was seen. So 50,167 with congenital anomaly, no effect of metformin was seen. A signal for increased risk of pulmonary valve atresia was seen, but this was a chance finding and very rare. Metformin given to obese and severely obese pregnant women. These are all MPOT study was on non-pregnant obese lady. Start without diabetes from 12 to 16 week gestation until delivery, had no effect on birth weight or neonatal or maternal anthropometry. The metformin associated reduction in inflammatory markers of CRP and IL-6, interleukin 6, showed beneficial effect on the adverse outcomes such as preterm birth and preeclampsia. So, obesity, non-diabetic on metformin, less preterm birth, less preeclampsia might have a beneficial effect on future life risk of obesity and metabolic syndrome of the offspring. The mixed tofu trial, again I repeat, offspring of GDM randomized to metformin or insulin followed after 7 to 9 years. And I've just discussed that fasting glucose, triglyceride, insulin resistance, glycosylated cholesterol, liver enzymes, leptin, and adiponectin were all similar between insulin and non-insulin in the group. Finally, a meta-analysis in another study compared the testicular size in pre-pubertal born to mothers participating in RCT. No difference in testicular size between insulin and the metformin group. A meta-analysis showed that children exposed in utero to metformin are heavier than controls, although the BMI Z-scores are comparable between the groups. In the METIS trial, which is just published in 2020, metformin in women with type 2, documented that women who took metformin during pregnancy for controlling their blood glucose experienced benefits like reduced weight gain, reduced insulin dose, and fewer large for gestational age babies. They had significantly lower last A1C level in pregnancy at 5.9% versus 6.1% in those given placebo, and needed fewer insulin doses at 1.1 versus 1.5 units kg, which equals to reduction of almost up to 44 units per day, and all the side effects of insulin are minimized by adding metformin. On metformin, less number of cesarean section, no difference between groups in terms of gestational hypertension or preeclampsia in rates of pregnancy, preterm birth, birth injury, respiratory distress, and congenital anomaly. Women receiving metformin were also less likely to have a macrosomic baby with a birth weight of 4 grams. But the drug is also associated with increased risk for small for gestational age, raising the question as to risk versus benefit of metformin for the health of the offspring. So METI trial stood in favor of metformin use. So METI KID study has been initiated to follow the offspring in the METI trial to determine whether there is any problem in the up to 2 years of age. In fact, METI trial offered us prospective control evidence to support the low-cost, potentially beneficial metabolical effects of which insulin is the management of pregnancy. It is true that insulin is the standard treatment, but sometimes you need to add metformin lower dose of insulin, and sometimes we cannot use insulin for infrastructures or monetary reasons, but they lead to less weight gain when insulin is replaced by metformin or combined, lower cost, and compliance is higher. So metformin is the only drug which can ameliorate the insulin resistance and prevent its complication both during and after pregnancy. In another study, metformin was started before pregnancy simply for PCOS. If the person had diabetes, for most people it should be continued except in cases of chances of intrauterine growth retardation. And the author, Peak, commented that on balance, she would be inclined to give metformin to most pregnant women with type 2 diabetes, perhaps with the exception of those who may have risk factors for small for gestational age, who have intrauterine growth restrictions, smokers, significant renal disease, have a lower BMI. PCOS and pregnancy, Palomaba et al. Found a 3 to 4-fold increase in pregnancy-induced hypertension and preeclampsia, 3-fold increase in GDM, and 2-fold higher chances for premature delivery among PCOS. Women with PCOS has shown placental inflammation, placental thrombosis, and infarction. It has been reported. Then 18.7% incidence of miscarriage in non-treated PCOS women, but it is 10% those who received metformin up to 32 weeks gestation and 0% who received metformin throughout the pregnancy. So this proves the efficacy of the metformin in pregnancy. If you don't use PCOS, 18.7% miscarriage, 10% when used up to 32, and throughout there is near 0%. A meta-analysis reports that in 5 out of 7 studies analyzed, metformin reduces the development of GDM in pregnant women. Venki et al. In RCT, no effect of metformin on the prevalence of GDM and preeclampsia, a significant reduction in the preterm delivery. A second RCT from the same group reported a reduction in the risk of late miscarriage and preterm birth weight with no difference in the prevalence of the gestational diabetes. Another study showed prevalence of GDM drops from 36% to 14% with the metformin. Here, metformin was used before pregnancy. In a cohort of 166 polycystic ovary pregnancy, there is a significant reduction in miscarriage, and metformin helped pregnancy loss rate to drop to 10.8% from a rate of 42.2% where metformin was not used. It is a case of metformin therapy on maternal neonatal outcome. 104% not control on medical nutrition therapy. Average weight gain during pregnancy 6 to 10 gram. Glycemic control with metformin achieved in 96.2%. No serious side effects. Mean birth weight near normal 2,972 gram. No congenital anomaly. Neonatal hypo very insignificant 3.8%. And metformin is clinically effective, inexpensive, and safe drug for treating gestational diabetes. Meta-analysis of 5 RCTs involving 1,270 patients. The conclusion of the study is metformin is comparable with insulin in glycemic control and neonatal outcome. It might be more suitable for women with GDM than PGD. Another meta-analysis showed lower gestational weight gain and modest reduced risk of preeclampsia with metformin. Clear evidence of benefit limited to reduction of gestational weight gain, and metformin which can inhibit food intake by increased concentration of growth and differentiation factor 15 may not lead to higher weight gain. Glycemic control and neonatal outcome in women, they have compared. This is the latest study published in BMC 2021 August. They have compared between glyburide, metformin, and insulin. The final conclusion is the present meta-analysis suggests that metformin may be as effective as insulin for glycemic control and is the most promising drug for the prevention of neonatal and maternal complication. And now, one study has combined metformin with aspart, effectively control blood glucose and blood pressure level, reduces the risk of adverse effects, perinatal and neonatal, and positive effects in clinical treatment. So now the comment has been published very fantastically by Romero that metformin is probably the aspirin of the 21st century. In this trial, metformin administration in early pregnancy did not reduce the frequency of the large for gestational age infants, but it decreased the frequency of preeclampsia. This is a different curve I am showing. This first one is for the changes in the fasting insulin and HOMA, where metformin in pregnancy has been compared in placebo. Second one is for the change in HOMA-IR between metformin and placebo group. And third one is the changes for the inflammatory markers. That this is about the C-reactive protein and metformin in beneficial for improving the insulin resistance, for improving the inflammatory markers also. This is all theoretical. Let me come to the what is the association guideline. Unfortunately, up to 2020, AD was allowing metformin, but in 2021, based on few results, that insulin is preferred. Metformin and glyburide should not be used as first-line agent. Other oral and non-insulin injectable glucose-lowering medication like long-term safety data. Metformin, when used to treat polycystic syndrome and induce ovulation, should be discontinued by the end of the first trimester. And oral agent may be alternative in these women after a discussion of the known risk and the need for more long-term safety data and offspring. Final message, the skeptical about metformin. But what about the Chinese Society of Obstetrics who need large doses of insulin or those refused to insulin? Metformin is better than glyburide. Regarding the Society for Maternal Fetal Medicine, reasonable and safe first-line drug is metformin. International Federation of Gynecology and Obstetric Initiation, metformin plus insulin when required performs slightly better than insulin. American College of Obstetrics and Gynecologists, insulin is the first line of drug. Metformin is a reasonable alternative choice. Diabetes in Pregnancy Endocrine Society, metformin therapy be used for glycemic control for those women with gestational diabetes who do not have satisfactory glycemic control despite medical nutrition, who refuse or cannot insulin or glyburide and are not in the first trimester. Breastfeeding women with overt diabetes successfully using metformin therapy during pregnancy should continue to use. So during lactation, according to the Endocrine Society, is safe. Our Indian DIPSI guideline, Metformin or insulin therapy is accepted medical management of pregnant women with GDM, not controlled with MNT, but insulin is the first drug of choice. Insulin can be started any time during pregnancy. The starting dose of metformin is 500 milligram. With the global increase in the diabetes among reproductive age women, it is anticipated that the use of metformin is likely to increase as metformin reduces insulin resistance and has the potential to lower the risk of insulin GDM PCOS mother. Its role appears truly encouraging. So DIPS is advocating a must use in PCOS. According to ADA, when used to treat PCOS and induce ovulation, metformin need not to be continued. But it has been confirmed, but Indian perspective is in contrast. It is indifferent. In Indian populations, incidence of PCOS is more and abortion chances is more. If you stop metformin, there are the higher degree of abortion. I have shown by data. Most of the obstetricians in India prefer metformin for its use. And these metformin may be safe, as effective as oral hypoglycemic agent, not associated with increased adverse pregnancy outcome. And finally, Government of India, the national guideline, has also endorsed the use of metformin in pregnancy, but they have endorsed from the second trimester because of lack of data in the first trimester. AAC, American Association Clinical Endocrinologist, supports the metformin in GDM. FOXY, our Indian Gynecology Society, they also support the use of insulin. Diabetes in pregnancy management, nice guideline. Use metformin as an adjunct or alternative to insulin in the pre-conception, and where required, you can use add insulin. IDF recommendation, International Diabetic Federation, metformin is safe in pregnancy. Metformin may be used if insulin is not available, not practical or refused. Then the recommendation from American College of Gynecologists, metformin can be considered for glycemic control in women with GDM. So it is the final point in favor of using metformin in GDM or pregnancy. There are 12 recommendations I have seen, I have shown, and only against is ADA 2021. But what I like to place before you, Indian population has got more insulin resistance. Metformin is the only drug which controls the insulin resistance. Affordability, use of insulin is not at rampant. According to the Government of India guideline, you can use from the second trimester. But what we are practicing in cases of polycystic ovary, we don't stop insulin in the metformin in the first trimester at least. If there is no problem, we continue. So in summary, GDM is a common medical problem, results from insulin resistance as well as impairment in insulin secretion. GDM is associated with a variety of maternal fetal complications, which may control some of them, and majority are improved by metformin, like gestational hypertension, preterm delivery, preeclampsia, which are the causes of death of the fetus. Management includes control of maternal glycemia with MNT, close monitoring of blood glucose, treatment with insulin and metformin. Finally, I like to know, there are some people who are very high nose, who always mimic the USA criteria. I say India is not USA. Metformin is very useful for Indian women for high insulin resistance and resource limitation. And I got the very interesting quotation that probably metformin can ask us, am I a fountain supplying you drinking water for your life, or a drain? Am I giving life or sucking it dry? Why unnecessary metformin is being claimed? I think this is a very cheaper drug. No company's project is, there is no stimulus for using metformin. For insulin and costly drugs, there is no so many stimulus. So my stimulus, thanks to all who taught me GDM, these are all my successful patients. In all of them, I used metformin. They are very happy, they are children. And also pay my regards to mentor, Professor V. Sesaya, who is the father of the pregnancy diabetes. Thank you for your patient hearing.
Thank you, Dr. Samar Banerjee. Very, very lucid presentation. And you have clearly, as I mentioned, that metformin is there to stay, especially in India. We are going to use it time and again and every time, I think, in all the patients. And yes, metformin is important in India. And we don't have so many resources and sugar monitoring and all those things. And if why not, if it is working so well? You have shown so many studies, and really they have shown that it has worked very well. So I don't think there is any doubt now about using metformin, starting from the PCOD and even pre-gestational state and using it throughout the pregnancy. Thank you so much.
Thank you.
So we'll move to the next speaker. Are we going to take any questions, or at the end of the session we are going to take?
Madam, if you allow me, I have got a program. It will be very beneficial if there be any question for me. I have another program at 6:30. So for me,
sure.
if you allow the questions now. For me only. With due permission from Anand Moses.
I think sir, there are no questions right now.
Okay, thank you. See you, Anand.
Yes, sir.
15 minutes.
So who is going to introduce Dr. Anand Moses? Do I introduce?
Yes, you can, please.
So now we are presenting our second speaker. He is Dr. Anand Moses. He is a senior consultant diabetologist, emeritus professor, the Tamil Nadu Dr. MGR Medical University, former director and HOD Institute of Diabetology, Madras Medical College, Chennai. He was the organizing secretary of RSSDI in 2012, chairman RSSDI Tamil Nadu chapter, member postgraduate board of studies and former member of the Senate and the Tamil Nadu and Dr. MGR Medical University, and is the member of National RSSDI. Now I request Dr. Anand Moses to present his talk.
Yes, so my talk is on some of the controversies with metformin. I think I can share my screen now. Yes, sir. At the outset, let me thank the organizers for giving me this opportunity on controversies with metformin, a review of the controversies. Actually, metformin is supposed to be the most non-controversial and a mild drug, as the previous speaker has said. But let's just look into it. So let us look at the journey of metformin. It is considered as a favorite initial treatment in most of the guidelines. If you look at all the international guidelines, most of the international guidelines will say, after with the lifestyle modification, metformin is a first-line therapy unless there is a contraindication for metformin. The advantage of using metformin, it can be combined with any drug. It's weight neutral. It is effective in reducing HbA1c. And like the UKPDS study has shown that there are some cardiovascular benefits of using metformin. The ADA has also allowed use of metformin to prevent progression of pre-diabetes. So people with pre-diabetes who are overweight, over the age of 60, people with history of gestational diabetes, you can use metformin as a drug to prevent diabetes. So where is the controversy? There are controversies in the use of metformin. In many of the physicians' mind, they say it used to be said that metformin is bad for the kidneys. 2-3 decades ago, it was propaganda that metformin use in mild renal failure can cause lactic acidosis, which is a dangerous complication. So even at the slight of microalbuminuria or macroalbuminuria, physicians were in the habit of stopping. But now, a number of studies have come through, and in 2016, patients with higher creatinine levels were advised until 2016 were not used. But after that, there were a number of guidelines now issued by the ADA and other guidelines saying that it is quite safe to use metformin up to eGFR of 45 or even 30 if the patient is already using metformin. The only caution they said was, don't initiate metformin when the eGFR is low. But if the patient is already on metformin, you could continue to use metformin at a lower dose because the benefits of metformin far outweighs any of the complications. And lactic acidosis is a very, very, very rare complication. So the usefulness of metformin in most of the stages, except for end-stage renal disease, it could be used with a lower dose. Another controversy is metformin and its association with B12 deficiency. Yes, it can cause B12 deficiency. Reports have shown that B12 deficiency is seen in metformin and anemia. When the patients with on metformin with anemia, you should screen for B12 deficiency. It has been reported that an average 6 to 30% of patients could show B12 deficiency due to metformin use. In addition, some studies have reported that serum B12 levels were inversely related to the duration and dose of metformin. But unfortunately, the assay of B12 assay is not standardized. Many a times you get false false high values, and depending on that itself, it is not wise to stop metformin. But ADA also gives a caution: long-term use of metformin may be associated with B12 deficiency. Periodic measurements should be considered, especially in patients with anemia or peripheral neuropathy. If it is present, probably a supplementation, parenteral supplementation with B12 may be necessary. I think metformin in GDM, the previous speaker has already gone into detail about the use of metformin. There was a lot of concern again earlier, use of oral drugs in pregnancy itself. But let us see what has evidence shows metformin use in the first trimester can cause congenital malformations. This was a wrong concept, but evidence goes back showing that that this is a study by Pedersen et al. Almost 20-30 years back, where in just 7 patients who were treated with metformin, he found no congenital malformations and no ill effects of metformin. This first positive study for metformin. Then he found no major congenital malformations, no obvious indications for therapeutic abortions in patients who have taken metformin during embryogenesis. Clearly showing that metformin does not cause any congenital malformations or problems during embryogenesis. Then later came in 2006 another study that showed meta-analysis which showed metformin treatment in the first trimester was associated with a statistically protective effect. Said there is no evidence for an increased risk of major malformations when metformin is taken. So this controversy is put to rest by recent studies. There's another study showing that metformin is not harmful, which could be safely taken during pregnancy. This is a recent study in 2018 in a large international meta-analysis shown that no evidence was found of an overall increase of congenital anomalies after first trimester metformin. This is a third controversy with metformin. Now, controversy with metformin causing dementia. This was once postulated that metformin could cause dementia, but now it is shown that metformin is an insulin sensitizer, and the principal mechanism is by activation of AMP kinase, and effect of AMP kinase activation is improves hyperglycemia by increasing insulin sensitivity of peripheral tissues and inhibiting hepatic gluconeogenesis, regulates TAO phosphorylation, and probably that is good for the brain. Regulating the TAO phosphorylation is said to reduce the dementia and progression of dementia to Alzheimer's disease. These are the critical process. So actually metformin may be beneficial in Alzheimer's disease. So metformin has a potential to interfere with neuronal longevity mechanism, slows the aging process by acting on mitochondrial metabolism and insulin signaling. Slowing the aging process will be beneficial because quality of life could be improved in old age. So metformin is quite safe. There is no controversy in the use of metformin in old age also. So long-term metformin use and cognitive function among older adults, metformin use was found to be associated with significantly lower risk of cognitive impairment. So there is a beneficial effect, particularly in elderly people. This again, comparing to other drugs. This study compared the risk of development of dementia associated with particular types of anti-diabetic medication. So we have to remember that dementia and Alzheimer's disease have now been recognized as one of the long-term complications of diabetes. And so much so, a lot of importance is given to that. People sometimes even call it a type 3 diabetes. So there was a study to compare the risk of development of dementia associated with particular anti-diabetic drug treatment. The medication studies were metformin, sulfonylurea, and thiazolidones, and it was found that people taking metformin had the highest benefits. Probability of dementia survival for type 2 participants with different metformin is useful drug. There were problems with dementia with sulfonylurea and thiazolidones, probably because of hypoglycemia, and metformin monotherapy did not cause any. So the risk of developing Alzheimer's disease was lower in diabetics receiving metformin than in patients receiving sulfonylurea or thiazolidone. Probably the explanation is hypoglycemia. Then, as a first-line drug, metformin is there. There were some recommendations from some cardiology society guidelines saying that metformin as a first-line drug is no longer there for a patient with the ischemic coronary artery disease. The benefits from SGLT2 and GLP agonists are very high, so they should replace metformin as a first-line drug. This was the recommendation, but most of the diabetic recommendations do not agree with this. They still go by the guidelines saying that a resounding answer is no. Even if there is cardiovascular disease, metformin could be started along with the SGLT2 or GLP-1 analogs. But metformin, these drugs do not replace metformin as a first-line drug. This is another recent controversy with metformin. And you should remember that these newer drugs trials, like the EMPA-REG trial with empagliflozin, the leader trial with liraglutide, and the recent SUSTAIN 6 with semaglutide, all were conducted in the background of metformin therapy. As you can see, more than 70% of the patients already on this trial had metformin. So there is no reason to say metformin should be replaced as a first-line drug. It could be added. You could probably say you could have an SGLT2 plus metformin as an initial therapy, and not say you can replace metformin with the SGLT. Then a few years back, there was this controversy of the NDMA, that is nitrosamine contamination for metformin. This was released by the FDA to some of the metformin produced in some countries, but not from India, which showed higher level of NDMA, which is said to be carcinogenic. The FDA was aware that some metformin from other countries were reported to have low levels of NDMA, but a lot of studies have been done in the metformin from standard companies in India, and they have shown they are quite safe, and there is none of the metformin in India from the standard companies contain any increased level of the carcinogen NDMA. So it is, this controversy again has been put to rest. Lastly, metformin, it's not a controversy, at least it's an old drug. It has the implications on cancer. It's an existing drug for cancer prevention. It has been shown in some of the meta-analysis that people on metformin develop lower risk of lung cancer and prostate. These are the some of the meta-analysis. So based on these reports, we can see some of the, I've gone through some of the controversies of metformin, but as you can see, most of the controversies of metformin have been overcome with solid evidence from number of studies. So metformin is a safe drug. It should be the foundation drug for all patients with type 2 diabetes, unless there is a contraindication for metformin. People do not, about 10% of the population do not tolerate metformin. Probably these people, you can think of other drugs as a first-line drug. So this is my talk on the controversies with metformin.
Thank you, Dr. Anand, for a really beautifully expressed views on the controversies.
Yes, madam.
And I don't think now there is any controversy after your talk that metformin has stood the that the metformin has stood the time tested. It is a time tested thing now. Yeah, test of time. Yes. And we cannot just rule it out by any companies or maybe ADA or whatever come. Nobody can rule it out. And yes, we have seen that it works It is the cheapest drug around, so probably nobody's
Yes.
interested in this drug. But it has worked very well in our patients, and with
Yes.
pleiotropic benefits.
Yes.
I think it is really
It's a wonderful
important.
drug.
Yeah, definitely. Thank you so much.
Yes.
And this for dementia, it was a new thing for me
Yes.
actually.
Yes.
Yeah, so that
These
is
are
a
some
very interesting
interesting
development.
interesting observation.
Yeah. Great. So Dr. Vinay is there? Our other chairperson?
Next speaker. There's one more talk in this session, madam.
Yeah. I was looking for Dr. Vinay Shekhar. If he's there, he can introduce the next speaker. Otherwise, I introduce.
You can introduce.
Yeah. So our next speaker is Dr. Anupam Prakash from New Delhi. Can I see the slide, please? Yes, he has a very interesting talk again, and I'm sure he is also going to tell us many interesting facts. He's editor-in-chief, Indian Journal of Medical Specialties, indexed in Webs of Science, associate editor, API Textbook of Medicine, 10th and 11th edition, 272 publications in journals and books, and authored 8 books. Delivered 176 lectures and 22 paper presentations. Principal investigator of many international trials. And he has many awards to his credit. Dr. B.B. Thakur Oration, Professor S.K. Gupta Oration, LHMC Oration, Dr. G.S. Senani Oration, Srimati Pavan Kumari Jain Oration, DST Award to meet Nobel laureates. He was the president of the Delhi Diabetic Forum from 2016 to 2022, President Indian Society of Atherosclerosis Research. Then he was president of Faculty Welfare Association, member of governing body of Association of Physicians of India from 19 to 22. He is at present the member. Then he's a vice chairman, Association of Physicians of Delhi State Chapter, and member of Faculty Council of ICP. We have very eminent person, Dr. Anupam Prakash, now to deliver his interesting talk. I request Dr. Prakash he can start his talk. Yeah.
Well, thank you, Dr. Deshmukh, for the kind introduction. If I had known that you would read it out completely, send the whole slide. Well, anyhow, thank you so much, madam. And thanks to the organizers also for giving me this opportunity to present on a topic which is partly well known. And partly I would say that, yes, it requires a lot of inputs. And even after my talk, I think it will still remain a challenge for most of the physicians and diabetologists. So the topic given to me is 2 months post CABG on metformin comes with heart failure. What next? So Dr. Moses has already enlightened us on controversies with metformin. And 2 words here, metformin and heart failure, again instill a controversy. Because initially in text, when we were taught in our undergraduate days, all failures, whether it is renal failure, whether it is heart failure, they were actually contraindications for metformin, because metformin predisposes to lactic acidosis, and heart failure is also one of those end organ failures where you can have some component of renal dysfunction as well as heart failure, severe hypoxia precipitating metabolic lactic acidosis. So that I will just touch at the end. So we have 4 points here: diabetes on metformin. I take it that this patient is our diabetic because he's on metformin. That is not given to me, but yes, diabetes on metformin, having CAD to the extent that he has undergone a post coronary artery bypass graft, and now he has presented with heart failure. So that is the scenario. And why actually heart failure is a problem? So this is a study in 2016, and if you see after CABG, coronary artery bypass grafting, if you see the preoperative heart failure patients, you find that this was a study done for 6 years, and death rates you can see. Those who do not have heart failure and had preserved ejection fraction, death rates were 13% over the 6 years. But those who had reduced ejection fraction, even without evidence of heart failure, it was 24.6%. And those who had heart failure as well as reduced ejection fraction, the mortality was of the tune of 42.9%. So that is the importance of heart failure. So if any patient otherwise also comes with heart failure, you see it is 24.6%. But any patient who is diabetic, who has heart failure, has post-CABG, the chances of mortality in the next 6 years could be very, very great. So that will remain a challenge. I'm not going to the details of the next part. But why actually heart failure should develop post-CABG? We always expect that it should improve once we have an intervention. But yes, I would come to a couple of slides later. It could be a pre-existing heart failure because in diabetics, it could not be diagnosed. It may be missed. It may be asymptomatic. And that may become manifest after the stress of CABG. It could be because of graft failure, operative myocardial injury, pre-existing LV systolic dysfunction, reperfusion injury resulting in myocardial stunning as the causes of graft failure. And similarly, some causes it could be non-graft related heart failure. So this patient has presented 2 months later. There are chances that the patient may be having any of the non-graft related heart failures. And in general, there are aggressive management of hypertension and diabetes is important, which may not have been done. Smoking cessation, patient may revert back to his own lifestyle, which actually may be detrimental. Weight loss is important and cardiac rehabilitation is also important. So these are some things which we have to pay attention when a patient post-CABG presents to us with heart failure. There are some others also, but I will just come as we discuss in the course of illness, course of the talk. So there are a number of things which come in a diabetic with heart failure. So the problem could be myocardial infarction, or it may be a microvascular disease, not necessarily an atherosclerotic vascular disease. It may be a microvascular disease like diabetic cardiomyopathy, where we do not have overt atherosclerosis. So insulin resistance and hyperglycemia remain at the center point, including with or without endothelial dysfunction, and heart failure actually worsens insulin resistance, as well as it can worsen hyperglycemia also. And this is what I was talking about. Subclinical myocardial damage occurs early, even before the diagnosis of diabetes. So this is what can actually result in heart failure, may have been covert and now becomes overt after CABG. And this may actually progress. So there may be a steady progression of the underlying disease despite CABG also. So this I have already alluded to. I will not go into details, but yes, we understand there could be a myocardial wall damage, which is a atherosclerotic event. And there could be inflammatory microvascular effects, which I already said, microvascular angina, we say, or microvascular disease or diabetic cardiomyopathy, which may not be atherosclerotic, cross-atherosclerotic dependent. So again, this is important that LV dysfunction in diabetics can occur even in the absence of atherosclerosis. So again, a manifestation of microvascular disease is important for all of us to understand. And this I have already alluded to in the study. This is another study way back in 2004. So those who have diabetes without heart failure, the proportion surviving is much more as compared to those who are having incident heart failure. Similarly, those who have preserved ejection fraction, heart failure with preserved ejection fraction, as was shown in that study also, they have better survival rates as compared to heart failure with reduced ejection fraction. So what can we offer to them? That was the question. What next? So once we understand the pathophysiology, we understand drugs for CAD is important. Drugs post-CABG, there are some drugs which need to be given, and drugs for heart failure, which we will need to give. And obviously controlling the underlying diabetes is also important, which I will allude to later. So drugs for CAD, we have beta blockers, ACE inhibitors, statins, aspirin, and mineralocorticoids. We have post-CABG. I will just come, because this patient is post-CABG, I will just come to what the guidelines say for aspirin plus spinous clopidogrel, ACE inhibitor, ARBs, and statin high efficacy. For heart failure, we need to understand that mineralocorticoids and ARNI have an additional role to play. Apart from device therapy, which I will not be discussing in this talk, otherwise it will just go on. So post-CABG antiplatelets, aspirin has to be given 100% unless until the patient is intolerant or allergic. So dose is 81 to 325 milligram per daily, class 1 evidence. And after CABG, because this patient is post-CABG, for 1 year, we need to give dual antiplatelet drugs. So we need to give aspirin as well as clopidogrel. If the patient before CABG had an ACS, then it is preferred to give prasugrel or ticagrelor as compared to clopidogrel, but aspirin still has to be given. Just in case this patient is being given only antiplatelet therapy, then to prevent aspirin resistance, we should give a higher dose of aspirin. So rather than on the lower side of the range of 81 to 325 milligram per day daily, we should give 325 milligram daily. That preferably aspirin plus clopidogrel for 1 year. And after 1 year, you can stop clopidogrel, but not aspirin. So aspirin has to be given lifelong in these patients. Statins after CABG, you have to give a high intensity statin. So you can give either atorvastatin 40 to 80 milligram and rosuvastatin 20 to 40 milligram. And only those patients who are intolerant to high dose of high intensity statin, or those in whom we fear drug-drug interactions, like elderly populations, we should give a moderate intensity statin therapy. So a slightly lower dose. Now, beta blockers are controversial in diabetics, but yes, CABG patients, they should be prescribed beta blocker unless contraindicated for the categories where there has been a history of MI, for the categories where there has been LV, where there is LV dysfunction present, and for hypertension where alternative drugs are effective or not bringing the target to 130/85. So the agents that we have to use is bisoprolol, sustained release metoprolol succinate, or carvedilol, because they have proven benefit in CABG patients, for LV dysfunction and for heart failure also. And definitely ACE inhibitors in diabetics will remain the key as an antihypertensive therapy and for LV remodeling. Also, if there is evidence of nephropathy. Now coming to glucose lowering agents. So this is what there have been a number of trials. This is just one of the slides I have taken. And you can see acarbose, pioglitazone, sulfonylureas, metformin, sulfonylureas, thiazolidine, accord, insulin. They had 4 arms like this. And even with rosiglitazone, we all understand that there is no benefit to cardiovascular events with any of these drugs, as you can see in the forest plot. So even DEVOTE, where insulin glargine was tested with insulin degludec. So they are all not beneficial if you go by what and you can see the hazard ratios given there. While DPP-4 inhibitors were largely cardiovascular neutral. So that was what the glucose lowering drugs were. But when we talk of, apart from cardiovascular events, when we talk of heart failure, so you can see heart failure, actually most of the drugs, oral drugs as well as insulin, you can see they are actually increasing heart failure. Thiazolidine diones, we understand, DREAM study, they were just withdrawn. DPP-4 inhibitors were also, we have some trials where they say that yes, it is increasing the impact of heart failure. So that is the problem with most of the drugs. With insulin, it may be the reason that people say it is because of insulin resistance. Evidence may or may not be so robust, but yes, we put patients on insulin when most of our drugs fail. So that's one of the reasons. GLP-1 by and large are considered neutral for heart failure. So I will talk about GLP-1 receptor agonists because they are one drugs which are beneficial to cardiovascular events, but not definitely against heart failure. So this patient is having ASCVD, atherosclerotic cardiovascular disease. It has an endpoint of ASCVD in CAD and has a CABG also. So this patient definitely would benefit with GLP-1 RA, the receptor agonist, but probably heart failure, we do not have evidence right now. So these are some recommendations of the standard societies that we have. We are actually believing in guidelines, and guidelines of all these agents, they say that those who have ASCVD, you should either use GLP-1 receptor agonists or SGLT2 inhibitors. Even the RSSDI, we are in the conference of RSSDI, and RSSDI 2017 statement also says those patients who have diabetes and established ASCVD, GLP-1 RAs and SGLT2 inhibitors should be maybe preferred, but now it is actually should be preferred. And they are suitable alternative for patients who are actually overweight or obese. So this is important. And if you go by this, the ACC expert consensus in 2018, the type 2 diabetes and established ASCVD, we should actually consider adding SGLT2 inhibitors when reducing heart failure hospitalization is the foremost priority. So this patient has heart failure. Definitely, we will not like to have admissions, and we will like to treat heart failure also. And as it was being discussed by Dr. Moses in the last lecture, now the primary prevention of ASCVD as well as heart failure, SGLT2 inhibitors are playing a role. So GLP-1 receptor agonists, they should be used for ASCVD, but right now for heart failure, we do not have data. See the European Society of Cardiology guidelines in the third row, 2019. First line treatment of T2DM in heart failure should include metformin and SGLT2 inhibitor. GLP-1 receptor agonist may be considered. So that is what the right now, GLP-1 receptor agonists, we do not have convincing data against or for use in heart failure, but definitely, yes, they can be used very nicely. We have a whole lot of studies, Pioneer, and we have the SUSTAIN studies with semaglutide and a whole lot of other studies which have benefit in atherosclerotic cardiovascular disease. But right now, not for heart failure, where actually SGLT2 inhibitors are the foremost agents that we actually need to use. So the pathophysiology, I will not go into this again, but there are a number of ways where SGLT2 inhibitors actually benefit the heart failure state. So we have improved cardiac bioenergetics, we have natriuresis, which they cause because of glycosuria also. We have reduction in interstitial edema, reducing the preload and afterload, improving the LV shear stress and improving LV function also. And also there are some ion exchange changes also which happen, and there is improvement in cardiorenal pathophysiology. Now we should understand that the cardiac are very intricately linked, and the renin-angiotensin-aldosterone system is at the center point of actually harming or benefiting the cardiovascular system. It actually does try to benefit the system, but there is cascade which actually goes haywire, and that is why. So SGLT2 inhibitors actually act on all these aspects, and that is why probably with ACE inhibitors, after ACE inhibitors, but in a diabetic with heart failure, they are actually the agents which should be used for glucose lowering drug. And as Dr. Moses was saying, even without glucose lowering drug, now the primary prevention aspect is also being modulated for these agents. So across the spectrum, there are 3 drugs. So empagliflozin, you can see the major adverse cardiovascular events as well as hospitalization for heart failure, they are reduced. The CANVAS program, the canagliflozin, again, hospitalization for heart failure are reduced. And the dapagliflozin, the declared TIMI study, we can see the hospitalization for heart failure as well as MACE are reduced. So these are just some of the studies which suggest, and you can see again in this, the all-cause deaths also are not significant in declared TIMI, but hospitalization for heart failure, there is a significant benefit when we use dapagliflozin for reduction of heart failure states. So, and this is subgroup analysis where we can see the history of heart failure, whether or not it is present, the patients did benefit of diabetics. I will not talk about the amputations part, but yes, again, you can see this is for those patients who have a history of heart failure. You can see in diabetics, there is a definite benefit with canagliflozin and dapagliflozin. Those who do not have a history of heart failure, even in those patients, there is a reduced hospitalization for heart failure in patients who are receiving empagliflozin and dapagliflozin. So that is the advantage of using empagliflozin, canagliflozin, or dapagliflozin, any of the SGLT2 inhibitors in patients who have heart failure. So they definitely reduce hospitalization for heart failure. And when we actually have to consider, we consider a lot many things when we start any patient on any glucose lowering drug or even another drug. So effect on mortality outcomes, we have to weigh the micro and macrovascular complication, whether they are benefited or not. Contraindications, as this patient is having heart failure, maybe kidney dysfunction also. Risk of hypoglycemia, risk of weight gain, adverse events, age, efficacy, and costs. So, and all these things, if we go, we find that yes, SGLT2 inhibitors would be the right choice in this group, which need to be added, provided all other drugs, as I have said, have been already optimized. Now, this is another group of drugs which is important. Now, this ARNI drugs are also beneficial for these patients, and they are also quite efficacious. So, were this patient was not a diabetic, we do not have robust evidence right now for primary prevention, but yes, still you should consider adding an ARNI, replacing the ACE inhibitor or ARB with an ARNI group if we are having this patient who is post CABG and develops heart failure, especially if it is NYHA class 2 or 3 heart failure. Definitely this patient should be a candidate. So this is just a comparison of subgroup analysis for dapagliflozin. So you can see those patients who were receiving ARNI, they did benefit with heart failure, did benefit. And those who were not receiving ARNI, the benefit with dapagliflozin was equal. So you can see dapagliflozin or any gliflozin SGLT2 inhibitor has an equal efficacy as good as ARNI, ACE inhibitors or neprilysin inhibitors. So whenever we have to select an agent after metformin, right now the question was after metformin, I'm not talking of primary choice, but yes, add on to metformin. So this patient, even if this patient was not having CABG or ACVD or history of heart failure, the choice should have been SGLT2 inhibitors because now the cost also is much less. But this patient has post-CABG and has the status as well as history of heart failure. So definitely SGLT2 inhibitors will have to be added in this patient group. Well, I think that's last slide. Thank you. Thank you so much.
Thank you so much, Dr. Prakash, for this interesting presentation. But I would like to ask you that if the patient develops a heart failure on metformin, what would be your take for metformin? Would you continue this or you would like to maybe replace it with the SGLT2?
See, that controversy I didn't want to touch, but I opened it up. And most of these patients who have post-CABG, they are invariably not on metformin alone. They are usually on insulin because this is a long-standing disease. Even microvascular disease affecting the heart does not appear over a initial part of the disease. And it is a long-standing disease they will have for 5, 10 years, 15 years. And there's only a young subgroup of population which actually will develop an acute MI and require CABG too early in the course of the disease. And that patient population will be only the one which will be on metformin. And metformin, I would say, if we have optimized everything, metformin is not heart failure is not a contraindication for metformin. But yes, most of these patients are on insulin as well as metformin. So in those cases, definitely when they develop, or even if they do not develop SGLT2 inhibitors, the evidence says that yes, we should definitely add them. But yes, I am agree with you that these patients are mostly on insulin with or without metformin.
So you would continue metformin in that case?
Yes, my personal, yes, I would continue metformin, definitely. There is no harm. As some of the guidelines also, you can say metformin with SGLT2 inhibitor is recommended.
Yeah, right. So any questions? I don't see any questions actually. Anyone wants to add anything? Dr. Anand?
No,
if he's there.
nothing, madam.
Yeah. So I think we shall conclude this session.
Yes.
Thank you.
Thank you very much for this new insight into the metformin. And I think our audience would be benefited with these talks. Thank you so much.
Thank you. Thank you. Thank you, everyone.
Bye-bye. Good night.
Good night.
Hello, everyone.
Hello.
Good evening, sir.
Can we start the session now?
I think Dr. Gupta is here.
Yes, Dr. Gupta is there. Or Dr. C.S. Yagnis is also there.
Okay, sir.
So,
Good evening, everyone. And here we are ahead of 30 minutes. We're lucky to get 30 minutes more perhaps at our hand. And with this, for the first session of this keynote session, I would like to invite Dr. C.S. Yagnik and on the topic, to deliver his talk on the topic adiposity in Indian babies at birth and later. Since morning and since from last yesterday, we are listening so many lectures regarding diabetes, regarding pathogenesis, regarding controversies, regarding newer therapies, and now we are going back and back to see. Just before this session there was a gestational diabetes topic about that, and now we are reaching at birth and later, as we know, the metabolic syndrome and that of adiposity in Indian babies, and it is now at the root cause because of this visceral fat issues. So I think Dr. Yagnik is there to throw light on this beautiful chapter, and he is the director of the diabetes unit at the King Edward Research Center, and he is also known for his description of the thin fat Indian high body fat as we are discussing now, and he is the current president of SNEHA India, Society for Natal Effect, and trustee of the International Dohart Society. Dr. Yagnik is advisor to many organizations, including Department of Indian Council of Medical Research, ICMR, National Institute of Nutrition, WHO, FIGO, and the Wellcome Trust, London, and so on and so forth. So the list is definitely many you can see. So I welcome Dr. Yagnik for this first session. Welcome, Dr. Yagnik.
Thank you, Dr. Sarita. I'll share my slides now.
Sure.
So you need to stop the screen share. Are you able to see?
yeah. Yes, sir.
Thank you. Thank you, Madam Sarita. Thank you, RSSDI, for the invitation. And I'm going to speak about adiposity in Indians, but also in other people at birth and later. And given the preparation I have made, it's going to be mostly at birth with only a little bit about later. And as you know, I'm very fond of this topic for last many years. I always like to start by saying mine is the only department of diabetes in the world which has mother and baby as the logo. And this is because of our firm belief as part of the DOHAD phenomenon, developmental origins of health and disease, that mother exerts influence on the baby's health, not only when the baby is growing in the womb, but for the rest of the life. And we'll see some evidence of that today. And the second logo, of course, you know, the modern Ganesh, who now within last 50 years has stopped looking at this mouse, doesn't travel on its back. He clicks the mice and rapidly moves around. And I have many collaborators and a lot of help from different people in research for last 40 years. So that I am saying what Pablo Coelho told us, that world usually conspires to help you. I'm going to start by actually defining the term adiposity, because there is quite a bit of confusion, and the thin fat idea actually was initially not quite properly understood by people because they did not understand the difference between adiposity and obesity. So adiposity is strictly fat mass in the body, expressed either as fat mass in kilogram or as percentage body fat. While obesity, the current definition is based on body mass index, and at birth it is based on ponderal index, which are weight for height. So there's no special fat measurement in obesity. Though in a given population, obesity is strongly related to adiposity, in different populations, the relationships are very different. And that is how Indians can be thin but fat. So adiposity is measured as fat. And we can use anthropometry, that's skin folds, by using a calipers. BI is body impedance analysis using the electric current. Deuterated water is a non-radioactive isotope which can be drunk, and the output of that isotope in the urine allows you to calculate the two compartments, the fat and the fat-free mass. DEXA is a machine which gives you three compartments: bone, muscle or lean, and fat. And we can have either regional adiposity, which is measured by CT or MRI, which shows us subcutaneous and intra-abdominal fat, or DEXA machines can also estimate this. On the obesity side, we have waist circumference and waist hip ratios as measures of central obesity. And the new concept of ectopic fat, fat present where it should not be, is usually done by imaging, CT or MRI. So it's important to understand that by adiposity, we mean fat. And by obesity, we mean weight for height. And we assume that obesity is adiposity, which is not always correct. My interest in fetal adiposity actually has been stimulated by various things, but I always owe a gratitude of debt to Pat Catlano, who's a very famous researcher in pregnancy, obesity, fetal adiposity from the US. He's also a close friend and a mentor. So I just mentioned one of his papers, that increased fetal adiposity is a very sensitive marker of abnormal in utero development. So it has much more significance than just measuring the fat, and we will see how it goes. And just last year, I wrote an editorial for American Journal of Clinical Nutrition, and I called it Fetal Adiposity Epidemic in the Modern World, a thrifty phenotype aggravated by maternal obesity and diabetes. And today we will see how this idea came about. This is a very interesting slide. I'll take you through this. And what this slide shows is percentage body fat in different mammalian species. So we know pig, we know rat, then we also know, so let's say lamb, or something like sea lion. Sea lion is such a huge animal. The newborn of pig and the rat have approximately 2% body fat. Sea lion has approximately 5%. Do you know how much a human fetus has? Human fetus has the highest body fat percent in the mammalian world, and therefore in all the animal species. 15%. It's amazing that the small human fetus has highest body fat percent in the mammalian sort of world. And therefore this must have some importance. Otherwise evolution will not invest in actually human baby, the most adipose of the mammalian world. So this is an important point to keep in mind. How does fat develop in utero? You heard about stem cells, and the stem cells which go on to develop fat are the mesenchymal stem cells, MSCs. So mesenchymal stromal and mesenchymal stem cells. Under the influence of various hormones, which includes insulin, then steroids, and factors like IBMX, This is converted into what we call lipoblast, which is a precursor even before pre-adipocyte. The lipoblast then goes on to develop pre-adipocyte, and pre-adipocyte then expands by clonal expansion and accumulates fat inside its cytoplasm. And when it achieves a particular amount of fat, what we call fat globule, we call it mature adipocyte. So the journey is from mesenchymal stem cell. Various transcription factors are involved, including ARK, CEBP, PPAR system, and EBP. So these are very important for us because there are a number of medications which have actually come in market, and our pioglitazone is of course a PPAR gamma inhibitor. So this is important to learn that adipocytes develop like this. And when do they develop in the intrauterine life? They start developing around 14 weeks of gestation when the mesenchymal cells aggregate. Then they undergo rapid differentiation into pre-adipocytes within a week or so. Then up to 19 weeks, the pre-adipocytes develop. The number is established, which more or less remains with you for the rest of the life. By 22 weeks, all this is over. Primitive fat globules start appearing in the pre-adipocyte, and then by 28 weeks, well-separated fat globules are seen, so we can classify them as an adipocyte. After this, the growth is mainly by increase in the amount of fat. So number of fat cells are almost decided by 22 to 28 weeks, and then subsequently in the third trimester, they grow by expansion of the size of the globules. Very interesting. The first interest of fetal adiposity and the offspring adiposity was published from, it's published from Denmark in the first place, which we'll see a little later. But the clinical report was from Pima Indians. And this very seminal paper published in 1993, and a version was published many years before also by David Pettit. It said that if mother had diabetes in pregnancy, her children are more obese as early as before 10 years of age, then around pubertal age, and around early adulthood, that is 18, 19 years. And to say that this was an effect of maternal diabetes, and it was not a genetic effect that mother was diabetic, therefore the baby had obesity. They also compared it with obesity in children who were born to mothers who developed diabetes after their pregnancy. That means they did not have diabetes in pregnancy, but they had a genetic predisposition. And then mothers who never developed diabetes. That means they did not even have genetic predisposition. So it was intrauterine exposure to hypoglycemia, which increased risk of obesity in later life. And this was converted into a concept by a very famous scientist from Chicago, Norbert Frankel. And he called it fuel-mediated teratogenesis. And what he said was that till that time, teratogenesis was applied to fetal anomalies. So he said it may help us to expand our concept of teratogenesis. It may be useful to look beyond the effects on organogenesis and examine for fuel-mediated teratology in behavioral, anthropometric, metabolic, and even more subtle dimensions. And what he suggested was that excess transfer of maternal fuels, namely glucose, lipids, and possibly amino acids, stimulated insulin secretion from the developing pancreas in the baby and produced excessive adiposity in the baby. which we called macrosomia. It didn't stop there. It increased their risk for obesity and diabetes in later life. That means the effect remained with them for the rest of the life. This is the new concept of fetal programming, which Norbert Frankel had called as a metabolic teratogenesis. Similar thing can happen in brain development and body composition development. So a whole lot of very interesting concepts were developed in 1970s and 80s. So based on these ideas, by 1980s and 90s, the concept was that maternal obesity and diabetes are major drivers of fetal adiposity in the Western world. And as I said, the pioneer Pedersen, who showed that the baby's insulin concentrations were high if mother had pregnancy diabetes, he had described this baby in his clinic as a classic example of a diabetic mother's baby, where he said the most conspicuous is obesity, the round cheer-ups cheeks, buried eyes, and short neck. It's a very classic description of a baby, newborn, if mother has very grossly uncontrolled, especially type 1 diabetes. Nowadays, of course, these things don't happen. This was in 1950s. But very soon, and actually around the same time, this paper was published, which is quite remarkable. I read it when I was a resident in Sassoon General Hospital in Pune. And what it did was it followed people in Netherlands, from the Western Netherlands, who were born towards the end of the Second World War. And they were followed up at the time of their army conscription, around 18 years of age. And what they noticed was that if they were born in this severe hunger winter, when the Germans had blockaded the food supply to Netherlands, so everyone had to survive on 600 calories per day ration. So the pregnant women also had a ration of only 600 calories. Their babies were more obese in later life if they were exposed to this hunger in the first 2 trimesters, but less obese if exposed in the 3rd trimester. And the authors explained it by saying in first 2 trimesters, brain is developing. So if that brain sees the world as a hungry place because of mother's hunger, then it continues to eat and the baby will become obese in later life. While when the number of fat cells are determined, if that time there is hunger, the number of fat cells deposited are less, and therefore they are less likely to obese. Fantastic follow-up paper. And very soon, within 10-15 years of this, David Barker came up with his idea of thrifty phenotype, when he showed that lower birth weight people had higher risk of diabetes and metabolic syndrome, which includes adiposity and central adiposity, compared to those who had larger birth weight. So if mother was healthy, did not have gestational diabetes, larger babies of healthy mothers had actually less risk of diabetes in later life and less risk of obesity. In other words, these 2 studies showed, quite contrary to the popular belief about fetal overnutrition as a cause of fetal adiposity and future risk, these 2 showed that fetal undernutrition can also cause future obesity and adiposity. And David Barker met me in 1991. That changed my research career completely. So we set up this Pune maternal nutrition study to understand why Indian babies are so small, what is the problem with their fetal growth, and to follow them up for a long time to find out how various phenotypes, especially diabetes, adiposity, and others, develop. So we studied in 6 villages, more than 2,500 women from before they became pregnant. More than 800 became pregnant in our study. They were intensively studied in pregnancy. Babies were measured at birth. Then they were measured every 6 months for 18 years. Then we measured them every year. And then every 6 years, we do a very detailed examination of cardiometabolic risk factors, brain development, cognition, and a whole lot of things. So you know about this because I usually talk about this. So the mother in our study started pregnancy with body weight of 42 kg and BMI of only 18.1. These are very fit village women. They're predominantly vegetarian. They ate less than 75% of the recommended dietary allowance. Large part of it was carbohydrate, less micronutrient containing food intake, substantial physical activity like you can see here, and no GDM, practically no GDM. In 800 women, we had just 3 women with very borderline sugars. Lot of B12 deficiency in this population and no folate deficiency. And their babies are what we compared with an English baby born in Southampton in David Barker's hospital. So this is an Indian baby born in Pune, Pune Maternal Nutrition Study. This is a baby born in England. Pune baby 2.7 kg. English baby 3.5 kg. So I asked David Barker also before I told him what the measurements were. I said, would you expect small Indian baby to have more fat or less fat? So his answer was less fat. So I said, you are wrong. They have more fat because we had made very detailed measurements. So this 0 line represents the English baby. And the bars which are below means the Indian babies are smaller. And they are smallest for their abdominal circumference. Then they are considerably small for their birth weight, height, mid-arm and head circumference. But surprisingly, their subscapular skin fold was almost similar to the English baby. And if we compared Indian babies and English babies who had similar birth weight, Indian babies actually had a larger subscapular. That is called pair matching. So pair matching actually we did in another study which is shown here, that so for pair matched babies which had similar birth weight, 3100 grams, the subscapular skin fold in Indian babies was 4.4. In London babies, it was 4.1. So quite amazing. They look small, they look thin, but they are fat. Not only that, in their cord blood, they have higher leptin concentrations, they have higher insulin concentrations, and they have lower adiponectin concentrations. In other words, that fat doesn't sit quietly, it is active. There is a degree of adiposopathy. Excess leptin and insulin, but less adiponectin. And this is a classic description of a thin fat Indian baby, that it has more subscapular and more central subcutaneous fat, more secretion of leptin, less secretion of adiponectin, and a degree of insulin resistance induced by these factors. And people didn't believe that I could do good anthropometric measurements, so they doubted the whole study. It's typical Pune address is not always good. If it was Boston, US, they would have said, what a great discovery. So then I had to go to black box. So we used the black box of MRI. So 30 babies, newborn babies in Pune measured with MRI, 30 babies born in Imperial College, London, measured with MRI. Nina Modi, famous pediatrician in London, close friend. And we compared these babies. You can see here for the newborn, most of the fat is subcutaneous, very little visceral fat. And to our surprise, or like to say, not to my surprise, Indian babies had higher fat in all 3 compartments of the abdomen, namely superficial and deep subcutaneous and visceral. So this was a proof which then everyone accepted because MRI picture shows it very clearly. Anthropometry, they doubted. So this was a confirmatory proof that Indian babies are more adipose than the Western babies. And then a plethora of papers have been published across the world in Indians within India, Indians migrated abroad, Indians in Suriname, which are multi-generationally migrated, showing different aspects of this. So in Canada, Sanya Anand and her colleague showed what we showed in PMNS, like Indian babies have higher ponderal index and higher subcutaneous fat. Then the Born in Bradford study in UK showed higher cord leptin concentrations in South Asian babies compared to English. And then using a machine called PPOD, which is a air displacement machine used for measuring fat at birth, the London study, London mother and baby study showed that Indian babies have higher fat mass compared to the English babies. So resounding proof everywhere. How does this happen? So in our study, we looked at maternal glucose, maternal cholesterol and triglycerides in relation to subcutaneous fat and abdominal circumference. And what do we find? Fasting glucose, not related. 2-hour glucose, strongly related. Cholesterol, not related to skin fold, but related to abdominal circumference. And triglycerides related to both. So this is like fuel-mediated teratogenesis of Norbert-Frankel. 2-hour glucose and triglycerides in the mother are two strongest determinants of subcutaneous adiposity in the baby and abdominal size. Additionally, we found low vitamin D in the mother was also associated with fetal adiposity. So macronutrient excess, micronutrient deficiency. That is the picture in Indian babies, which produces adiposity in the baby. So I coined a new term called dual teratogenesis, micronutrient deficiency and excess macronutrient. I call this as nutrient-mediated teratogenesis coupled with fuel-mediated teratogenesis of Norbert-Frankel. And together we called it dual teratogenesis. Published it long time ago. I'm going to now tell you about 2 pregnancy diabetes studies which we have set up over years. As you know, I started practice somewhere in 1980, came back again from England in 1984 and joined KEM in 1986. So I think this should be 1986. I'm sorry, it's 88 written here. So DIP is Diabetes in Pregnancy Study in Diabetes Unit KEM Hospital, Pune. And it's a real life pregnancy cohort. It's not a research cohort as such. And by now we have been able to collect data, quite good data on about, let's say, little less than 400 NGT and more than 800 diabetic pregnant women. We have clinical anthropometry, OGTT, delivery details, and for baby, we have birth anthropometry, clinical data, and cord blood measurements. 2004, we got a DBT grant, which we called India GDM study, where we followed up some of these babies from our cohort. And we also set up a new cohort of prospective pregnancy studies. So we have DIP study, which is a real life pregnancy cohort, and India GDM, which is a prospective new cohort. But part of India GDM is follow-up of children and parents who were diabetic pregnancy or non-diabetic pregnancy in our previous records. And we have quite interesting results. The India GDM new cohort just gave us very good characteristics of the GDM versus NGT babies. So the GDM babies born just 2 days earlier, not significant, but they had higher weight. They had higher abdominal circumference, sum of skin folds, fat percent measured on DEXA, fat mass, less lean mass. Less lean percent, but similar lean mass compared to the normal babies. In other words, they are a little bit overweight and they are adipose compared to the NGT babies, or babies born to NGT mothers. Now, if we go back to DIP, we have an interesting thing that being a diabetes unit, we treat all types of diabetes. So T1Ds who become pregnant, T2Ds, then GDMs who are diagnosed during pregnancy, and NGT in the hospital. So this is the data on these 800 plus pregnancies with diabetes and 372 NGTs. Type 1 diabetes, youngest. Type 1 diabetes, thinnest, lowest pre-pregnancy BMI. Their weight gain and post-BMI, post-delivery BMI, lowest among diabetic, but more than the non-diabetic. Then first trimester HbA1c. This is old age, so 9%, 7%, 5.7%. You can see the gradient of hyperglycemia which the babies are going to face. And post-delivery skin folds of these mothers much higher in diabetic compared to the non-diabetic, but lowest in the type 1 compared to type 2 and GDM. So picture comes that type 1 are the youngest and the thinnest mothers with most hyperglycemia, while these two are relatively more obese but relatively less severe hyperglycemia. And what about their babies? This is very interesting. So birth weights of diabetic babies or babies born in diabetic pregnancy were naturally higher compared to the NGT, highest in the T2D because these mothers were also the most obese. Lengths practically similar. Ponderal index, which is equivalent to body mass index, higher in diabetic babies. Abdominal circumference, larger in the diabetic babies. Skin folds, again larger in the babies of the diabetic mothers. But interestingly, for a given weight and length, the type 1 babies had quite a substantial adiposity and higher abdominal circumference. So the mothers were the thinnest and the most hyperglycemic, but babies are the fattest and most adipose, both by skin folds and by abdominal circumference. And this is what we are showing in this slide, that the red line here is type 1 diabetes, blue is type 2 diabetes, and yellow is GDM. These are mothers, these are babies. So mothers of type 1 diabetes, lowest weight, lowest waist circumference, lowest skin folds. And T1D babies of the type 1 diabetic mothers, they were the youngest. That means they were delivered at a relatively younger age. Most obese, ponderal index, and most adipose, that is skin folds. Quite remarkable. It tells us immediately that it is the transfer of nutrients, the fuel-mediated teratogenesis, which is driving the adiposity of the baby. And then we followed them up, as I said, in the follow-up India GDM study. So these babies were between 2 to 30 years old when we studied them. And we have done very detailed study. This is just to show you the body size and the body composition measurements in the babies born to diabetic mothers compared to those born to the NGT mothers. So NGT mothers are represented by this vertical line, which we call 0. If it is positive, then it is more in the ODM. If it is negative, it is less in the diabetic mothers' babies. And what do we see? All body size measurements except height are more in the babies born to diabetic mothers at an age between 2 to 30 years. So from very early age till adult age. And lean percent is less. And this is natural because if you have more fat percent, together two will make it almost 100%. So they have less lean percent. So they are thin fat. And this is quite interesting that the adiposity of the diabetic babies is continued to reflect in the later life. And it's true more in boys in our study than girls. So in girls, most of the things are similar in the two groups. The confidence intervals are crossing 0 line, while boys have higher in all respects. And now by mother's type of diabetes. And this is again very interesting. I told you at birth, the babies born to type 1 diabetic mothers were the most obese and most adipose. Now, type 1 diabetes mothers' babies here, type 2 diabetes here, and GDM here. The colored bars are actually mother's BMI. So GDM mothers had higher BMI and type 2 diabetes mothers had higher BMI compared to the NGT mothers when they came up to follow up on average 10 years after delivery, while type 1 diabetic mothers were less obese compared to the NGT. Babies of GDM and type 2 diabetes, more obese and more adipose. Babies of type 1 diabetic mothers, similar to NGT, not more obese, and if anything, they had slightly lower fat. In other words, the picture is now exactly opposite of what it was at birth. At birth, these babies were most adipose and obese. Now they are similar to the NGT. Glucose-wise, all three have higher glucose compared to the babies of the NGT mothers. In other words, body composition and metabolic programming is separated. And this, I think, is one of the few studies which is showing it so beautifully from the type of diabetes in the mother, because their characteristics in India are very useful for such bifurcation. In Western world, type 1 mothers can also get very obese, then you lose this difference. So we have now sent this for publication. I think it's a very nice observation. And then we also measured fathers because they are the forgotten characters in diabetic pregnancies. And what we find is that the obesity and overweight and obesity in the babies is influenced by not only mother, but also by fathers. So if both mother and father are non-overweight obese, that means normal, their babies have least chance. If one of the parents, either mother or father, is overweight obese, they have a higher chance of being overweight obese. But if both parents are overweight obese, then the chances are highest. Again, a beautiful demonstration that fathers also have a role to play, which we usually forget when we follow children of diabetic mothers. And then a multivariate analysis to see whether parental overweight obesity and parental glucose intolerance work independent of each other for outcome of overweight obesity and glucose intolerance. And what's the answer? For overweight obesity in the baby, parental overweight obesity is significantly related. Allowing for this, glucose intolerance is not. For glucose intolerance, parental glucose intolerance is significantly related, overweight obesity not. Clear demonstration that for a given sort of overweight obesity in the parents and given glucose intolerance in the parents, you are going to have separate fetal and subsequent programming of body size and composition and metabolism. Is birth weight related to any of this? Yes, it predicts overweight obesity. So size for size, metabolism for metabolism. Beautiful description. Another study from Mysore showed that babies born to diabetic mothers were obviously bigger at birth, and then they dipped down at 1 year and then started picking up at 5 years. So Dr. Krishnaveni, who is an expert in Mysore on gestational diabetes, she has put up this data. Now she has followed up these children up to 20 years like Pune babies, and we will see more exciting research from her. But this shows about catch down growth in the babies of diabetic mothers who are overgrown at birth. So catch down and then rapid rebound. So this is called adiposity rebound. And then we followed up our Pune maternal nutrition study, children at 18 years. And what we find is that their adiposity measured either by DEXA or by MRI is still predicted by maternal red cell folate concentrations in pregnancy and maternal vitamin D deficiency in pregnancy. So mothers who had low vitamin D and high folate in pregnancy, their babies are more adipose. Again, an example of nutrient-mediated teratogenesis in addition to the fuel-mediated teratogenesis. The cellular and molecular mechanisms, you know about epigenetics. I'm not going to get into details of it, but DNA methylation is one of the major mechanisms of epigenetics. And this study from Southampton showed that methylation of RxRA gene as seen in the cord blood is a strong predictor of adiposity in the baby at 6 years of age. In other words, epigenetic influence of maternal disturbed glucose metabolism by promoting methylation of certain genes can influence the long-term phenotype of the baby. And what we are doing in Pune, we are doing a whole lot of things. So we are now doing DNA methylation, we are doing transcriptome, we are doing placental transporters, and we are doing what are called adipocyte-derived exosomes from the mother and also from placenta. All these 4 major mechanisms are being studied intensively in Pune. We have very exciting results, and I won't go into details of that. It will take a separate lecture, but we have very good methylation of metabolic genes in babies of gestational diabetic mothers. We have dramatic transcriptional changes affecting cell cycle regulation after B12 intervention in our study. We have dramatic exosomal miRNA differential expressions in babies which are either adipose or not adipose. And we have shown differences in GLUT transporters, the fatty acid binding transporters, and vitamin B12 transporter, what is called CD320, in the placenta of the mothers in relation to their either macronutrient or micronutrient nutrition. Quite dramatic studies, very basic mechanisms. This is going to change our thinking. I must also mention Dr. Sandeep Mathur and his team from Jaipur who have been very active in molecular biology of adipocyte. 3 major papers which he has published in last 5 years and different molecular mechanisms which he has shown. Time doesn't allow me to discuss this, but you should invite Sandeep to actually discuss this. Finally, I'm going to tell you an interesting example because this is what affects every practicing physician when he looks at a pregnant patient. Usually we consider pregnancy means mother and baby. So 2 generations living together. If it is a pregnancy with a female child, all the 1 million ova which are present in the ovary of that baby for the rest of the life are present by 20 weeks of gestation. So if it is a female pregnancy, then you are dealing with 3 generations. If you improve the health of this grandmother, you have a help or you have a hope of improving the health of her daughter and also her grandchildren. This was a picture, last paper which David Barker published before he passed away in 2013. So I always show this picture towards the end of my talk. A female pregnancy is 3-in-1 situation. Very precious to improve the health of the community. And these are 4 generations in our cohort, which we have actually followed up. Finally, I'm just going to conclude by saying that by investigating more and more nowadays, we find more and more abnormalities. So Aldous Huxley said, medical science has made such tremendous progress that there is hardly a healthy human left. So we are either thin fat or we are fat or we are normal fat or whatever, and doctors quite enjoy it. Thank you very much.
Thank you, Dr. Yagnik. really amazing presentation. Just we couldn't think of how 45 minutes passed so swiftly. And literally you have taken us to the mother's room, the perinatal area, and mother and fetus, and your last sentence is really amazing, and it gives the insight to look for the future inside every mother. Okay, it is not actually one generation, next 2 generations also, if at all it is a girl child inside womb. And I think we will invite questions at the last, and I would like to hand over the microphone to Dr. Gupta, my next co-chairperson, and to invite Dr. Mohan sir, another stalwart in field of diabetes.
Thank you, Dr. Sarita.
Dr. Gupta, please.
Thank you, Dr. Sarita. And thank you, Dr. Yajnik, for such a nice presentation. And thanks, RSSDA, for inviting me on this platform. Now we move on to the second talk of this session, which is by none other than Dr. V. Mohan, who is doesn't need any introduction. He'll be speaking on reversal of diabetes. When and for whom? This looks a very interesting topic because this used to look as a very far-fetched idea and a myth a few years ago. But now we know we can, actually reverse the diabetes with lifestyle modification, diet without a non-pharmacological method. To deliver insight and go deep into this topic, we have Dr. V. Mohan. I will read out only a few credentials because he doesn't need that introduction. He's a chairman of Dr. Mohan's Diabetic Specialist Center, President Madras Diabetic Foundation, Chennai, and he has main research interest as epidemiology of diabetes and its complication. He's received over 180.
I think that's okay, Dr. Gupta.
Thank you, sir. Thanks. Dr. V. Mohan, please, sir. My pleasure.
Yeah. Now I'll share my slides. Hope you can see my slides. Is it seen, Dr. Gupta? Yeah. So let me start by thanking Dr. Banshi Sabu, the outgoing president of RSSDI, and the incoming president-elect Dr. Vasant Kumar, and the dynamic secretary of RSSDI, Dr. Sanjay Agarwal, for organizing this brilliant meeting. Is it okay? Everything okay?
Yes.
So organizing this brilliant meeting. Very difficult to do it in COVID times, and to do it hybrid plus virtual is a big challenge. So congratulations to all of you. It's been an amazing meeting, and I've just had the pleasure of once again listening to Dr. Yajnik and his amazing work. So the topic of my presentation is reversal of diabetes, how, when, and for whom. As Dr. Gupta said, this has been a topic which has been raging. And the reason I'm talking about this nowadays is because except us, everybody seems to be talking about it. Software engineers, dietitians, everyone else says that the diabetologists only treat. We are the people who reverse diabetes. So I thought that, it's very important for us also to recognize what has been said about reversal, what are the facts, and where, who, when, and for whom. So just so that we are all on the same page, a very simple talk, so that we are all on the same page. We know this natural history of diabetes very well, which means that from the normal glucose tolerance to pre-diabetes to diabetes and the stage of complications. So this is a natural history of diabetes, and we are going from left to right. Now, what about if you go from right to left? Is that possible? Now, that is what is called as reversal of diabetes or remission of diabetes. And if we think that this is a new concept, this very figure was published in 1970s itself from our group, and again in 1980s, at least about 10-15 textbooks have this figure with this reversal already shown. I think before anyone else had talked about it, we had talked about reversing of the diabetes. And these arrows, this is a slide I've been showing for the last 40 years. There's nothing very new in this slide. So reversal can happen. But the reason I'm talking about it now is that I've heard people say that even after 30 years and 40 years of diabetes, you can reverse diabetes. I think that's a bit far-fetched, because once you develop the complications of I've heard people say that even if your eye is affected and your kidney is affected and your heart is affected and your feet are affected, we'll reverse your diabetes. I hope that was true. I don't think that is actually true, because you can see that this reversal arrow, the blue one, only starts at the stage of clinical diabetes. Of course, you are at the stage of pre-diabetes. Nobody is arguing that you can reverse. We have shown it. Others have shown it. Several groups have shown it. The various prevention trials have shown it. Not only not progressing from here to there, but also reversal. So again, to set the record straight, from the clinical diabetes stage, it is possible. Again, it is not possible to reverse certain forms of diabetes. If somebody claims that type 1 diabetes, after somebody's beta cells are completely gone and is on 4 times insulin, I can reverse it. I think only the quacks now talk about that. And I've seen some of my children, unfortunately, children with type 1 diabetes, unfortunately die because they went to such quacks. So we must make it a point, and our voice must be heard, that there are many forms of diabetes which are not reversible, completely not reversible as of now. Maybe 10 years later, 5 years later, we'll be talking about reversal of that also. Today, is it possible? No. So when you talk about reversal of diabetes, we're talking about type 2 diabetes and its related forms like gestational diabetes and a few other types, but mainly about type 2 diabetes. So this is slide to just tell you that it's been long considered as a progressive condition, and indeed it is in many people. And remember, there's heterogeneity within type 2 diabetes. So it is not that everybody can reverse or everybody will progress. Some people naturally reverse. I've been looking at my series of reversals over the last so many years. Some people without even weight loss just went back. They've had diabetes and they went back. Some of them is clearly stress related. But in others, even without anything, they just seem to go back. They come and they go back. Something has triggered it, and when that goes away, it goes away as well. And in many cases, 50% of individuals require insulin therapy within 10 years. And therefore, it's been traditionally thought that it's treatable, but not curable or not reversible. But here are 5 examples of reversal of diabetes, which you should all know. First is after severe weight loss. And the rest of this talk will be only about that. I don't have the time to talk about post-gestational diabetes, although we're doing a trial there, the living trial with Dr. Nikhil Tandon to see the prevention of diabetes after GDM. After bariatric surgery, it's well known that you get reversal. But again, there is too much of hype around that. We have just published a fairly large series of bariatric surgery. And what we have shown is that only up to 8.5 years duration, they are able to reverse. Otherwise, they need some medication. Of course, the number of medicines will come down after losing 30, 40 kilos in weight. The number of medicines come down. Sometimes they go off insulin. But for reversal, as I'll show you, they should not be on any medication. And that is rare in my experience, even after bariatric surgery, even after losing 30 to 40 kilos. But it can happen. In some cases, early cases, you do bariatric surgery, you can get reversal. Stress-induced diabetes, we all know. Even during the COVID situation, a lot of people had stress-induced diabetes, just panic, stress, depression. You remove that, give them psychological counseling, stress goes away, diabetes goes away. That's well known, although it's not that common as it's believed to be. Drug-induced diabetes, again, coming back to COVID, steroid use during severe COVID has produced so many cases of diabetes. I'm sure all of you listening would have seen cases of COVID-induced diabetes because of the steroid. And after the steroids were stopped, very often they go back. And so that is another example of reversal or remission. But in the rest of this talk, I'm going to just talk about the severe weight loss, because each of these is a topic by itself. Now, there are 2 definitions put here, and I would think the simplest definition is a recent American Diabetes Association definition of remission. Now, what they have said very clearly is, don't use the word reversal, because reversal gives an idea. It implies that there is a cure, C-U-R-E, cure. And that cure, as of now, does not exist, even for type 2 diabetes. What you're getting is a remission. And the analogy that they use is cancer. You can have cancer, let's say breast cancer, you treat it, you do surgery, radiotherapy, chemotherapy, hormone therapy, and then you do a PET scan, and there is no cancer anywhere in the body. What's happened? That patient has gone into remission. How long can that remission last? Usually a few years. Sometimes it comes back. And when it comes back, we call it as a relapse. And as I'll show you, the same relapse occurs in diabetes also. So that is why the term remission is used. It's just gone into hiding. It has gone into remission. It has not gone away forever. Okay. And I can give you some personal experience. My wife Rama, whom many of you know, was in remission for 13 years, 13 years. I was told by my oncologist that after 5 years, it's called as a cure. After 10 years, he said she's definitely cured. And after 13 years, the same cancer came back with a vengeance. And therefore, diabetes can also come back with a vengeance at any time. And this has never, ever been described in my knowledge, at least in the Indian circles and in these conferences. And that's why I think you as diabetologists should know about this. So what is the definition of the ADA? You should be in remission, which means a HbA1c less than 6.5 or fasting glucose less than 126 without any medications for at least 3 months. So 3 months for somebody who took medicines, now the medicines are stopped, tablets, insulin, everything stopped. 3 months later, A1C is less than 6.5. They call it as remission. The direct trial, the diadem trial, they actually say it should be 1 year. So these are just random arbitrary definitions which are put. The longer the remission, the better, because after 3 months, it may come back again. But the ADA definition is the simplest. Now, how can you achieve this? There are 2 routes to achieve it, and proponents of both will swear by it. There are people who swear by the low carbohydrate diet, and quite rightly, because in our country, we eat very high carbohydrate. 45% or more is defined as high carbohydrate diet. In India, we take more like 60, 70, 75%, sometimes even 80% carbohydrate. So very, very high carbohydrate. And that's one of the reasons we have shown in recent trials, longitudinal 15-year follow-up studies, that just polished white rice itself is one of the strong drivers of the diabetes epidemic, apart from lack of physical activity and so on. Moderate carbohydrate is less, and when you come down to very low carbohydrate, it's less than 10% or only 20 to 50 grams per day. So those are proponents of this LCD diet or low carbohydrate diet say, give them virtually no carbs, less than 20 to 50 grams per day. Okay. Now, what this will mean is that there are only 3 components of a diet: protein, carbohydrate, and fat. Now, the protein has gone, you cannot give more than 20% protein. In fact, people don't even eat 8% or 10% protein. If you double that and make it 20, where is the remaining 80% going to come from? If less than 10% is going to come from carbohydrate, 70 to 80% is going to come from fat. So it becomes a very high fat diet. And in my experience, when you start giving these people very high fat diets, their LDL goes up, their triglyceride goes up, and the entire dyslipidemia starts setting in. And this I've seen very commonly. In fact, I've even seen increase in the coronary calcium if for too long you take such high fat diets. But it's very effective. When you cut the carbohydrate suddenly like that, you will get dramatic reversal. Medicines go, HbA1c goes. It's almost like doing a bariatric surgery. The question with the low carbohydrate diet is how long will it last? And how long can you go for the rest of your life? No dosa, no idli, no puri, no chapati, no bread, no rice, no nothing, no millets, no nothing. For the rest of your life, next 50 years, you're going to do that in India. Show me a few people who have done that. It's extremely difficult. After 3 months, 6 months, they say, I cannot. And just eat fat 3 times a day. Well, it's difficult. Let me tell you, it's difficult. Very few people do that. So while it's effective, it's not very sustainable in the long run. And so is the very low calorie diet, the VLCD. Now, the VLCD calorie diet, the very low calorie diet, you have to take less than 800 calories per day. That's practically starvation. That is what Frederick Allen did before insulin was discovered. Children, he starved them and kept them alive for 6 months more or 1 year more. Now, what we are saying is do the same thing now in the modern day. Stop eating and you will regress. Your diabetes will regress. Of course, it will regress. You will see very quick response. The question is, what happens when you start eating more? The diabetes may come back, at least in a large percentage of people. So while very low, in the very low calorie diet, you don't bother about whether they take carbohydrate or protein or fat. You're only going to give them 800 calories. So whatever they take, they can get only that much of it. So these are the 2 proponents. I have very carefully studied the low calorie diet versus the low carbohydrate diet. There is very little difference between the 2 in the published studies. Both seem to work equally well or equally badly. Now, this is the famous twin cycle hypothesis of Roy Taylor. It looks very complicated, but I'll make it extremely simple for you. If you eat too much and you don't exercise, you'll have a positive calorie balance. That positive calorie balance will result in more liver fat, and therefore you'll get more triglycerides in the liver. So the excess fat gets converted, the excess calories get converted into fat, and it will be stored in the liver. So you get fatty liver. We all know that. If you do an ultrasound, you'll see grade 1 fatty liver, grade 2 fatty liver. The moment you have positive calorie balance, this will occur. Very soon, this will spill over, and then you'll get the fat in the pancreas also. So once you have fat in the pancreas, the insulin secretion gets affected. Once you have fat in the liver, insulin sensitivity gets affected. So the insulin resistance sets in. So you have both the defects of type 2 diabetes. One, insulin secretion, the other is insulin resistance. Both get amplified when you eat too much or you don't exercise. So the opposite of that is, if you cut down on the calories or you cut down on the carbohydrate, when you cut down the carbohydrate so much, automatically the calories will go down. So when you cut down on the carbohydrate, the liver fat will go, the pancreas fat will go, the insulin sensitivity will improve, the insulin secretion will improve, and therefore your diabetes goes away. It's not a big magic, it can happen. Now, can diabetes actually be reversed by very low calorie diet? There are a lot of studies which have shown that within 7 days, 1 week of a substantial negative calorie balance, somebody is taking 2000 calories, now bring it to 700 calories, okay, or 800 calories. Such a dramatic reduction will lead to a dramatic fall in the liver fat. The liver fat will just go down. Your hepatic insulin sensitivity will improve. And then after 8 weeks, after 2 months, this occurs in 1 week. After 2 months, the pancreatic fat will also go. Here is evidence for that. The very low calorie diet showing you decrease in the fasting glucose, hepatic glucose production going up, hepatic fat going down dramatically within 8 weeks. And you can see that if you measure the fat in the both in diabetic patients and in non-diabetic patients, if you can see that the fat going down. In this case, it was after surgery, but even after any weight loss, you can see the fat going down. And here you can see after 8 weeks, what happens is, now the pancreatic fat has gone down, as I told you. Once the pancreatic fat goes down, you can see the insulin secretion going up. So the insulin, the glucotoxicity has gone, the lipotoxicity has gone, and therefore the pancreas is able to secrete more insulin. Now, did you know that type 2 diabetes is caused by less than 1 gram in the pancreas, 1 gram of fat in the pancreas? We heard a lot about adiposity from Dr. Yajnik, and this is only actually supporting what he said, that 1 gram of fat in the pancreas is enough to produce diabetes. But we have to get rid of that 1 gram of fat. You have to lose about 15 kilos in weight, about 32 pounds you have to lose if that 1 gram of fat has to go, if your reversal has to occur. That was shown actually by the DIRECT trial. DIRECT is called as Direct Remission Clinical Trial, done by Roy Taylor and colleagues. This is the largest study. Most of the other studies I'm not showing you had 8 people, 10 people, 11 people. But the DIRECT trial had almost 300 people. This is the largest trial. And what they did was took people and divide them into a control group and intervention group. In the intervention group, practically starvation diet, they put them on an 800 calorie diet for 3 to 5 months. And then what they saw was how many of them lost weight, how many of them achieved remission. Control group, of course, they did not reduce the calories that much. What happened? What are the results? The results showed that after giving 800 calorie diet, starvation diet, for 3 to 5 months, 46% of the participants in intervention group achieved remission. That means less than half. 54% failed, that you don't really hear when you read the DIRECT trial. After putting them on a starvation diet, 54% of people refused to get into remission. They could not get remission. And note that 4% in the control group also achieved. So the difference is about 42%. But the point of interest is here. You really have to lose a lot of weight. Now look at those who lost less than 5 kilos in weight. Now what is shown here is at the end of 1 year and at the end of 2 years, how many people had remission. Now if you see those who lost less than 5 kilograms, virtually no remission. If you go to 5 to 10 kilos, little bit more remission. 10 to 15 kilos in weight, it increases further. And then if you go to more than 15 kilos in weight, that means 15, 20, 25 kilos, if you lose in weight, then 86% achieved remission. Even then 14% could not go into remission. After losing 15, 20 kilos, after being on starvation diet for 3 to 5 months, 14% still did not go into remission. So you can see how difficult it is in a clinical trial situation where people are, where they are looking at you, talking to you, goading you to go on to this trial, and coaxing you and so on, even then there are people who failed to get into remission. And the same people who had the remission, 86%, 16% went off, relapse occurred within one more year. Okay, there's only 1 year and there's a second year. So by that time, it's already come down to 70%. To follow them further, I suspect it will come down further. So is it totally sustainable in those who achieved remission? Difficult. But if you say, will it occur in some people? Yes, some people will definitely have remission. But in others, it is difficult even after weight loss. The reason I'm telling you this is because remission and relapse, remission and reversal of diabetes is considered so easy now. Social media is talking about it. Oh, freedom from diabetes, this one, that one. They keep talking all this. It is not easy to achieve this, and even more difficult to sustain it. Okay, so the conclusion of the direct study was that about half of people who are overweight and had less than 6 years duration, look at the people who are entered into the trial, those who failed also, but those who had less duration, they didn't include people who had 15 years duration, 20 years duration, then the results would have been much less impressive. Okay, those had less than 6 years duration and who had lost 10 kg in weight, at least, about half of them had achieved. The other half failed even in that. Okay, and of course, some recovery of beta cell was shown, which is good. Now, who does a reversal work for? I have made this into an A, B, C, D, E mantra so that you understand this very easily. A stands for A1C. If the A1C is not very high, we want it to be 6.5 and below. If it is 7.5, it is 8, it's 8.5, you'll probably get reversal. If somebody with 16 A1C, can they get reversal? Unlikely, because they probably have severe insulin deficiency. And how are you going to just make them lose another 15 kilos in weight when they're already thin? So that brings me to B. B is body weight or BMI. If your BMI is high, if your BMI is 35, 40, 32, 38, something like that, you've got a lot of weight to lose. Your actual weight should be 60, but you're 102 kilos. You've got a lot of weight to lose, 40 kilos. Even if you lose 15 kilos, you may achieve remission. But you should be 60 kilos, but you're 55 kilos, you're a thin Indian. Then what do? How much weight do you lose? How can you lose weight? That's what somebody asked me even yesterday. Somebody asked me, if I have to lose 15 kilos, my weight is already 50, I am diabetic. How will I come down to 35 kilos? No, you can't, sir. You can't reverse diabetes in your case. It's very difficult. That's a painful truth which you have to understand. C is C-peptide or insulin secretion. It has to be good. If your beta cells are all burnt out, completely gone, how can you get reversal? You know, just by losing 1 gram of fat in the pancreas, if all the beta cells are dead and gone, you cannot get them all back because 1 gram of fat went away. It's not possible. But in the early stages, when you have only 4 or 5 years duration, when your C-peptide is still good, yes, the chance of, so that is the C part. D is duration of diabetes, shorter duration of diabetes. As I mentioned, in my cases of bariatric surgery, only after 8.5 years, up to 8.5 years, reversal was possible. Those who had 10, 15 years duration, they could not. Some of them went off insulin, but they could not go off tablets. They could not get reversal. They could not get 5.6 HbA1c and so on. It was not possible. Okay, so shorter the duration, the better. And the last is E is enthusiasm. If you want somebody to starve for 6 months, 8 months, 1 year, 2 years, 5 years, he better be terribly motivated and enthusiastic. Most people will give up after 2-3 months. And that's a problem with human nature. To continue a diet and to continue an exercise program forever is not something which works. Right from Adam and Eve's time, we have known how difficult it is for humans to follow rules which are told to them. But this A, B, C, D, E will roughly tell us who are the people, because we should identify these people who come to us and say, you are only, having 5 years duration, you have a lot of weight to lose, your C-peptide is quite good, and you're a highly motivated, enthusiastic person, your HbA1c is only 8.5, why not we try for remission? So you must start talking to your patients, okay? So note that as we stand today, effectiveness beyond 2 years is limited. We don't have the evidence. More data is needed in ethnically diverse population. We don't have many studies from India. And most importantly, re-reversal of diabetes, the term which I coined, re-reversal of diabetes. You can also call it as a relapse, which is a term used in cancer. Re-reversal of diabetes occurs in a large percentage of people. And I see this day in and day out of people who go for these reversal programs, come back to me with very high sugars. And I'm just going to show you one case, illustrative case. Okay, this is a 35-year-old person who came to me, Mr. C, and he had 6 years duration. So ideal for reversal. He was treated with tablets and insulin. He had a low calorie and a low carbohydrate diet was given. He lost a lot of weight and was very happy that he achieved reversal of diabetes. You know, when these people achieve this reversal, they go overboard. They really go on social media, they give videos, and that will attract another 50 people into that. Then they will give and they will attract another 50 people. That's how this business is kept up, because more and more of the people are attracted by one video shown by somebody. So he was able to stop all tablets and attain remission of diabetes. We are also very happy for him. Okay, now that's his weight. He lost, and he lost it gradually, not over a sudden period of time, almost 2.5 years it took for him, from 123 kilograms in weight, 118, 116, 102, 99. So 24 kilos he lost in weight. So when he lost that 24 kilos, you can see he's still overweight. He's still obese. He's 99, but he's lost 24 kilos. He achieved reversal of diabetes. How did he achieve reversal? That's his HbA1c. From 8.4, 7.7, 7.7, dropped to 5.6, 5.4. He stopped all medications. Everything was stopped. No insulin, no tablets, nothing. HbA1c is 5.4. Clear case of reversal of diabetes. No doubt about it at all, or remission, okay, by any definition. Look at his fasting blood sugar. 132 came down to 89. Postprandial 293 came down to 110. So 89 and 110 without medication is a normal sugar, absolutely normal sugar. Look at the liver function test. When he first came, he had fatty liver, and his SGOT and SGPT were 69 and 94. Now it's come down to 20 and 16, completely normal liver function test. We did the ultrasound, fat is gone. You know, the fat is completely gone. So fatty liver is also reversible by weight loss. Now what happened to him? He stopped all his medication and he forgot about his diabetes. We called him. What happened? Come back. He said, why should I come and see you? I'm cured. I don't have to see you. And when I'm cured, why are you guys disturbing me? I don't have to come back. He said, no, you still come back. We'll make sure that you still continue to be cured. Please come back. He never came back. 9 months later, he sheepishly came back to us. He said, what happened? No, I couldn't sustain that diet and all that. You know, how can I be in starvation all the time? So I started eating. My sugars were completely normal. I started eating. I'm cured. No, once I'm cured, why should I bother? I'm doing this only to get cured. I'm doing this only that I can eat everything. That is why I'm doing it in the first place. What happened to him? His weight went up from 99 to 112. Okay, over a 9-month period. Now, this is only 13 kg weight gain. He had lost 24. So he's still down by about 11 kilos. He is still down. Okay. Remember that when I show you the next thing. He has not gained too much. He has not gone to 140 kilos. He's only gained this because he came back. If he had stayed some more, he would have reached 140 kilos. Before he came back, he would reach 140 kilos. It would have been much worse. Luckily, 9 months later, wisdom dawned on him. Let's go and see what's happening. He felt a little unwell. That's why he came. Look at his HbA1c. His worst HbA1c is only 8.6. Now it's 8.4. Now it's 9.6. He has never had that HbA1c in his life. So that's why I said when it comes back with a vengeance. Just like cancer relapses, metastasis, when it occurs, it doesn't occur with one cancer cell went into the liver. No, it metastasizes like a bomb exploding in the body. That's exactly happens when you have a release phenomenon like this. And HbA1c went from 5 to 9.6. That means almost 4.2% increase in A1C over this period. Okay, and that means he's been climbing, and only here he came back. Otherwise, he would have gone to 12 or 14 when he came back. Luckily, he came back here. Look at his fasting blood sugar. 130 was his highest. Now his fasting is 247, almost like his PP sugar earlier. And his postprandial from 110 went to 321. That's his highest ever. He has never reached those levels. He never had such sugars in his life. And here is a man who has gone into remission. We thought his beta cells have all recovered and so on. And this is what happens to them. Now look at his liver function. His SGPT was 94 at the worst, came down to 20. Now it's gone to 152. He had grade 3 fatty liver. All the fat reaccumulated in the liver. When you look at ultrasound, completely no fat. Now all the fat has come back. And in how many months? 9 months time. Okay, that's how fast things can happen. And the SGOT went from 16 to 66, which is again higher than his highest. So his liver function is also the worst. Weight is the worst. And the HbA1c is the worst. And this is what we call as reversal of diabetes. You can call it as relapse of diabetes if you like. If you ask me, is it the only case you've seen? I've seen hundreds of such cases. So I thought at least one I should share. I'm now collecting all this. I'll publish it as a report, but I've seen hundreds of such cases coming. I've never seen this discussed in meetings where people talk about it. I think we should know, we should talk, and we should tell our patients about it. So I'm going to conclude here by saying, on the positive side, conversations with people with type 2 diabetes, which is a targeted population, should include remission. You cannot go and tell somebody who is 40 kilos in weight or 50 kilos in weight after 20 years duration, taking 80 units of insulin, I'll reverse your diabetes. Don't be practical about it. Take the young people, long duration, short duration diabetes, and with good C-peptide. These are people whom you should talk. Are you ready? We'll work with you. We'll help you to lose weight. The dietary approach is less important, which you take. Low calorie diet is okay, low carbohydrate diet is okay. These people will swear by it. I know people will say, just stop milk, diabetes will be cured. Try it. Stop milk and see how that goes. Okay. There are different people who will talk all kinds of nonsense, and they just believe in it so much that they'll keep convincing people. Nothing, no single item will work. Ultimately, it is calories. Programs supporting people is very important because you have to be in touch with them all the time and keep on motivating them, like in a clinical trial. Only then they will do it. Otherwise, they'll give up. After 1 month, after 3 weeks, they will give it up. It should be structured, continued, regular support, involving the dietitians for long term. We won't have time to keep on ringing him every single day, finding out what did you eat today, what did you walk today, we won't have time. We need a team to do it, and they can do it. But in many cases, re-reversal of diabetes occurs, but this is hardly emphasized. And I think it's very important that we start emphasizing this in our discussions. I'll stop there. And if there are any questions, I'm happy.
Thanks, Dr. Vimon, sir. I think it was made very clear by your talk that calorie intake made less, carbohydrate, or maybe the total calorie can reverse it. I think it is a very good idea in, selected people who are, you have to choose them judiciously so that it can work better. I can't see anything in the chat box, but I have a question, sir. Is it worthwhile doing all this exercise in all the patients, or just like it is more of an extensive lifestyle modification, losing weight? If you work on those patients on an extensive lifestyle modification and tell them to control diabetes, it is as good as remission, or you're not going to land up into any complications, rather than giving them hope of a remission and then they relapse or resurface after maybe 1 year, and like this patient which you demonstrated came back with a vengeance, and then he had again had to go maybe on a insulin later on.
He went back on insulin. Actually, it was very symptomatic. So yeah, you're very right, Dr. Gupta, and this is what I've been emphasizing. See, all these years, the reason I'm reacting like this and in passion I'm talking about it, because even patients are telling me, see, they're brainwashed so much by these guys who are not even doctors. Some software engineer gets a lot of money, and then private equity money, and then he's trying to make convert all these people. So they then blame us. Why you are not talking about remission? Why you are not talking about this? I said, see, it's difficult. I only give you something which is sustainable. And we know the people whom we work on it, we do tell them. But every Tom, Dick and Harry who comes to me with long duration after burning out all the beta cell C-peptide showing 0, I cannot be talking to you about remission about diabetes. It is not practical. What I can try to do is, can I help you to live a long and healthy life despite diabetes? In several publications, they have shown 40-year survival, 50-year survival. People are doing well. Some of my patients have crossed 90 years. I've shown people have crossed 100 years. At least 3-4 of my patients have completed 100, 101 years. They finished 60 years, 65 years, no complications. They're doing extremely well. Is that more important, or trying to get for 3 months something and then show we did this and all that more important? So I'm not saying you shouldn't do that, but don't lose track of your ultimate goal. What is your ultimate goal? That at the end of 40, 50 years, I should be fine. I shouldn't have. And the other thing that they keep saying is, many of these people, particularly from alternative systems, oh, you take these tablets, you will get metformin will produce cancer. Metformin will produce this. Sulfonylurea will produce that. Insulin will produce cancer. Insulin will produce kidney damage. Metformin will produce kidney damage. They keep on, where is the kidney damage? I have not seen. 50 years I've been following up these people. I have electronic records for 40, 50 years. Nothing has happened to them. They're all doing well. So I think that's another myth and another thing which is being created. All these are hypes being created, which I think at some point somebody has to respond to that. Just keeping quiet and doing that is not right. We should do what is right, teach people the right things, and the truth has to be told to people. So I thought I should do that in conferences and talk about this, because and this is with evidence. We have our own electronic record. We've got our data. We're not talking from the top of our head. And if you carefully analyze the data of published data, there are a lot of holes in that as well. And most important thing is the sustainability. Is it sustainable? How long are you going to go on a smoothie, on all your vegetable smoothie for the rest of your life? You're going to take the next 40 years, you'll live on a smoothie. Tell me who has done that. Only some paranoid person will do that. Other person will not do it. You mean to say all the other diabetics were following a reasonable, healthy diet, eating some vegetables, eating some fruit, some small amount of rice or something, and taking protein. What you have to tell them is to eat a healthy, balanced diet. Cutting out carbs and making it zero is not a balanced diet. Cutting out complete fat, the other extreme will be complete fat, zero fat. That is also not healthy. There's a lot of healthy fats, a lot of healthy carbs and protein, which is missing in our population. Let's give that. That is what milk. Milk is a villain now. Okay, milk will produce milk. All these years we have survived 33 million people. Just 2 days ago, the government said that 33 million children are malnourished. If you take away milk from them, if you take away egg from them, they will get 80 million malnourished children. So I don't think things which have survived in literature or survived in history for 10,000 years or more, now suddenly milk becoming bad. How did milk become bad suddenly now? So I don't think we should be rational in our approach, I felt.
Absolutely right, sir. I take away 2 points from here, that there are certain things which are more experimental. We can't just practice those experiments into daily life, because it is altogether different when we actually practice and when we actually go into the clinics. And I think we need to counsel the patient and educate them regarding the newer therapies, lifestyle modification, exercise, and tell them what they need to look at after 40 years down the line, rather than just looking at a short-term goal or maybe some myths or taboos which have come into their mind from the social media or from listening from the other, talks and the other people. Right.
And one other point I wanted to say is, if there is a case who's obese and simply taking a lot of medicines, can we tell that person, try an intensive lifestyle, at least for some time, get into remission, at least you'll know how it feels to be normal instead of keeping on taking. So there may be a select group of people whom we should also start. The other thing that we should do is, I think we are also partly to blame. The allopathic doctors are also partly to blame. What we do is we don't spend enough time with our patients. When they come, we are in a hurry to add one more tablet, third tablet, fourth tablet, fifth tablet, sixth tablet. Instead of saying, why are you sleeping well? Are you drinking enough water? Are you doing exercise? Are you taking too much of carbs? Are you taking too much of calories? Can we cut it down? Can we listen to what you're eating? Can I help you with that? That part of it, we don't have time and we don't spend enough time, So what happens? We'll add one more tablet, one more tablet, one more tablet. This is a wake-up call even for us. Can we spend a little bit more time with our patients? And can we also bring in that holistic approach, which others are taught? Sleep well, eat on time, do some yoga, do some pranayama, do some walk. Don't eat too much of carbohydrate, cut it down a little bit. All that is good, absolutely good. If we just follow that little bit more, we'll be better doctors and we'll get better results.
Absolutely right, sir. I think because it is a team approach, we don't have that much of time to spend with the patient. So we need to have more people supporting us, the dietitian, the counselor, and other support staff, which guides patient with the non-pharmacological methodology, which is more important or equally important what we are doing with pharmacology. We are more interested in putting them into SGLT2, the insulins and the newer molecules, and trying them, and with the trials and other things, we're trying to prove ourselves, bringing down the levels down. And just
nothing wrong in that, but the thing is that you should also not forget the lifestyle part of it. Essentially, type 2 diabetes is a lifestyle. In insulin, I don't mind. Type 1, insulin. But type 2 diabetes, there is a large lifestyle component. Let us not forget that in our over enthusiasm to use all the drugs. If the drugs are needed, please use it. But ask yourself, is it really needed? Ask the patient, is it really needed? That is the only point I was trying to make. I think Dr. Yajnik might want some questions.
Yeah, Dr. Yajnik, that absolutely well discussed. The anti-prenatal obesity leading on to a thin individual still having a high fat content, and then having a diabetes and a other adiposity issue later in the life, which were untouched, and which is a very new topic and unheard, and the research which we have done is commendable. I think the genetic factors play a lot of role in those individuals who are thin and probably still have a preponderance to type 2 diabetes or the other metabolic syndrome later in the life, not only related to the the teratogenesis because of the nutrition or the fuel teratogenesis. I think the genetics also plays a role, sir.
Can I ask a question to Ranjan? We can combine both on that. This epigenetics is absolutely fascinating. Is the epigenetic methylation and so on, after it's occurred, is that reversible later?
Yes. Yeah, I mean, my usual talk on programming has this resounding message that for last 35 years, I have been trying to find out a reversible susceptibility factor. And that seems to be epigenetics in the current jargon. And methylation clearly is reversible, as are miRNAs, as are histone modifications. But the knowledge is just now so preliminary that actually we, again, like many other things, we build a lot of hope. And after a time, we will have an equilibrium in the system and we will understand what can be done and what cannot be done. And that is why I am excited is our PRIYA trial, which is Pune Rural Intervention in young adolescents. And I showed one transcriptome slide there, which is done in collaboration with Sanjeev Galande and his team. And I think for the first time, we have shown that B12 with multi-micronutrient supplementation has altered the cell cycle dynamics. That's, I think, a very exciting thing. And cell cycle dynamics is such a central biological phenomenon during development, differentiation, and growth that I think we have hit upon something very basic.
Wonderful.
Same thing is going to apply to beta cell development. Same thing is going to apply to the fat development. And therefore, I think we have found something quite interesting. Giriraj Chandak and his student did the methylations. We already published before how a B12 intervention trial changed the methylations, especially in the miRNA 21 gene, and other things which we have done. The most interesting thing there was that the methylation of genes which are associated with diabetes, namely TCF7, FTO, KCN, did happen with B12. Now that may be an entirely non-specific response of the genome to the increased levels of methylation mechanisms available. Whether that has any long-term effect, only time will tell. What I am excited is that we are now able to show mechanisms which appear to be relevant in the methylation, in the transcriptome, placental transporters in our PRIYA trial again, and in gestational diabetes studies. Specific changes in GLUT1 in the placenta. Specific changes in CD320, which is a B12 transporter after B12 transportation. It brings in a whole lot of basic mechanisms to think about, and that primordial prevention which we have been talking about. Your thing was at NGT, my thing is about NGT in the mother. And therefore it's intergenerational, because the best window for epigenetic reprogramming is within 48 to 72 hours of conception, which happens without anyone's knowledge. And that is why it was important to do a preconceptional trial. And PRIYA was the first preconceptional trial in adolescents anywhere in the world with an idea to look at the effects in the offspring. And because of COVID, we have not been able to follow all the offspring. We followed up first 86 out of 160 which were born. And what we have shown is now out for publication in journal is that neurocognitive performance improved between 2 to 3 years of age by just giving 2 micrograms of B12 a day to the adolescent girls. Now, this is a huge gain on human capital. We are giving iron and folic acid for last so many years. There are various reasons why it is working or not working. One of the reasons is we are missing out in the methyl donors, and we are now showing for the first time an effect on neurocognitive development, on the transcriptome in the cord blood, and we will talk about adiposity and glucose intolerance when they grow up to the age of 6 years, when we plan to do the first cardiometabolic risk study. So I am quite excited about what we have got.
Wonderful.
And therefore, I think, again, it is never too early, never too late. Whether you want to do primordial prevention or in your clinic, you want to do a tertiary prevention, avoid premature death or avoid loss of vision or avoid permanent dialysis, or do you want to reduce the risk factors in the whole population so that the population health, dynamics, and human capital improves? And that's a basic divide. And I have therefore openly challenged these people to say, we need to shift from the clinic to the community. And as doctors, you need your clinics to be full. That's what a definition of doctor is. And we need public health people who would think a little bit beyond that. And it's coming out, I think, in Indian Express in 2 days' time. Because people are now saying that screening of diabetes should be reduced from 30 to 25 years. Great statement. What about 25 years? And the paper which is in Diabetes Care just now, it will be in the printed version of December. We show that pre-diabetes in the village 18-year-olds at an average BMI of 19, 30% were pre-diabetic. And that glucose, higher glucose at 18 years is predicted by glucose at 12 years and is predicted by glucose at 6 years. We have 2 more cohorts where we replicated this. First time we have shown now a tracking of glucose from as early as we measured it into the next generation. And their mothers had normal glucose by the criteria which we had in 1993 to 96. But by today's criteria, they seem to be higher for fasting glucose by IAD-PHG because they were more than 92. So it's an intricately epigenetic programming on background of course, genetics, because everything is genetic. But it's the way the genes learn to respond to the environment which determines the phenotype. And I think when people say genetic, what they don't realize is large part of it is actually epigenetic. It's not the sequence of bases, it's the superimposition of chemical structures on the bases which determines how they behave. So a lot of things are happening.
Thanks, Dr. Yajnik, for such a great insight. Dr. Sarita, please. Dr. Sarita.
Yes, sir. Just now, I am just imagining myself just as if I am looking the Vamana avatar out of Dasavatara, putting one step inside mother's womb, one step Dr. Mohan's remission of diabetes, and one step current topic like just management
My
of diabetes.
goodness, yeah, okay.
So,
that's
really
great. You should draw a cartoon of that. I think that's a great idea, Vaman Avatar. Perfect. I'll get my daughter-in-law to do a cartoon for me. She has done about machine learning and animal intelligence, that is MI and AI, which is my snub for all my colleagues who want to do MI and AI in everything. But it's the Ganesh who is actually now hanging in the air after the mouse decided that he was going to learn about laptop, and he hangs the Ganesh at the top. And COVID is a fantastic example of what can happen in a society where you are basing everything on machine learning and animal and artificial intelligence, and then animal intelligence come into play. So new concepts like one health, one world, etc. are now going to come into diabetes also. And there are so many things which actually give us an indication that diabetes is more than what we think about beta cell and the insulin resistance. So great session. I think you got two passionate people who want to talk always.
Yes, sir.
And make you listen. So I think we both actually did very well.
Thanks, Dr. Yajnik. Thanks, Dr. Mohan. I think I thank the organizers, especially Dr. Bansi Sahu. If there are no more questions, Dr. Sarita, we close the session.
Yeah, we can close the session.
Thank Dr. Mohan. Thank Dr. Yajnik once again.
Thank you, sir.
Thanks for
Thank you.
It was really a nice session and nice interaction. Thank you.
Right.
Thanks, sir.
Good night.
Over to the organizers. They can take it for the next session.